I'm starting the session, sir. Good morning, everyone. I welcome you all to the ICRA fetal session. I request Dr. Amit sir to start the session. Over to you, sir.
Thank you, God. Good morning, all. We are starting this Sunday program on education series in fetal radiology. I will start this session by welcoming ICRA Chairman Anbra Vasu sir, Dr. Sikandar sir, Coordinator Dr. Rijo Mathew sir, Dr. Sumati Natarajan Madam, Moderator of this session Dr. Mohit Shah sir, and all the esteemed speakers. We will be starting with basic in fetal radiology, turf expansion session today. Now, without wasting much time, I will hand over to Dr. Anbarasu sir for his comments on this.
Thank you, Amit, our Secretary of ICRA. Welcome you all. And first of all, let me thank Dr. Sikandar, our Vice Chairman, for coordinating this event, and Dr. Rijo Mathew for putting together this fantastic program in fetal radiology. And of course, Dr. Sumati, who has joined him as a co-coordinator for this year, and Dr. Mohit Shah for going to be there for whole day moderating the whole session. It's really nice to see him today. And we have some great seniors, Dr. Nitin Chaubal, Dr. Jyoti Chaubal, and Professor T.L. and Praveen, in addition to our good friends, Dr. Alpana Joshi, Dr. Hemangini Gupta are going to be here. And thank you, Dr. Shruti, Dr. Sonia, Dr. Ruchita, Ramamurthy. Again, they are all big names in their own fields, and they're doing a fantastic jobs in teaching education as well as quality work in their own areas and cities. And really, really fantastic that this is an important aspect of teaching and education for radiologists. You know, we are at a very, very crux time of fetal radiology in India, because this is something where we are actually, getting back our profession back in such a way that our advancements and knowledge in radiology, especially in ultrasound and fetal imaging, is going to be the important factor in deciding that particular stasis and being ahead of times. And it's important that we all learn a lot from these esteemed faculties. And thank you very much for being with us here. ICRA has done tremendous strides in the last 2 to 3 years, and we have been forefront of teaching, for that matter, any of the major rich and poor countries' medical associations have not been able to achieve what we have done it, and for which there has been a record appreciations given by not only the London Book of Records, but also by various societies, including European societies and Royal College of Radiologists, British Institute of Radiology, Korean Radiology, and they all appreciated our efforts of academic wing of IRIA for making this a successful project. And being part of this is a great achievement and honor itself. And thank you very much for being with us today, and best wishes to every one of you. And I will now hand it over to Dr. Sikandar, Vice Chairman, please.
Thank you, sir, and good morning, everyone, for this esteemed Sunday. And we know that fetal radiology, our motto is like turf expansion. So we have very young, dynamic faculties as well as experienced masters in their subspecialty of fetal radiology. So as this program is designed by none other than our dynamic Dr. Rijo Mathew. So we are honored and we are privileged, because despite of his busy schedule, and today he's in Hyderabad, in my city, for a preventive radiology session, which is starting very shortly. So thanks to Rijo for putting all this together and designing along with all the faculties who are contributing today. And my only request is that since fetal radiology is something which we feel that it is not being given much undue importance as other things are subspecialties. So don't think like that. We have excellent stuff, and it is in fact a bread and butter of most of our majority of radiologists. So without taking much time, I welcome all the esteemed faculties, and I hand over back to Amit.
Thank you, Sikandar sir and Anbarasu sir. Now, I think Dr. Rijo Mathew will start the session with introducing moderator and everybody.
Thank you, Dr. Amit. Thank you, ICRA Chairman, Dr. N. Parashu, and ICRA Vice Chairman, Dr. Sikandar Sheikh. As Sikandar rightly said, today we have it's a lot of activities happening in subduction in Bhuj and preventive radiology in Hyderabad, and there is ICRA fetal radiology turf expansion session here. It's happening here. A lot of activities, and it's time for radiologists to explore further in fetal radiology, because the future is of integrated diagnostics and combined screening, especially in all the subspecialties and especially in the pregnancy and childbirth care with the pathomics, genomics, and radiomics that will play a very crucial, important role in diagnostics and management. So it is time for us to explore further into the every modality and every aspect of fetal radiology. Right from their residency, we have to train our young radiologists to equip themselves and understand the basic concepts. And that is why ICRA Fetal Radiology Turf Expansion session is focusing on some of the basic concepts and make our residents interested in fetal radiology, fetal imaging, and the fetal medicine, which comprises of all the fetal pathology, fetal genomics, genetics, and the radiology that plays a very, very important role in that. So to ICRA and IRA has really activated the young radiologists, and I can see a lot of change happening at the residency level as well as the medical college level itself. But it's time for us to push further to have examination, include fetal radiology or the ultrasounds as part of the examination curriculum examination 2. Unless that is there, the focus still will not be there. Only after passing out, they realize that there are many things that has to be learned in terms of fetal radiology and fetal medicine when they come out into the practice. So we have today Dr. Mohit Shah, the moderator for this session, a Jeslo Kalmini with me, and a great teacher who has contributed significantly to fetal imaging as well as to MSK. And I am proud to associate with him, and really honored to have him here with me as a moderator. And he has arranged a good topics as well as our masters and past masters to give the talks to the residents, So I'm very happy to hand over the academic session for the next 4 hours to Dr. Mohit Shah, who will take over from here, introduce all the speakers and the topics, and I'm hopeful that this will be a real good interactive session. And welcome all the delegates to send your questions into the chat box, which will be answered by the speakers through the interactive session and also through the chat box. Over to you, Mohit.
Thank you, Rijo, for those kind words. Thank you, Dr. Anbarasu, Dr. Amit, Dr. Sikandar. You guys are doing a great job, and I totally agree, and I echo what all of these luminaries have said, that we need to understand the basics, because unlike other ultrasounds, obstetric ultrasound is ever evolving. So unless you update, you will stagnate, is always believed so. And I always teach in that manner, that you need to evolve continuously. So what we're going to do today is we're going to take you through basics of everything. And believe me, the basics will always be the foundation on which you will build. If you are really interested, you will build your career in fetal radiology. Now, the faculty that I've chosen are excellent in taking you through the basics. Dr. Jyoti Chobal, Dr. Chandralulla, Dr. TLN Praveen, in fact, have been my teachers as well. And I'm sure if you really concentrate and understand, you're going to take out volumes of information from this program today. But be sure that you ask us and understand the basics, because this is, again, as I said, going to be the foundation. And before we understand what fetal radiology is about, it is not just ultrasound. It is an amalgamation of specialties where we have an equal contribution of genetics. And genetics, my dear friends, is difficult to understand unless you have a good teacher. And today we have Dr. Shruti Bajaj. Now, Dr. Shruti Bajaj is an MD Pediatrics who's done a fellowship in clinical genetics, but she has her own Purple Jill clinic, but she has a special interest in pediatric and prenatal genetics, inborn and also metabolism, dysmorphology, skeletal dysplasias, basically all those subjects that I used to leave as an option in my MBBS days. So she's brilliant. And I can assure you, because I've heard her multiple times, she will make you understand genetics like no one can. So Dr. Shruti, over to you.
Thank you so much for those kind words, sir. I hope I can live up to them. At the outset, I would take a minute to thank the organizers, IRIA and ICRI, to give me this opportunity, as well as to take the effort to bring rare disease to the front. Incidentally, February is Rare Disease Awareness Month, and there couldn't have been a platform better than this to sensitize the young and budding radiologist of tomorrow, as well as to interact with the masters of today, so that even we can further our learning. So I'm going to first give a little bit of a prelude as to why even the significance and relevance of today's session, that we often tend to feel that rare diseases are rare and we really don't need to know much about them. But contradictory to this fact, in fact, rare diseases are many. Taken together, the cumulative burden of rare diseases is such that 1 in 10 of us may live with a rare disorder at some point in our lives. I'm going to take you through a quick case to just build up the momentum for the day. So this was a lady, who had polyhydramnios in the antenatal period along with fetal growth restriction. And the rest of the scan was fine, but the treating team felt the need to just run in a microarray test. And well, fair enough, that was normal. I am going to touch upon the basics of what are these test methods. For those who are aware of these tools, maybe it will help to understand what exactly is this case trying to tell us. So with this couple was reassured. However, by 34 weeks, the lady had some fetal hypokinesia, and pregnancy was continued to term. Baby was born at 38 weeks, but had distress, asphyxia, and did not cry at birth. This child had feeding difficulties right since the beginning and was very floppy. And the penny actually dropped when the treating neonatologist felt that this is not just pure asphyxia, called us in. And as a geneticist, when I saw this child and the out of proportion hypotonia, along with the background constellation of polyhydramnios with fetal growth restriction, we did think of Prader-Willi. Prader-Willi is a type of a relatively common genetic condition, and we realized that not all Prader-Willis get picked up by a tool, by microarray. We ordered another specific testing platform called as MLPA, which picked up the condition. So my reason to put up this case is, as Sir rightly said, we are in an age of expanding omics, radiomics, genomics, and multi-omics. And every day there are new test terminologies that are being thrown at us, MLPA, transcriptomics, whole exome, whole genome. And what sense do we make out of it? As a practicing radiologist, what is it that we should be knowing? I've tried to really reflect on these aspects. And in the next 20 minutes, we'll try and look at 3 aspects. When should I suspect? If I have suspected, how should I work up? And why should I be pursuing this all? So I also am a propagator of, being strong in our basics, because often when our basics don't work fine, even our specifics wouldn't work. So with that little bit of prelude, we are going to try and understand what is it in that a fetal medicine specialist should be knowing about genetics. And of course, every time the geneticist cannot be present in every fetal medicine OPD, although that is the scenario in many developed countries. As per 2015 data, India has just 75 trained geneticists, just 13 to 15 centers that actually offer genetic services. So which means that the onus of early suspicion lies on each one of us. We have to know when to suspect. We have to know how to work up. At least the basics need to be done right. Needless to say that at any point when we feel overwhelmed with the situation, you have your genetic colleagues around to touch base with. So in terms of when should I suspect, there is this easy aid memoir, which goes by the name of family genes. So whenever we have a family history of similar presentation, we have a group of congenital anomalies. Of course, this is, I think, the G part is the commonest what a radiologist would be raising the flag for. Exceptional presentation of a relatively common scenario. So say you see unusual amount of fractures which are not explained, say in the fetus or later on in the as the time progresses in the child. That's an example of exceptional presentation, neurodevelopmental delays or regressions, extreme pathology, surprising lab values. So these are the red flags that we should be suspecting, genetics or genetic disorders. Although I would want to give a word of caution over here, although family history is important, if we just rely on family history, we would be missing a fair degree of patients and often causing a recurrence of the same disease in the family, because 80% of the genetic disorders do not have an underlying family history. So only family history, only consanguinity, and then I'm going to think of genetics. Maybe we need to revise this thought process. Having suspected, I am going to take you all in the second half through a lot of case scenarios, but we'll just build on the basics now. How does one work up? What are these various test methodologies? So I'm going to give an example of a simple grammar sentence, and this is a very repetitive slide in most of my talks which deal about the test tools. So if we take a sentence, give me the book, and if I were to delete or duplicate this entire sentence, this is like a macro deletion or a macro duplication. So it's something like what we see in trisomy 21 or Turner, where the entire chromosome has got deleted or duplicated. Whereas if I delete or duplicate a part of the sentence, this is a micro deletion or a micro duplication. Of course, in the last row, I have not deleted or duplicated anything. Rather, I've just changed the K to the T. So this is a spelling change. Now, why is it important that we need to know this well? Because these are different types of errors. These are copy number variants, and these are single nucleotide variants. In genetic jargon, it is CNV and SNV. You'll often hear, or when you're asked, talking about the different test methodologies, you will see, oh, this test is good at picking up CNVs, this test is good at picking up SNVs. Why is it important? Because different tests are designed for different types of errors. Of course, this is an oversimplification. Borders do blur. Tools which are designed to pick up SNV will pick up CNV and vice versa. But we need to build on our basics first. So for the CNVs, of course, we have karyotype, FISH, MLPAs, microarrays. And for the single nucleotide variants, you have the next generation sequencing. So if I was to draw a parallel, if I have a library filled with books and I just want to know whether my textbook of radiology is there or not, I just need to eyeball the library. This is like a macroscopic question. So it's like the karyotype. But if I want to know, is a particular book having a torn page or a duplicated page, just eyeballing will not help. So I need to dig deeper. And that's when a micro deletion duplication test like a microarray helps. And of course, if I want to do a spell check, microarray will not help. I need a spell checker. That is where a next generation sequencing helps. I would keep on telling repeating the disclaimer, this is an oversimplification, but this is a good starter for us to understand these various test methodologies. So there are different types of genetic errors, and corroborating to that, there are different types of genetic tests. Okay, so once we get this, we go on to the next segment of understanding microarrays. My personal experience is that microarray is very popular amongst fetal medicine specialists and radiologists, and it should be. But I feel there is an over-reliance. And often the sentiment is that for everything that we see in the fetus, microarray is the end-all, do-all. That's not the case. Like in a lot of things with radiology, there are many a times where microarray will be inadequate, insufficient, sometimes even harmful. I'm going to take you through case scenarios about the same. Microarray in very simple terminologies is like the elder brother of karyotype, much smarter, more resolution, doesn't require living cells to be cultured. So it is a test of choice for products of conceptors. It is a test of choice of fetus with multiple anomalies without an apparent etiology. It is a test of choice when you have a stillbirth, IUFT, again, where you cannot have an explanation. Essentially, microarray just compares the patient DNA to the reference DNA. And if there is a deletion or a duplication, a signal is thrown accordingly. So this is a relatively genome-wide test. But it's important to understand that your error would be shown up only if that corresponding probe is represented on this chip. So it doesn't mean that if a microarray is normal, there cannot be any deletion or duplication at all. So this is what I meant, that microarray is probe dependent. It would not pick up gene level errors. You have understood now. You require a spell check for that. Next generation sequencing is what is usually applied for gene level errors. It will not pick up balanced translocation because it's essentially designed to pick up unbalanced errors. Now, with that background, we go on to the gene level errors. So we have understood microarray. We understand next generation sequencing. In next generation sequencing, you're essentially sequencing the gene, while a decade and a half back, we used to sequence a single gene at a time. And I remember days where we used to send the test, and it used to be our next posting by the time the result used to come back off shores across oceans. And now all it takes is throwing one net, multiple genes sequenced together. I don't know whether life has become simpler or more complicated after that. We will reflect on that question in the next 15-20 minutes. But we have next generation sequencing at our disposal, which has surely revolutionized clinical medicine, because now it's like a high throughput technology, checking multiple genes of interest at the same time. Within NGS, that is next generation sequencing, this is just to understand the differencing, and I think we can skip this slide. It's to understand that in next generation sequencing, essentially, when we talk of exome sequencing, within next generation sequencing, you have clinical exome, whole exome. What do these exome sequencing do? They check the exons or the coding part of the DNA. They will not check the introns. Having said that, it's important to understand that while exons, all the exons in our genome make up for 1% of the DNA, and that is like a high hotspot of mutations. We need to understand that we are now gradually even moving beyond the exomes. So you have a whole genome which will essentially sequence the entire watermelon. I wouldn't say we are there as yet, should be used only with a lot of prudence in the hands of experts. But yes, a slice of the whole genome, which is all the exons put together, this is the whole exome. And when we do a part of this, we are doing gene panels. So this is what I want to give a rough idea. There is karyotype fish, then there is microarray, and then you have your next generation sequencing platforms in the form of clinical exomes, whole exomes, and gene panels. What we need to understand and keep in mind is that when we run these tests, you have different types of results which come out. You could have proper pathogenic results. We could have uncertain results. We could have benign results. What we need to understand that every negative result doesn't mean it's the end of the road. You can explore more, and every positive result is not the holy grail. You really need to be interpreting results with a lot of caution. Before I move on to the case vignettes, one important statement of why this effort, why are we even talking about genetics and genomics in our radiology forum? Well, importantly, 1/4 now of the infant deaths are largely because of congenital malformations and chromosomal abnormalities, having given the fact that we are improving in our neonatal care, improving in infectious diseases. Conquering this segment is very important if we really want to reduce our infant and child mortality. Needless to say, if we have a precise answer, we can give better prenatal counseling, we can prognosticate better. So often we have scenarios where You must all be familiar with benign radiology red flags like echogenic cardiac focus, a solitary choroid plexus cyst. While these may be not so alarming, we know that even a single thing like an occipital encephalocele, although it's a single marker, can be alarming. So prognostication is very important if we really have to understand what do we do to proceed further. Sometimes parents may want to go ahead, give birth, and in such a case, you want to mitigate the complications. And that's again when you need a precise diagnosis. If nothing else scares us, this one medico-legal term always scares us. As per a recent survey, the second commonest cause of litigation was a failure of duty to refer. Today, if as a specialist, we come across a scenario which is beyond our scope of training and learning, we have to refer to another colleague, another specialty where there is someone else who has spent years training in that aspect. So it's really team effort at the end of the day. And that's when genetics and genomics is becoming pretty much a sibling of fetal medicine, and we need to work with each other to give the families better answers. We are in an era of therapeutics and treatable genetic disorders, and it's really criminal to not being able to give timely answers to these families and delaying answers now. And last but not the least, timely genetic test and timely brainstorming can actually save money and time for the families. So with this little bit of background of when, why, and the hows, we now come on to the actual case scenarios where in these examples, you see various test methods being used and each case has its own message to give. So this was a primigravida, and her 19-week scanner showed that the fetus had an absent nasal bone and an aberrant right subclavian artery. Anxious that the parents were, while of course the whole team tried to prognosticate and everything, but they went first and discontinued the pregnancy. And the POC was sent for karyotype in fish, but it returned to be normal. Now, should we be ordering more tests? We can hold on to the thought. I'm sure most of us would think yes, because we understand that when an ARSA is associated, especially if it was isolated, I agree most of the current guideline statements and the thought process is that we can leave it alone at a normal KT for the POC. But if you have especially an aberrant right subclavian artery along with other markers, which is suggestive of a constant syndromic etiology, and you're not clear about what the etiology could be, the test of choice in such scenarios across guidelines is now the chromosomal microarray. And rightly so, we applied that and we did get an answer. The fetus had a 22q112 deletion. And this was important because 7 to 10% of these deletions can be inherited from an asymptomatic parent. And this can be significant in terms of helping them in their future reproductive options. A similar case scenario, this was a fetus that had a constellation of club feet, echogenic cardiac focus, ventriculomegaly. Again, we ran in the microarray. This time, though, if you ask me, there are various platforms of microarray. There is a low resolution, medium resolution, and a high resolution. For practical purposes, the fetal medicine experts would use the low resolution, and I agree it would suffice. But there are certain scenarios where we need to use a medium resolution, especially scenarios like if you have the increased nuchal fold, or scenarios like this where you're having multiple anomalies and you feel that your 315 may miss out on a finer deletion or a duplication. Well, I did the 750K, although in retrospect, even the 315K would have picked up because this was a very large error, showing a trisomy 6 and a monosomy 7 in the same fetus. Another case scenario where this current pregnancy, not really IUFT, it was an early abortion where the mother underwent incision and drainage for a large gluteal abscess, and following the procedure on the same day, there was no fetal heart rate. You can imagine the caregivers and the physicians were all petrified, wondering whether this has got anything to do with the iatrogenic angle to the case. And karyotype failed in this case, and this happens often because karyotype requires living cells. So in fact, 20 to 40% of the POCs could have failures if we order just the karyotype. And this is where the microarray scores, because microarray does not require living cells. I think we should be over this era now of sending POC for karyotype. We have to, as a standard guideline now across, even in India, start ordering POC for microarray. If you look at essentially the cost difference, if you have done this in 10 cases, your microarray will actually be more cost effective in terms of the results that it gives, in terms of the lack of failures that it has. So in this case, also the microarray helped us. It was a low resolution and it showed a trisomy 13. It was a bit strange. Maybe, of course, by the time it would have been 18 weeks, the fetus would have shown some structural anomalies, but this was a case of a trisomy 13. I was telling a few minutes back that we do feel and get a sentiment that there's an over-reliance of microarray in amongst the practicing fetal medicine experts sometimes. And this is one case I'm thankful to my colleague, Dr. Smita Pawar, for this. We had worked together on this case. You can appreciate that this fetus has a grossly malrotated ankle joint. And, this child also had ankle contractures. And she actually called me, that Dr. Shruti, we want to send the microarray. And having worked for some years, I would still say I'm a learner in skeletal dysplasias. But when we look at a fetus with joint dislocations, contractures, we're really thinking a lot about this whole spectrum and phenotype of skeletal dysplasias with joint dislocations. And paradoxically, they can be contractures and dislocations. So, of course, I told that this cannot be done over telephonic consultation, send across the parents. And for us in genetics, it's always family medicine. We cannot and should not just be looking at the fetus and at the scan. And when I looked at the father, he had this little stocky build, normal stature. He said, Doctor, mere bhi elbow contractures tha. Even I had elbow contractures, and my mother said I had some knee contractures. But look here, doctor, I'm all fine. And why are you really sweating about it? And he was, in fact, running a very successful business model, normal intellectually. On looking at his nails, I saw that he had these hypoplastic nails. And really, it was putting two and two together as because it was very evident in the scenario of hypoplastic nails with contractures. We just asked for his X-ray of the pelvic joint. I was thinking of a syndrome called as nail patella syndrome. And lo and behold, he did have the iliac-horn signs. I don't need to explain this to the elite audience whom I'm speaking to. This patient had nail patella syndrome. It was autosomal dominant, inherited, where the father had passed it, and really no one had suspected. And while we may wonder, why are we sweating it out? It's nail patella. Look at the father, he's so successful. Well, that may not be the case, because nail patella, if you talk to pediatricians, talk to intensivists, talk to nephrologists, it can be a cause of really early neonatal death, because it can be associated with congenital nephrotic syndrome at one end. It can be associated with, obviously it's associated with normal intelligence, but there are a whole lot of other complications which can be associated. And we took the parents through this entire spectrum. I told you a few minutes back how prognostication is so important. And mind you, here the microarray would not be useful. In the father, we did the targeted NGS panel, and it did show the de novo pathogenic variant, which nailed the diagnosis of nail patella syndrome. However, in this case, after listening to everything, the family said, we want to go ahead, fair enough. In that case, we did not even opt for amniocentesis. So you understand, it's not every time about poking in the needle and doing in the microarray. We need to understand the diagnosis, the prognosis. In this case, if the family would have just gone, done an amnio, microarray would have come normal, they would be upset on delivery. Because they would have still seen, by the way, this child was born affected, and this child is still following up at 1.5 years. But the family is very happy because they were explained right at the birth, in the antenatal period, what is the diagnosis, what is the prognostication. So, and they did not even undergo an amniocentesis, and they still had the answer before the child was born. So I think this case has many take-homes to register. This was another case where this lady had a large occipital encephalocele, had a fetus with a large occipital encephalocele with cystic kidneys. Of course, although the polydactyly was not there, I'm sure many of us in the audience are thinking about Meckel-Gruber syndrome. This is a syndrome complex. I would want to reassure the budding radiologist in the audience, we do not always need to know difficult syndromes names, or we do not need to by heart complex pathways. We need to think basic. If you think that this is not normal, this is unusual, you need to go back and read. And even if that doesn't suffice, if it is suggestive of a red flag, raise the red flag. So while neural tube defects can be multifactorial, we understand that occipital encephalocele are almost always single gene disorders. And for this, thus, if you go back, a microarray would not be the test of choice. For single gene disorders, you need exome sequencing. So I told you, it has to be a constellation where the etiology is inapparent. And what may be inapparent to one may be apparent to someone else. Here, I wouldn't say the syndrome etiology was inapparent. I was suspecting Meckel-Gruber syndrome. We asked for the exome sequencing in the products of Conceptus, and rightly so. We proved the Meckel-Gruber syndrome. This is an autosomal recessive disease where both the parents were carriers and the fetus was affected. And we understand that there's a 25% chance that this can happen again. Needless to say, now we have the mutation, the family can go ahead and plan their reproductive options with more definite aspects to pursue when they are pregnant. I would want to touch a bit upon variants of uncertain significance. I've often seen this a bit of casualness when we deal, and that's very disturbing and alarming at the same time, because when we talk of uncertain results, they are what they are. They are uncertain. While they could get, and they are going to match the phenotype to some extent, because that's what you fed into the system. So today, if you type in the word Lata on Google, and you get 1 lakh Latas, out of which one is Lata Mangeshkar, we cannot argue that the, whatever other images got, that still could be likely. Your uncertain significance can many a times, in fact, 75% of the VOUSs get downgraded to benign. It's very important, most important for fetal medicine experts to understand that as per the ACMG guidelines, we are not supposed to take prenatal decisions based on uncertain findings. Leave alone the patient damage aside. We could really be sitting hens for litigation later, years later to come. We have seen scenarios, and I'm going to allude to that very soon over here. So these uncertain results could get upgraded, they could get downgraded. But if you are wanting to give a prenatal counseling based on an uncertain scenario, think twice, collaborate, talk, document before you do that. Right? The parents need to understand very well what are they getting into. So this was a case referred by a gynecologist, 12-week fetus aborted because of absent lower limb bones. And I was very thrilled because I was just back from my skeletal dysplasia training from Lausanne. And just on looking at the x-rays where you can see these absent vertebral body ossification with this anarchic ossification pattern, you can see missing bones. I thought in terms of either achondrogenesis or atal osteogenesis, and rightly so. When we collaborated back with the experts, this was me a lot younger, few years back, but they agreed that this fetal X-ray, all from an X-ray of a fetus of the length of a finger, we thought this could be atal osteogenesis, and this is just to stress how important the phenotype is, how important it is to take that fetal X-ray. Please do that when you come across cases of fetal skeletal dysplasias. When we ran in the exome, this was back in 2019, it did show the same disorder that we were suspecting, atal osteogenesis. It is autosomal dominant. It happens de novo. Parents are not carriers. But, we went ahead and proved that too, that the parents are not carriers. However, in 2019, the parents had just gone through a lot of trauma. We really spoke through them at length, telling them that, look here, this looks to be the case. It's matching the phenotype. But there are lots of other differentials. And although de novo makes it very likely to be causative, you need to understand that this could happen. De novo variations are known to occur in me and in you and in a lot of other people. We can be 95% certain that this is the case. Do you really wish to go ahead with prenatal at this point? They said, doctor, let's do one thing. Whenever we are pregnant again or planning again next, we'll get in touch with you. And they came back in 2022 to us. And now when we check the databases, as geneticists, you need to understand we don't just tell order this test or order that test or look at the report over the phone screen and tell whether it's pathogenic or not. We work a lot into databases, correlation, phenotyping. And when we went back, we saw that all the variant criteria were satisfied. And now this uncertain variant was reclassified to pathogenic. So now my recipe is complete. I tell them, look here, I'm all safe. You are safe. Let's go ahead and test the fetus. Although we know that in the next pregnancy, the risk of recurrence is barely 1 to 2%. Why this 1 to 2%, even though the parents are not carrying the mutation? Because, well, there could be scenarios of gonadal mosaicism. So you need to always keep that in mind. Now, when we talk about clinical exome sequencing in the fetus, very often we are asked, why not just do the fetal exome sequencing directly, in such scenarios? Well, if you have a previous proban, a previous history, a previous mutation, you have to go targeted. In case if that scenario is not resolved, and if this fetus is normal, we are not justified in doing the fetal exomes because we would get a whole lot of uncertain findings which we would not be able to really necessarily correlate. So there is, as per latest literature, fetal exome has got a yield of around 32%. Even more so when you do it with trio, that is parental testings. It is more fruitful when there are more than 4 organ systems involved, and the high yield system involvement where fetal exomes can help are those with craniofacial or musculoskeletal involvement. When we deal with the cases of uncertain scenarios, this is just to say there's a lot that goes on in the back end. It's not as simple as, oh, it's matching the phenotype, let's just call it significant and go ahead and counsel the families. And this case will highlight what I'm trying to drive home. This was a couple who visited us. Their children were based in USA, and this couple in USA was pregnant, and their daughter was 23 weeks pregnant. The fetus showed a non-ossified fetal nasal bone. They ran in an NIPT which came screen negative. Back there, they did the microarray which showed a 22q13 duplication. Uncertain significance. 2 genes were duplicated, TCF20 and NFAM. But the literature evidence was very poor. There was some evidence of it being associated with autism, variability in phenotype was explained. And, these were lawyer and doctor couple. I don't know who was more scared, them or us. But we had to really take them through very scientifically, very rationally. We explained to them that, look here, this is an uncertain scenario. You should ideally not be taking any decision on this. I agree, at the end of it, you may have a child who may be mildly affected, but really the evidence is very poor over here. I would suggest do not terminate. They had already ordered the parental microarray. Time was running out of hands. Of course, in genetic counseling, we follow non-directive counseling. This is what I said I would suggest was because I'm addressing a meeting of medical specialists, but to the parents, to the patients, we always say that it's up to you, you'll decide, because you really don't know how an uncertain significance could swing. So the couple was anxious. They terminated the baby, and the parental microarray, which was sent in at the 23rd week, came back, and the mother was carrying the same variant, and she's completely asymptomatic. So the current evidence made this uncertain variant get downgraded. And it was really disheartening, actually, to see the family feel the regret of having aborted likely a normal fetus. Of course, they were told that this seems to be downgraded now, but evidence keeps on mounting. Do seek a reanalysis whenever you are pregnant again, because this isn't a definite, this is as per the current scenario, but data keeps on accumulating. You need to kind of take a call again when you're pregnant the next time. So the reason to put this case was to understand that every time an uncertain result need not be pathogenic or actionable. This is my last case. Again, often the scenario comes to us, why not just do a fetal exome? So this was a lady who was pregnant. I would first want you to see this video. So what you are seeing over here is the clinical sign of myotonia, the inability to relax. I think I've already let the cat out of the bag. So this was a couple who had, the previous child had antenatal polyhydramnios, extreme floppiness, club feet, respiratory distress, and the baby died on day 14 of life without any investigations. And the fetal medicine expert called me telling, see, now she's pregnant. Why not just do a fetal exome? And many a times this happened. I feel I was fortunate to be called. Very often we are not even, the discussion with the geneticist is often an afterthought after the exome results come. Well, this was a spot diagnosis of congenital myotonic dystrophy where the mother had myotonia. And it's only when you evaluate and assess, you take the family tree, that you realize that she had similarly affected members who were given all misdiagnosis of neurophenotypes. She had early female type of balding, endocrinological issues, which was actually a spotter. So ideally, this diagnosis should have even been made in the antenatal period when this child was in the ICU. And an exome will not pick up these disorders. Myotonic dystrophy is a trinucleotide repeat disorder. Microarray, exome, nothing will pick it up. Require a simple test, which is TP-PCR based technology. And we did that in the mother, found the definite mutation. Very simple. Now, when she's pregnant, we just ordered that particular test in the fetus, and the fetus was unaffected. So you need to understand that whole exome sequencing will miss a lot of errors, and it's not the that any one test is the be all and the end all. And it's very heartening for clinicians to note that in the era of artificial intelligence, there is a human component that can never be replaced. The better the phenotypic terms, the better is the diagnostic yield. Next generation genetics and genomics, fortunately, still needs our generation clinicians. I'm going to sum up the talk by saying there is an expanding armamentarium of clinical tools, but clinical skills and phenotype are still and will always remain very, very relevant. Judicious selection of the right tool and subsequent sound interpretation of the test is crucial to reach the right diagnosis. While we go gaga about the strengths of the test, let's not forget that there are limitations, and let's keep in mind the caveats of uncertain results, because I think with great power comes great responsibility. We all need to use these tools, but with a lot of caution and care. We have our center, as Sir said, in Malad, and we do help in remote consultations, physical consultations, and I would be very happy if I could be a part of your patient journeys ever. Thank you so much for your patient listening.
It's important to understand that when we talk of fetal medicine, fetal radiology, genetics, obstetricians all become a part of this super specialty. So understanding genetics is the first step before we move into fetal radiology. And now you have to understand that an NT and an anomaly scans have become pivotal in clinical practice. So thank you, Shruti. That was wonderful. I now hand over this session to Dr. Alpana Joshi. Dr. Alpana Joshi is the director of Shobha Diagnostics, Malad. But more than that, she's been an excellent teacher. She's been a backbone of most of the conferences. And we do work together in conference, and it's a pleasure learning from her. She is responsible for arranging the basic course of fetal radiology for radiologists in Maharashtra, and she's been traveling extensively all over Maharashtra, sort of inspiring radiologists to take up this fascinating branch. And she's going to start with the most basic concepts that we should know in the 11 to 14 week scans. This is important because this has become a daily routine practice now to incorporate 11 to 14-week scan in each and every pregnancy. So over to you, ma'am.
Yeah, thank you, Mohit. And Shruti's lecture was really an excellent and an eye-opener probably for, all of us radiologists. So we will be starting with our talk on 11 to 14 week scan. Probably as radiologists, we, all have, heard about this NT-NB so many times that we, almost all of us are an expert in NT-NB. But what is more important now is the structural analysis. Like 18 to 20 week scan, what we do at 11 to 14 weeks also. And that's why first we will just go through quickly the timing of early anomaly scan, the markers of aneuploidy, and then mainly we will look at the 11 to 14 week structural analysis. So what is the need for early anomaly scan is, of course, the major life-threatening abnormalities are picked up early, or they at least have some sonographic clues to the abnormality. And that's why there is a changing concept of early anomaly scan at 11 to 14 weeks and then a later scan at 18 to 20 weeks. And as we just heard from Dr. Shruti that, there are a lot of genetic tests which are coming up, but which are time consuming. So we have a window period for decision making. Of course, it is, earlier detection is easier termination and it is less traumatic. But for any doubtful findings, there is a window period for decision making. We can again call them back at around 16, 17 weeks. We can do some invasive testing where there is an ample time while waiting for the genetic test results. And of course, what started initially as the NT-NB scan has evolved into a structural defect scan. And of course, screening for preeclampsia, diabetes, preterm delivery, etc. So that is with the help of serum biochemistry. So it has really evolved a lot. The timing for early anomaly scan, of course, we know that even though it can be done between 11 to 14 weeks, there is a lot of difference between doing it at 11 to 12 weeks and 12 weeks to 14 weeks. At 11 to 12 weeks, the structural analysis becomes a little difficult. Of course, the NT can be measured, but structural analysis can be difficult. At 13 to 14 weeks, of course, structural analysis is much better. Bigger the fetus, better it is. But what happens is at around 14 weeks, the fetus is, almost many times vertically oriented and we don't get a very good NT section. We don't really get a very good NB section. So that may be a problem. So the ideal time will be between 12 to 13 weeks, where the fetus is almost 5.5 centimeters in size. The CRL length is around that. So that becomes the best time because structural analysis is good. There is an horizontal position of the fetus. So NT-NB measurement and all the other things are also good. Well, problems is mainly because of the small size of the fetus. I mean, the fetus is so small, imagine it's just 5 centimeters. So uterus is still deep down in the pelvis. So especially when there is a retroverted uterus, there is no place for, maneuvering the fetus there. There is a flat maternal abdomen. The fetus is in the pelvis. So then the maneuverability becomes difficult. And on the top of it, if you have a focal myometrial contraction, then you know that this fetus is not really going to change the position. But then, of course, the increased mobility of the fetus. Sometimes you start doing the NT and you see, oh, this fetus is his prone position, the spine is up. And then, in the next fraction of second, it has completely moved and you get a very good NT section. And a good sagittal section. So increased mobility is asking the mother to cough, walk, eat, and, turning the mother on one side. If the bladder is completely empty and the uterus is deep down in the pelvis or retroverted, maybe you can distend the bladder. Or if the bladder is very much distended and that's why the fetus is not moving, you can empty the bladder and then suddenly you learn over the period of time while scanning. Image optimization is like any other scan. You have to choose the high frequency transducer when possible. Nowadays, a lot of new machines have a convex high frequency transducer, which is a very good option. consider using linear or endovaginal transducer. More than linear, the endovaginal really helps a lot. Sometimes you can use the other hand to gently manipulate the uterus. You can narrow the image sector. That improves the frame rate and it improves the resolution of the image. You can magnify the region of interest. Always focal zoom the area which you are interested in seeing and use only one focal zone. Again, that improves your resolution. So we will just go through important aneuploidy markers because it is, it is beyond the scope of this time limit that we can really discuss all the new aneuploidy markers. So NT, ND, DD, and TR, these are still the kind of main aneuploidy markers, the important ones. The nuchal translucency is a collection of fluid under the skin, only between, we judge the image under these 6 criteria. So how do you go by that? The magnification is judged by only the upper thorax and the head, which is seen, and every slight movement of the caliper produces a 0.1 millimeter change in the measurement. True mid-sagittal section is known by when you see a tip of the nasal bone, a rectangular shape of the palate, non-visualization of these hypomatic process. So that tells you that this is a true mid-sagittal section of the face. Neutral fetal position is when the head is in line with the thorax, with the spine. So if it is, if it is too flexed or if it is completely extended, then you get a false nuchal translucency reading. And there has to be a clear space between the chin and thorax. So that tells you that it is not flexed too much. Caliper placement is inner to inner, and that we all know. You should take the maximum lucency. You cannot take the translucency at this level, or you cannot take it at this level. You have to take it at that maximum lucency, widest part of the lucency. And you should always see a thin nuchal membrane. So the fetus has to jump and come up a little bit. It cannot be resting on that posterior myometrium. So then you don't really tend to see this nuchal membrane. Sometimes it will flatten out if it is, resting onto the posterior uterine wall, and then you're not sure what you're measuring is correct or not. So again, you should take more than one measurement. The maximum one that meets all criteria should be recorded. The umbilical cord around the neck, will falsely increase the NT. So the guidelines will say that, you can take the NT above and below the measurement cord and then take the average. But normally the fetus is moving so much that you don't really have to do that. You really get it without that cord really being there behind. Auto NT is an acceptable kind of measurement now. And again, that general cutoff of 3 millimeter should not be considered. It should be applied cautiously, because if you are measuring the NT at say around 46 millimeter of CRL, then the 95th centile is 2.1 millimeter only. So if you get the measurement of NT 2.4 millimeters, you cannot say that it is less than 3 and it is normal. So giving a percentile is always a good kind of a practice point. The CRL of 84 millimeters, the 95th centile is 2.7 millimeters. So maybe here you can say that the 3 millimeter and above is abnormal, but not at early CRL or say at 11 weeks, 3-4 days. That's why whenever you are writing the NT value, always write the percentile of that. And for that, there are online calculators available on perinatology or on MF site. Then we all know that there are different kind of problems. It is not just Down syndrome, but many non-chromosomal syndromes, cardiac defect, torch infections or other infections and things like that. Nasal bone again is taken between 11 to 13 weeks, 6 days. It is ossified. It starts ossifying when the CRL is 42 millimeter, and then it increases linearly. So what is important is to see the tip, to see the skin, to see the nasal bone. The nasal bone has to be ideally more echogenic than the skin which is there above, or at least the same echogenicity. Now with the good amount of harmonics or noise reduction kind of tools, many a times the skin and the nasal bone appears more or less the same ossification. So more or less the same echogenicity. but you should remember that it should be at least to the same brightness as the skin overlying, and ideally more than the skin overlying. So whenever you get the nasal bone at that angle, this is your ultrasound beam, and if you get it in an angle of 45 degrees, you get the orientation correct and you get the echogenicity of the bone very well. Again, the criteria are the same. You will have to see the mid-sagittal section, the overlying skin, and that is typically called as the equal sign. And this is where you see it as an equal sign, the tip, the skin, and the nasal bone. The ductus venosus, again, you will have to have the between 11 to 13 weeks, 6 days. You should get the mid-sagittal section, which is magnified. Fetus should not be moving, only then you get a crisp spectrum. On color Doppler, area of maximum aliasing or the brightest signal should be seen, and the sample width as small as possible on your machine should be utilized, and the intonation angle should be less than 30. So this is where you will see that maximum aliasing, you reduce your sample width, and then you start taking the spectrum. So this is the normal spectrum, S, D, and A wave, and there is always a continuous flow during the atrial contraction, that is the A wave. So whenever there is a reversal of A wave, that is significant, and that is an abnormal DV flow. There is many a times a lot of contamination with the surrounding signals. So what you should remember is that this is from here till here is the one pulse, and the D is ending here. There is a gap here, and then the next S is starting. And so that A wave reversal is seen here, and that is a true A wave reversal and not a contamination. The tricuspid regurgitation, again, you should magnify the four-chamber view. The guidelines say color Doppler is not so useful at that time because color tends to a little bit bleed, but with a good really get a good aliasing of that tricuspid regurgitation even at 11 to 14 weeks, even on transabdominal scanning. You can just put a PW sample width of more than 2 to 3 millimeters across the TV valves with the intonation angle less than 30s, and then you get the spectrum. That will be the inflow, and whenever there is any regurgitation, you will see it as in the opposite direction. So many a times, since the heart is small, you tend to get the outflows coming in that same section, but the velocity is less than 60 centimeters. As you can see here and here, it is a tricuspid regurgitation because the velocities are much higher. So these are the important markers, what we saw. So let's come to the structural analysis. This is done system-wise, like we do at 18 to 20 week scan. So right from head to the toe, everything, whatever is possible can be assessed at this time. The previous guidelines which came up were almost 10 years back. It was published in 2013, and a lot has changed since then. So these new guidelines which were just released a month back are really extensive. I will suggest everybody to go through these guidelines. They're really extensive. They've really explained things in detail, right from the genetic test, what should be the counseling, what kind of machine to be used, and all that is explained really in detail. So biometry, of course, is an integral part of any obstetric scan. So here it is the CRL and the BPD HC ACFL. These measurements are possible beyond 12 weeks in most of the machines. So whenever the fetus is beyond 12 weeks, we start taking these measurements, and plus CRL. CRL has to be taken in all your scans between 11 to 14 weeks. Then how we do the scanning for the CNS in 18-week scan, second trimester anomaly scan, we do the same 3 sections, even in 11 to 14 week scan. So this is the plain one where you will look at the FUX in the center. You have to look at the overall head shape, ossification, the choroid plexus, which form that butterfly kind of a structure, the lateral ventricles. This hypoechoic structure, what you see actually is not the cortex, and it is the lateral ventricles. The cavum is this particular structure, cavum vellum, and that is seen here in the center. And the cortex actually is a small thin line here. I don't know whether you can, really appreciate it, but the cortex is that small thin gray line which is seen there, and that is the cortex. It is not really seen so well. Then when you come a little bit, is the falx, of course, there are these thalami, cerebral peduncles, and the aqueduct of Sylvius. This is the most important structure here. Look at this, it is so posteriorly placed as compared to the second trimester. That is because the posterior fossa is not well formed. So this almost looks like the CSP, what we see in the second trimester, but on the opposite side. So this is the aqueduct of Sylvius. Make a habit of seeing the aqueduct in all your scans. Then when you come little down and the transcerebellar section, these are the, choroid plexus. These are the thalami. This is the fourth ventricle. That is the fourth ventricle, which is seen so prominent, and future cisterna magna. And this continuation, this keyhole kind of an appearance is normal at this stage. So that should be remembered. And cerebellum is just kind of developing. It is not really developed so well at this stage. So this is a general sweep, what we do, like we do the actual scans for the 18 to 20 weeks anomaly scan. Then the other important thing is the intracranial translucency, which is also taken in that same mid-sagittal section. So what you see here, this is the NT. This is the occipital bone. This is the future cisterna magna. This is the intracranial translucency, which is the fourth ventricle. This is the choroid plexus. This echogenic line, what you see here, is the choroid plexus in the fourth ventricle. And then the brainstem and the thalami midbrain complex will be seen. So that IT is very important to see. And, whenever you are trying to get a good NT section, when you are just moving your probe from one end to the other, slight movements here and there, you will always tend to see that NT section, IT section very well. So what you see is those generally the four echogenic lines. This line is the upper border of the brainstem, which sometimes may not be seen as very well echogenic line. So some people will say these are three echogenic lines. This is the lower border of the brainstem. Then it is a choroid plexus of fourth ventricle. That is the occipital bone. So these are the four echogenic lines, which you eyeballically also you can make out that these are the ones. IT can be measured. Nomograms are available. Normally it is around 2. 1.7, 1.8 to 2.1, that is all is the measurement what you get, and that is your IT. So similarly, if you take the brainstem diameter and brainstem to occipital distance, you know that the brainstem to occipital distance is going to be more, and then you can take this ratio. So whenever there is an open neural tube defect, this is the brainstem is going to come down, the IT is going to be obliterated, and this ratio is going to be reversed. So normally it is less than 1, and then in neural tube defect, it is going to be with that. Tip or the apex of triangle is seen as the bones. Then these are the orbits here. Here you will see orbits coming there. That is the maxillary process. That is the maxilla, this is the mandibular gap. So there is a gap here, and there should be no gap at the maxilloalveolar ridge. The significance of that we will again be seen in the next lecture whenever we are looking at the abnormalities. The palate can also be seen in that axial section. Your axial section of the brain, you will keep taking one section down, and when you come to the orbits and a little bit down, you will see this as that whole echogenic structure, and that is the maxilloalveolar ridge. So this is the bony hard palate, which is seen as the faintly hyperechoic region. So here, when you are coming down, see, you tend to observe that hyperechoic structure here, and that is the entire palate. So this is the actual section of the palate, how we see in the 18 to 20 week scan. So always there are subtle signs, there are small clues to the diagnosis of, say, cleft lip palate, say micrognathia. So you have to see these images, see the sections in the other view. If you're seeing it, suspecting something in the coronal view, confirm it in the axial view, confirm it in the sagittal view, and things like that. So this will be again seen as the normal sagittal section where you see the palate. So what is superimposed line sign? This is in the sagittal section again. When you come posteriorly in the palate, you start seeing it as two lines. This is the palate and this is the vomer. So whenever you don't see a superimposed line sign, again, it will be suspicious of a cleft palate, cleft hard palate. Again, as you see here, you're seeing this as a double line. So this was about the head face. In the neck, we have to see that there are no jugular spaces seen, and the NT measurement, which we have already covered. So we come to the thorax. In thorax, we see the lungs, the four-chamber view. Initially, we said just two inflows on color Doppler is good enough, but the new guidelines say that you should try and see the four chambers or the four-chamber view even on grayscale. And then you look at the axis, the size, the situs. So all these things have got added in the newer guidelines. So this is the grayscale image. This is again the same way as you draw the axis in the second trimester. You will be able to see equal inflows once you put the power that itself the cardiac axis, because you know this is the interventricular septum. So you can take the axis well even in that. And then, of course, you will see the two outflows forming a V sign, or more than V, what they see is a tick sign, because you tend to see this limb more as compared to this aorta. And so they say it as a tick sign or a V sign. Then we come to the abdomen, and here we will see this as the stomach, the urinary bladder, the cord insertion, the two umbilical arteries. Then when you come to you go still posteriorly, you will tend to see the kidneys, the spine will be seen in that coronal section, and the kidneys, most of the times trans-abdominally, if you're seeing, it may be a little difficult. By 13 weeks, probably you will start seeing it. By transvaginally, you will always tend to see it. So now I think it is going to be more and more important to start doing the transvaginal scan, probably in all your 11 to 14 weeks scan patients. Then we come to the extremities, and we come to, three segments of the limbs. You should see arm, forearm, and the fingers. So the proximal segment, the mid segment, and the distal segment. At 11 to 14 week scan, it is in fact very easy to see all the four limbs, because there is good mobility, there is good space. In fact, in 18 to 20 week scan, sometimes we find it so difficult to look at the posterior hand, the posterior fingers. We really have to make a note, see that the fetus moves, and we have seen the other hand completely. But here it is going to be really very easy. Then we come to the lower limbs. Again, here it is the proximal segment, mid segment, and the distal segment. So all that should be seen. All three segments should be seen. When we look at the spine, you see it just as a two-line structure. It is not completely fused at this stage. So you see it skin covered completely right till the end. So that is what is very important. Even though there is an open neural tube defect, you don't see that typical meningomyelocele kind of an appearance, what you see at 18 to 20 weeks. So your importance is on the IT, which gets obliterated, and that skin cover, that continuous lining of the skin will not be seen. Then you will see some break. Then you take a transverse section, and then then you will suspect, or you will directly see the neural tube defect. Of course, you have to look at the uterine artery PI. It is taken in the sagittal section at the level of cervix. You are in the sagittal section, you see a cervix, and you do a fan shape movements, once to the right, once to the left, and you put the color Doppler on. You will the uterine of internal os, which is vertically oriented going into the uterus. And there you will see it as the vertically oriented structure, which slightly aliases because there is a high velocity flow. And you should put your PW sample gate should be 2 millimeters. Angle of insonation should be less than 30. And you take it as right uterine artery PI and the left uterine artery PI, and the mean is calculated. Again, giving a percentile value is a good practice point, but just to remember, 2.35 is a easy to remember cutoff. Anything more than 2.35 is abnormal. Anything less than that is usually normal. And it's a mean uterine artery PI. If one-sided uterine artery PI is, say, 2.8, and the other side is 1.4, the mean is going to be less, and then that is considered as normal. You must look at the other intra or extrauterine structures. You have to look at placenta cervix. You have to look for any subchorionic fluid collections. You have to look for the position of placenta in relation to the cervix. We always do that in 18 to 20 week scan, but it is not so important at this stage because the uterus is so small, the placenta is formed, and invariably it is going to be near the cervix or say within 2 centimeters of the cervix. Most of them will migrate away from the internal cervical os. So placenta previa should not be reported at this stage unless it is completely covering previous LSCS. You are seeing there is some thinning or there is a history of bleeding PV. And that's why you want to warn the clinician that yes, this placenta is low lying or it's completely covering the os, and then we tend to write it in the reports. Special attention should be given to the patients with the prior cesarean section. They are predisposed to scar pregnancy or adherent placenta with significant complications. So you should be aware of this and you should make the clinician aware of this. Any gynecologic pathologies, uterine shape anomalies still will be picked up at this stage. At 20 weeks, it may not be really easy. Leiomyomas, because they tend to increase in size during pregnancy, they may cause pain. So you should be documenting that structure to see whether it has increased in size, whether it has undergone any degeneration, any adnexal lesions. When the uterus is really enlarged at 20 weeks, we don't really see the adnexa very well. But at this time, we still will be able to see next to the uterus on both the sides if there is any cyst, any dermoid, or any of these structures, so which can be mentioned in the report. So as I said, everyone should go through these guidelines. But what is there in these guidelines is that first is what they say, you should just look at the fetus in general, confirm it is a singleton or pregnancy, overview of the fetus, uterus and placenta, head, what are there in our CNS sections. So this is just the kind of checklist which is there for head and brain. In the face and neck, again, what we said that the forehead should be seen, bilateral orbits, the nasal bone, the maxilla, retronasal triangle. Now, what has come up here in these guidelines is they have written that you should look at the upper lip, which is difficult many a times, especially transabdominally. Transvaginally, you get it little easily, but that upper lip is something which is going to be of nuisance for maybe some days, at least initially, till the time we get used to seeing it in all our 11 to 14 weeks anomaly scan. The mandible, of course, can be assessed in sagittal section and in that coronal as the premandibular gap. Nuchal translucency thickness and no jugular cyst in the neck. So that should be seen in your face and neck region. Thorax is shape of the thoracic wall, lung fields, and diaphragmatic continuity. It is, in fact, relatively easy to look at the diaphragmatic continuity if you adjust your grayscale, your DR and your other grayscale images. The lungs can still be differentiated from the liver, and the diaphragmatic contour can be made out at this stage. Heart, again, as I said, a lot has changed in the heart. You have to look at the heart activity for the regular rhythm. You have to establish the situs. You have to look at the position, cardiac axis, Size 1/3 of the thoracic space, 4-chamber view with 2 distinct ventricles on grayscale and color Doppler. So that needs to be remembered. We were not very comfortable seeing it in grayscale in all these patients up till now, but this is what has become mandatory now. Left ventricular outflow view on the grayscale or color Doppler. Again, you can't really always see the outflow track, but as I said, on the color Doppler, it will be seen. So this is this is not compulsory to see it on grayscale. 3 vessel and trachea view on grayscale or color Doppler. That is easy. We were doing this all these years. Absence of tricuspid regurgitation, antegrade ductus venosus A wave on pulse wave Doppler. So all these things, we anyway were seeing it as a part of aneuploidy markers, but it is now considered as a part of heart analysis even in this. In the abdomen, stomach, of course, we always were looking at it. Bladder, again, before 12 weeks, it may be difficult to document bladder. That's why I said structural scan should be always between, say 12 to 14 weeks. Abdominal wall, kidneys, bilateral presence, again, will be, little difficult transabdominally, transvaginally, it will be seen very well. 2 umbilical arteries again. Spine and extremities is what we have seen. Placenta, amniotic fluid, membranes. So all these things are important. And cord insertion into placenta, I think this is a very good point. We should see it at 11 to 14 weeks and also in our 18 to 20 weeks anomaly scan for the filamentous insertion and for maybe the vasa previa, what it may come up with. So just to summarize, yes, there are problems. There are plenty of problems: obesity, fetal position, previous LSCS, acutely retroverted uterus, but you can do it with the high frequency linear convex. You can use your TVS. Maybe the waiting time has increased for the patient, but these are all the advantages of doing the early anomaly scan. So it's a changing concept. We cannot just say that it is a nuchal scan. Now, we have to do it as an anomaly scan. Adequate patient counseling is important. It is not that once you see it at 11 to 14 weeks, everything is normal. 18 to 20 weeks scan need not be done. You have to get it done. You should know the sonoembryology well to say what can be seen and what cannot be seen. And there is a lot of difference between doing the scan at 11 to 12 weeks and beyond 12 weeks. So that needs to be remembered. So thank you. This was a little kind of a bigger topic, but the new guidelines, if you all go through that, it will be easier for you to understand and apply it in your practice.
Thank you so much, ma'am. You've laid a perfect foundation. I guess you've driven the right message that guidelines need to be followed. And we have to go beyond, much more beyond NT and NB. Thank you so much. In spite of you having so time crunch, you could spare this time. Thank you so much, ma'am. And to take this further, we have none other than Dr. Chandar Lulla. He's been my teacher. He is probably the pioneer of fetal medicine in Mumbai. He's a consultant at HN Reliance and Just Look Hospitals, apart from the Rias Center where he sees the who's and who's of Bollywood. So he is going to take us one step further as to what now needs to be seen in the structural scan that we'll perform at 11 to 14. Over to you, sir.
Thank you, Mohit. Thank you for the kind words. I'll just share my screen. Can you see my screen?
Yes, sir. Yes,
okay,
it should be.
That was a lovely talk by Alpana, laying the grounds for a first trimester scan, and that makes my job a lot easier. I'll straight away go to looking for anomalies. As you can see, we usually scan between 11 and 14 weeks after Carnegie stages 10. And sometimes it's useful to keep this chart in front of you to see the development of the fetus. Now, you know that the first trimester ultrasound is absolutely a new pillar in obstetric care. And we have tremendous advances in ultrasound equipment already there and already coming. And this is providing every day increased insight into embryonic development. And this has been instigated by, of course, the nuchal scan. Now, Alpana has very well highlighted the use of transvaginal, which we use sometimes, not always, but most of the times transabdominal provides good resolution. And of course, color is useful for the doctors and for the fetal heart. And 3D is good for multiplanar imaging and solving complex situations. We have seen already what are the practice guidelines that we need to follow. And this is a very useful chart that they have provided for which you can tick to see on your computer what all structures and the levels of different scans which you have just seen, what are the structures that you will see. Practically speaking, although we need to follow the guidelines, what we actually do in real practice is we sweep through the entire fetus in the sagittal, transverse and coronal fashion, and this gives us most of the views that we are looking for. So we get about 4 views in each section. So you get the NT scan, the entire fetus for the CRL, the limbs, and the spine that we see in the sagittal view. In the axial view of the fetal head, we see the structures that have already been highlighted by Alpana, and the lateral ventricles, the cerebellum, the eyes, the lips. In the thorax, we, with color, at least identify the presence of all the chambers, the 2 outflow tracts. Moving down, we look at the important to look at the stomach bubble, the bladder, if it is seen, and also the cord insertion site. On a sagittal scan, or sorry, on the coronal scan, we look at the premaxillary triangle, which she has so well shown. We look at the spine, then the kidneys, and the stomach in the left upper quadrant. So this is very, very useful. And then, of course, the sagittal's midline scan is probably the most important scan from all points of view, from measuring the fetus to looking at all the aneuploidy markers, and also to look at the various contours of the fetus, because most of the times you will see that the entire fetus has a very smooth contour, and sometimes even before 11 weeks you can pick up abnormality in just by looking at the midline section and also the aneuploidy. Now, the 612 transvaginal transducer is really useful, and so is the 29 transducer. This is available in most equipments today for doing very high resolution scanning. And you can see this is, of course, a very early scan of a fetus at about 9 to 10 weeks, I think 9 weeks, 5 days. And you can see that that was the fetus seen at which presented at 9 weeks, and we couldn't see much at that point of time, except that there was something wrong here and here. When you actually go and see, this is the case of holoprosencephaly on the transvaginal scan. You don't see the interhemispheric forks, and there's a fusion of the thalami. So it's very important. The moment you feel that there is an abnormality or some red flag, you switch to a transvaginal scan. And of course, these are some of the images that today we get with the transvaginal transducer, which Alpana has already spoken about, all the landmark structures that can be seen. And so these are some of the areas that we normally like to evaluate. Of special mention is the limbs, because this is the best time to look at the entire limb in one view, and you can see the digits and all the 3 segments very well. Also, the heart, applying the second trimester principles, you can see the various outflow tracts and the various sections that we would take for the fetal echocardiography. That, of course, is the right subclavian artery. And then we have a whole host of technological innovations that allow us to see the fetus better in 3D with the silhouette view, etc., which here you can see the skeletal system very well, the absence of the nasal bone, etc. And there's microvascular imaging, which adds to looking at both the intra-abdominal and intracranial circulation. Now, this is a landmark paper, I would say, from the point of view of understanding the fetal anatomy scan between 11 to 13 weeks, and also I would think from a medical legal point of view. It was published in 2019 by Singalaki et al. And the earlier publication was in 2011. And these are some of the abnormalities that they looked at. What can always be detected was 30%. sometimes detected 40%, and undetectable 26%. So you can always fall back to these, especially when patients, troublesome patients, ask you why was it not picked up. So, but one must remember that everything is a caveat. If this is mentioned in bold, you cannot miss these abnormalities, specifically acrania, holoprosencephaly, body stalk, some cardiac abnormalities, and ventral wall defects. Most of the times, these will be detected. So again, this is a sword on our shoulder that you need to look for spina bifida, lethal skeletal abnormalities, some lethal cardiac abnormalities, and megacystis and low urinary tract abnormality. These are never and these are sometimes, so we will see what we can pick up and what we cannot. Now, this was just a case yesterday night. It came to me. I was just rushing through. It's 9 o'clock in the night, and you can see that the limbs are seen, 2 hands, and there was something wrong here in the left hand. And immediately I switched to a transvaginal transducer, and you can see that, sorry, there is radial clubbing of the hand on 3D surface rendering, and also on the 2D view, you can see that the fetus is, and this was really heartbreaking for both for me and for the patient. This is an IVF pregnancy, and you can see that there is a single forearm bone. So very important that you look at the transabdominal scan very carefully, because we do have limitations of time when we are scanning, and only then we can move ahead to these diagnoses. So let's look at some of the abnormalities that we can pick up in the first trimester. And let's start with the CNS abnormality. This is, of course, very early. At 8-9 weeks, you can see the classical 3 cystic areas, the prosencephalon, mesencephalon, and rhombencephalon, which go on to developing the entire fetal CNS. And here I use the contour sign, as I have described it earlier, is that, as I said, the fetus normally has a very, very smooth contour. And the moment you pick up any abnormality in the contour like this, you know you're dealing with an abnormality even before 10 weeks. So when we're looking at the most lethal abnormality today, which needs to be picked up, is the acrania, exencephaly, and encephaly sequence. They're basically 3 different severities. It starts as an acrania. Sometimes you will not have the frontal bones. The margins will be smooth, and then it may progress to developing the classical encephaly. And you can see on the 3D surface rendering, that's the frontal bone here. The frontal bone is missing, but the brain and the skin is intact. And it will then move on to give you different appearances, as has been highlighted in this paper, of the different types of anencephaly, depending on the presence or absence of cystic areas in the frontal area. So this is a typical acrania with intact skin covering, and the brain is exposed, and there's of course nuchal edema, and then it will progress to anencephaly, and this can be today picked up before 10 weeks just by looking at the abnormal contours. No brain cavities, the prosencephalon, mesencephalon, and rhombencephalon, and of course the abnormal CRL, because the absence of the calvarium makes the CRL to become smaller. And moving on to 12 to 14 weeks, then you will see the fetus moving around with the typical Mickey Mouse sign, and the brain which is floating around. And this is seen in about 1 in 1,000 pregnancies, and has a small recurrence risk, and we need to give preconceptual folic acid once we see this abnormality. Now, this was very well classified as the Donald Trump type of anencephaly, with the typical hairstyle that he had, and this is sometimes what you will see. The next major abnormality that you need to look for is an alteration in the contour with a bulge, is a cephalocele, which is less common than anencephaly, but it's more commonly seen in the occipital area, as you can see here, and that's the calvarial defect seen on 3D imaging. And on the same fetus in the frontal view, you can see a bilateral cleft lip. So this is as early as 14 weeks. This is a lateral cephalocele that can be seen here. And these are, of course, lethal defects. We can straight away terminate these pregnancies. This is another fetus with complete absence of the calvarial vault here. You can see with a slight bulge of the fetal cranium, and on the coronal view, you can see that this is a hemifacial acrania where the entire one half of the face is missing, and this could be due to an amniotic rupture sequence where you may not see the amniotic bands. The moment you see a cephalocele, we look for a syndromic situation where all the three elements, that is a cephalocele, the polycystic kidney, and the polydactyly, may not be seen in each and every individual, but we need to, especially in certain families, we have seen that being an autosomal recessive disorder, this ciliopathy can be recurrent, and we need to call these patients for a recurrent scan. Moving on to the area of another area of lethal defect is the spina bifida, and from time immemorial, people have been looking at spina bifida, and this is again a very small fetus at 8 weeks. You can see a 8 to 9 weeks fetus has a smooth outline, and here I was seeing a very small irregular contour. I'm just highlighting this to show you that with high resolution ultrasound, you can pick up these abnormalities at slightly earlier stage, or at least get red flag to then follow up these fetuses. And at so this is important. We don't make a final diagnosis at times. We follow up these fetuses even sometimes up to 16 weeks. And then we see that there is a meningocele with a widening of the spine at the same area with a spina bifida at 11 to 13 weeks. So obviously we don't commit at this stage. We just do more intensive follow-up, and this will allow us to pick up these abnormalities. So this was a publication we did of an 8-week embryo. Of course, today, a better way to look at spina bifida, as has been shown by Alpna already, is the IT sign, which is about 50% sensitive and 99% specific for open spina bifida. And you can see here, but what is more specific is the widening of the brainstem. So the brainstem occiput ratio, if it is more than 0.5 to 0.6, or specifically more than 1, with compression of the fourth ventricle or the IT, that means you don't see the IT very well, or the cisterna magna, then we immediately look for the spine, and there you can see a large meningocele. So one may argue that it would be better to see the entire fetus, and again you will pick up an abnormal contour, as I said, and that of course is the case in most of the times. But when you're doing an NT scan, this immediately strikes you to looking at the spine that much better. And then there are a host of signs today to pick up spina bifida. I'm not going to go through all of them. They are all available on the net, but I think the IT sign is one of the easiest to perform on the mid-sagittal view. For most of these other signs, you will need a transvaginal axial view. For example, here, this is the dry brain sign, where the choroid plexus looks larger than the rest of the brain. And this is Ravi Choi's new sign for spina bifida. And here again, you can see that the choroid plexus is filling in more of the lateral ventricle, and that indicates that there is going to be a spina bifida somewhere there, and that's the meningocele that we see here. So then there is another sign is the frontomaxillary facial angle. If it is reduced, normal being 80 to 90 degrees as pregnancy progresses, this is because of the collapse of the frontal bone and herniation of the midbrain, and that again suggests spina bifida. And then there are plenty of such lines. I will not go through them all. The final one, of course, being the crash sign, where the aqueduct is displaced posteriorly, and you can see that the aqueduct is here, and that is the aqueduct here. This one here, and if it is compressed and pushed posteriorly, suggesting that this is a high chance of spina bifida. Moving on to holoprosencephaly, very, very early in pregnancy, today 7 to 8 weeks, you can see the developing fox and the separation of the midline. And as I showed you earlier today, holoprosencephaly can be a 9-week diagnosis. This is another fetus at about 10 to 12 weeks, 10 to 11 weeks. And you can see that there are a host of other abnormalities. There are there's syndactyly, there's cleft of the lip here. And so the moment you see all these, you need to look at the face to look for other, and this could be a trisomy 13. Now, most of the times we don't diagnose hydrocephaly in the first trimester because the choroid plexus fills up the lateral ventricle completely, except in some specific situations where it is so striking. Here you can see there is isolated dilatation of a unilateral ventricle. The choroid plexus is floating. There is shift of the midline to the opposite side, and this is unilateral for obstruction of the interventricular foramen of Monro. So this is a rare situation, and here again you can see there is widening of the IT that is seen here. This is another rare situation where there is ventriculomegaly with a mass in the lateral ventricle. This turned out to be a choroid plexus papilloma. So these are, of course, rare situations and may not be expected to be seen at most times. Now, in spina bifida, we see compression of the IT, but if the IT is wide in the first trimester, then that is a good sign for picking up a posterior cranial fossa fluid abnormality. As you can see here, this was a twin pregnancy, one twin having a normal IT, the other twin having a widened IT 2.9 millimeter. And on the axial view, of course, we are seeing a posterior cranial fossa cyst. At the same time, we could do a sagittal section, and fortunately, the vermis is appropriately sized, suggesting that this is a Blake pouch cyst. And on follow-up, we could see the derotation of the vermis and collapse of the Blake pouch cyst. This is another fetus. This was a publication by Acheron et al., which suggested a widened IT, and this turned out to be a Walker-Warburg syndrome with the typical kinking of the midbrain. And similarly, we had a fetus of the very similar findings. There was slight kinking, but most importantly, you can see that what highlighted us to this feature was hydrocephalus, massive ventriculomegaly. There's a lot of fluid and you don't see the choroid plexus so much. And you can see here, that is the dilatation of the third ventricle here. And on the sagittal view, you see a widening of the IT. So complete ventriculomegaly with kinking of the midbrain. And this is again a Walker-Warburg syndrome that can be picked up earlier. Corpus callosum need not be picked up. This is just from point of view of interest. You need to wait till 22 weeks for complete development. But just to complete the list, there have been some papers published. This, interestingly, is the midbrain Fox ratio, where you drop a line from the upper margin of the diencephalon or the thalamus, and the Fox ratio is calculated from this. And this is usually this upon this is about 0.5 to 0.6. But expectedly, if the corpus callosum is not going to develop well, the midbrain will herniate upwards and this ratio will become more than 0.8. And I just put this because I had a case. Otherwise, I would have probably skipped this. Here you can see there is widening of the midbrain here. At the diencephalon, it's about 0.78 and the ratio is 0.87. And that was a 3D image. This is the 2D image. Again, ventriculomegaly, you can see the upward migration of the midbrain, and also there was a dorsal cyst here suggesting that this is agenesis of the corpus callosum and holoprosencephaly. You can see here again about 11 weeks. There's marked nuchal edema suggesting an aneuploidy situation. But what is interesting to see is that some of these signs can work if you look for them. So this was a mid-sagittal view, and you can see the herniation of the midbrain with the dorsal cyst and holoprosencephaly, and of course there was polydactyly also seen in this fetus. You can also use the color Doppler very similarly with the slow flow, and we can see that the pericallosal artery is not below the cranium here. The moment it moves close to the cranium here, this is called the snake under the skin sign, described by Simon Marg, and this is again a sign for agenesis plus holoprosencephaly. Moving on to fetal abdominal, this is again defects that we need to pick up in the first trimester, and we need not wait till the second trimester. A physiological herniation may occur before 11 weeks. And it's usually less than 7 millimeter in size. Even if it is more than 7 millimeter in size at this early stage, then we can definitely suspect that this fetus is going to develop a ventral wall hernia. These are the different types of ventral wall defects. You can have an omphalocele, a gastroschisis, bladder extrophy, cloacal extrophy. and complex situations like pentology of Cantrell, the OES complex, and the Vacteral syndrome. And the basic fulcrum is that we look for the umbilical cord insertion. If the umbilical cord insertion is normal and in defect is to the right side of it, most of the times with free floating bowel loops, it will be a gastroschisis. If the umbilical cord insertion is normal and the defect is below it, and you don't see any extruded bowel, this is a bladder extrophy, and you would therefore not see the bladder. And therefore, it is important to see the bladder in the 12-week scan. If the cord insertion is abnormal, if it's a low insertion with involving the cord insertion site, then this can be a cloacal extrophy. If the defect is just sitting below the cord insertion and it's protruding below the cord, then that's the classical omphalocele. If the defect is above the cord insertion, potentially involving the cord insertion, this is the petrology of Cantrell. And if there's no definite anatomic distribution, this is a grossly abnormal fetus in fixed position, then this is a body stalk abnormality, which has to be picked up in the first trimester. Now, this is the whole spectrum of abnormalities that you will see. We identify the cord insertion site, and that's the K triangle there that you can see here. That is the umbilical vein, the umbilical artery, and the IVC. And if this triangle is disrupted, you know that there is a ventral wall defect even as early as 9 to 10 weeks. So that is bowel herniation, that is gastroschisis. This was actually a bladder extrophy, as I'll show you a little later. This is herniation of the cloaca. There's cloacal extrophy. There are multiple abnormalities associated with gastroschisis, omphalocele, and spinal abnormalities. So typical OES or vacteral abnormality also can be suspected. And this is also having an encephalocele. And here the fetus is completely deformed with part of it within the amniotic sac, part extruded. And this is a limb-body wall complex. Now, when we see a ventral wall defect, especially an omphalocele, we know that 75% of them have associated chromosomal abnormalities, and you need to do a CVS, specifically if you've got liver contents. So if there's bowel and liver, this could be trisomy 18. Here there is liver alone, but with other abnormalities, and this is also having a neural tube defect. This is an omphalocele again here, which turned out to be a trisomy 13 because there were other abnormalities, umbilical cord cyst, absent nasal bone, tricuspid regurg, and widened intracranial sign. And so on and so forth. Trisomy 13, 18, you may see limb defects. This was trisomy 18 with again nuchal edema and absence nasal bone with an omphalocele. So needless to say that the moment you see a ventral wall defect, the smaller the defect, the more in a higher chance that this is associated with a chromosomal abnormality, and the large may look alarming, but may have a better prognosis with less likelihood of a chromosomal abnormality. So it's very important that you look for this triangle, and the moment it's disrupted, you will pick up an abnormality. This was a 10 weeks fetus, just to show again the importance of the contour sign. Very obviously, the contour is abnormal. This is a herniation here. That's the cord insertion there. 12 weeks, similar findings, and at 18 weeks. Here, of course, you can notice that we are not seeing the bladder throughout, and in 18 weeks, there is complete extrophy of the bladder, and we are not seeing the bladder. Now, you could also see a cloacal extrophy here. That is a single umbilical artery. The kidney is showing hydronephrosis. The ureter is dilated here, and both the kidneys are hydronephrotic. And you can see that that's a cloaca which is extruded from the ventral wall defect, and that's a cloacal extrophy. This is, of course, an OEIS complex, as I've shown you earlier. The next important thing in the abdomen is to identify the stomach. This is not a very common abnormality seen in the first trimester because as the fetus consumes more amniotic fluid, this progresses to becoming a CDH more important in the second and third trimester, but rarely sometimes you may see the position of the stomach within the thorax. And this was actually a twin pregnancy with one stomach below, one stomach above. And on the 3D surface rendering, you could see a bulge of this area here with the stomach there, causing an abnormal contour. You can see it here. And we, of course, didn't make any conclusive diagnosis at this stage. We followed up the fetus at 18 weeks, and you can see that the stomach is displacing the heart at 18 weeks. So important message here is that we do red flag a situation. This is not a lethal abnormality. This is a correctable abnormality. Of course, presenting so early could lead to pulmonary hyperplasia, but important to note that we must follow up these fetuses to make a conclusive diagnosis. In the abdomen, the other area that we may see important findings is a distended bladder, what we call as the megacystis. And you have been told earlier that anything more than 7 millimeters is diagnostic of megacystis. And so there are two groups, we classify them. If it is very large, more than 12 millimeter, then there's a high chance of developing progressive obstructive uropathy like a luto, and less likelihood of being a chromosomal abnormality. Whereas if it is less than 12, then there is a higher chance of being a chromosomal abnormality. Here, I must caution you that some of these, especially if it's less than 12 millimeter, may regress on their own. So you do offer invasive diagnosis and follow up, and this is the differential diagnosis that we could be dealing with. If your karyotype is, if you have nuchal edema along with megacystis, of course, this could be an aneuploidy. If you have spinal defects, as I've shown you earlier with other associated defects, this could be an OEIS complex or even a bacterial abnormality with both the spine and the skeleton involved. And of course, if the size is very large, this could well be a cloacal malformation. So the moment you have an NT which is less than 95th centile, then you should look for the umbilical cord, because if there are umbilical cord cysts, then this is less likelihood to be a posterior urethral valve. If there are no umbilical cord cysts, then there's a higher chance of this being a low urinary tract obstruction, and some people have even put in shunts at a very early stage. Now, this is a very interesting case, just to highlight the fact that in the first trimester, we had a markedly distended bladder, almost 13 millimeters. This was the second trimester scan, where then the bladder was normal. You can see the bladder has regressed, but we were seeing an abdominal cyst. And coming back to the first trimester scan, you can see that it was pelvic in location. You're seeing the umbilical artery, the iliac arteries on either side. So it was definitely the distended bladder at this stage, but it regressed. And then the patient developed an abdominal cyst, which became smaller at about 30 weeks. By the time, of course, we had done all the aneuploidy workup. And finally, at 34 weeks, all the cysts disappeared. The abdominal cyst disappeared, and also the pelvic cyst. So it's very important that even if a cyst like 13 millimeter, we counsel these patients carefully, do an aneuploidy screen, follow up these fetuses at least up to the second trimester. And unless if it is, of course, very, very large and you're seeing kidney abnormalities and other abnormalities. Now, this was another such fetus where we were seeing hydronephrosis with a single umbilical artery with a markedly distended, what we thought was the bladder, but we couldn't really see a proper skin covering, and this was a very thin covering of the bladder, and this turned out to be a prune belly syndrome. Here is another fetus with a single umbilical artery with multi-septate cystic areas in the pelvis, and that, of course, is a cloaca. You can see some echogenic fecolids or enteroliths that are also developing in this fetus here. And you can see hydronephrosis. So 14 weeks, cloacal malformation. The other area which is very, very important that we don't miss abnormalities, because on the transabdominal scan, sometimes it may be difficult to see all the three segments. So you need to see the developing limbs and can be seen, as you can see here, better, of course, with 3D, but you need to identify the length, the shape, the mineralization, the associated features like the head, thorax, and spine. For skeletal dysplasias, for genetic abnormalities, we look at the heart and the kidneys, and a whole host of abnormalities that can be picked up, skeletal dysplasias that can be picked up. And one such case here, you can see this was a very, very early thanatophoric dwarfism. The limbs are extremely small. You don't see them beyond these small buds out there. There is frontal bossing that you see here, and there's a mild nuchal that is seen about very little nuchal edema. This was a thanatophoric dwarfism, but these are other cases. This is an achondrogenesis where you don't see calvarial mineralization. This is again the same fetus with on 3D. You can see that this thorax is markedly small and the abdomen is protuberant with a large head. And this is a hitchhiker's thumb with dystrophic dysplasia. And this is another fetus, again, with a very small limb. So here, if you see at the 11 to 14 scan, if the femur is less than about 0.9 to 1 centimeter, we definitely suspect that this can be a skeletal dysplasia. So that it's important sometimes to measure the fetus. Now, these are other rare skeletal abnormalities with hydrops picked up only on the microarray. There were small limbs, cardiac abnormalities, and this turned out to be a very rare abnormality of a glucose 6-phosphatase isomerase deficiency. So these are autosomal recessive conditions. Important just to highlight the fact that we should do a complete whole exome or a clinical exome the moment you're suspecting skeletal dysplasia, because you have an early window here, and many of these skeletal dysplasias will have single gene defects which can be running in the family, and this will be the first time that you will ever come to know about them. Then this is, of course, a sirenomelia, very commonly seen at the 14 weeks with a single umbilical artery and oligohydramnios. And there can be other limb reduction abnormalities that you can see. This is complete amalia, only a single limb was seen here. And here there is amputational defects. This patient had a first trimester bleed. This was the abdominal scan, and you could easily miss this if you don't focus on the limbs. The moment we move to a transvaginal scan, you can see that all the 4 limbs are amputated. You can have hand and finger abnormalities. So there's polydactyly, there's syndactyly, there is talipus. This can be transient. So if there are no other associated findings, we would just follow up. And this is a lethal pterygium, multiple pterygium syndrome, where there are extreme degrees of contractures with hyperextended neck. And of course, we did not let it go beyond the first trimester. Otherwise, you would have seen other pulmonary and cardiac abnormalities associated with this abnormalities. Then looking at the face, Alpana has already highlighted about the cleft lip. I'd just like to point out about micrognathia. There are some angles available. There are a lot of syndromes, as we know, but this is one angle that I really like. It's called the maxilla nasion mandible angle. It's about 11 degrees throughout pregnancy. And if it is widened, it suggests that this could be mandibular hyperplasia, because most of the times you're doing a midline sagittal scan and you will see a retrognathia or a micrognathia. Here, of course, there were other abnormalities. And this is a very, very serious abnormality, the Pierre-Robin syndrome. So it's visual at most times, but you can measure the angles. And if it is subtle, then you need to call the fetus back at about 18 weeks. So severe cleft lip, median cleft lip, causing a severe micrognathia because of cleft palate. The tongue is herniated upwards and the mandible doesn't develop. So the cleft lip, again, with Rabi-Choi's maxillary gap sign, we got a great Philip to look at the maxilla here on the mid-sagittal section and to look at the gap sign for multiple defects that can be picked up. And here is one such case here at 11 weeks. You can see the defect very well in the palate, and you don't see a nasal bone. 3D is especially useful when I'm looking at facial abnormalities. You can see the depression of the nasal bridge, how the nose is malformed, and you can actually see the cleft lip there here. With the cleft palate on the axial view. So very important that we look for the 3 sections of the head. Of course, this fetus also had a holoprosencephaly, microphthalmia, and cardiac and finger defects, all pointing in favor of trisomy 13. And then we have this lovely paper by our very own Lakshmi on looking at first trimester cleft lip. I request all of you to see that. It's a bit difficult to do because you need to be very accurate and move from the midline to parasagittal. At most times, I think we can focus on the maxillary gap sign, but sometimes it may not work, especially if it's a unilateral cleft with the palate. You may see see an intact palate. And then Lakshmi's paper is very useful from the point of view of both looking at the premaxillary triangle at that and adding that information. Some lethal defects can be seen on the first trimester, and this was an orofacial teratoma that we could see. Multiple pregnancies, we may see some abnormalities in the form of conjoined twins. You can see here, this is 8 to 9 weeks fetus with a single umbilical cord and a complete fusion. This is actually not a conjoined twin. You can see 2 umbilical cords. These are actually momo twin, monochorionic, monoamniotic, but there is intertwining of the cord. So you need to be very clear. If you see the fetus separating from each other at any stage, please be careful. This could be a momo twin that you may see with 2 different heartbeats in the umbilical cord. And this is a 17 weeks fetus with a omphalophagus that you can see with with a single umbilical cord, 2 livers. The most ideal of the conjoined twins, which can be easily separated because you see the fusion is very, very less. And these are, of course, a lot of other situations that can be picked up. Now, in multiple pregnancies, we must remember that the risk of abnormality can be very, very high. This was a quadruplet pregnancy with 1 anencephaly. You can see the abnormal contour. The other fetus had a trapped fetus, a parasitic twin. The third embryo, these are all at 10 weeks, 10 weeks, 2 days. You can see there was a small abnormality of the contour. So, of course, we reduced these 2 and we followed up. And you can see at 18 weeks a meningocele, and only the 4th fetus was normal. So the first trimester can be used to reduce an abnormal fetus either with KCL or with laser in many of these situations, especially if there's a trapped fetus. As you can see here, a laser can be used to reduce some of these fetuses. Cardiac abnormalities, Alpna has already highlighted the fact that you should look for symmetric chambers. I'm only going to show a whole, this is of course showing reversal of ductus, highlighting you to the fact, a wave of the ductus, that there could be hyperplasia of the heart. But these are some of the red flags. The ductus venosus and the tricuspid can be red flags to pick up abnormalities. And these are some of the abnormalities that we can pick up in the first trimester. Hypoplastic left heart, VSD, AVSD with the central regurg. Color is very useful in the first trimester to pick up abnormalities. You can see that there is a central regurg. Here there's you can use pulse Doppler. The peak flow velocity is high with calcification indicating that this is aortic stenosis. 3D with power Doppler allows us to pick up single outflow tract abnormalities like overriding of the aorta and truncus. This was, of course, a Fallard's. This is a truncus with a single outflow tract that is seen here with bidirectional flow. And then with color and Doppler, you may see multiple abnormalities. So polyvalvular dysplasia, both the outflow tracts are showing bidirectional flow, indicating that this is polyvalvular dysplasia, trisomy 18. Now, the use of color, I'm just going to show a couple of slides because it's very useful to see color. We normally see the hepatic, we don't see the hepatic artery as often. It is, of course, a marker for Down syndrome. But here you can see that in this particular fetus, when you have hydrops, specifically when you have hydrops, you need to find the cause. Of course, you will be doing aneuploidy screening with either a chorionic villus sampling or an amniocentesis, but we need to do a careful structural scan. And here you can see that this is a dilated hepatic artery inserting into the umbilical vein. So this was an AV malformation, a vascular malformation, and how color helps to pick up. And you can see the normal hepatic artery is less than 20 centimeters per second. If it is 20, it's suspect for Downs. But here it was 79 centimeters per second because this AV malformation was causing the hydrops of this fetus, and there was no aneuploidy in this particular situation. And this is, of course, a 3D reconstructed view. You can see the dilated hepatic artery going into the umbilical vein. At most other times, you may see abnormalities of the ductus venosus. This is a normal, this is an abnormal. You can see the ductus inserting into IVC. And if it is isolated, it can have good prognosis. But if it is associated with nuchal edema, then it can be a marker for either trisomy 21 and sometimes even Noonan syndrome. So here, of course, we are seeing tricuspid regurg with nuchal edema. And here it's again inserting into the IVC here. And the insertion into the IVC is with the massive nuchal edema is a marker for Noonan syndrome. Last two cases I will conclude because these were interesting presentation. This fetus was referred to me for an A-wave reversal. And when I saw the umbilical vein, it did show an A-wave reversal. But what I was seeing was a split in the umbilical vein. So one component going into the IVC, one component going into the venous confluence, and the ductus was actually here inserting directly into the IVC and showing a normal flow. This fetus had no nuchal edema, and therefore we can expect a good outcome. So another fetus referred for absence of ductus. And again here, the similar abnormality. These two, in fact, came in the same week. You can see direct insertion here. And so with color and 3D reconstruction today, you can pick up all these subtle abnormalities. And therefore, it's very important to pick up abnormalities. Single umbilical artery, there should be a caution. Sometimes what is apparent as single may actually turn out to be double on an 18-week scan. But of course, if you have other abnormalities, you can pick up. Cord cysts can be a marker for other abnormalities. And needless to say, the moment we have an abnormality, we do a CVS and rule out the entire genetic environment. Now, in conclusion, the list of abnormalities that can be picked up increases on a daily basis, but for most of us, these are expected to be picked up. You need to rule out the acrania sequence. You need to rule out holoprosencephaly, a ventral wall defect. You need to pick up megacystis, hydrops, and of course, body stalk abnormality. There can be limitations of size. Don't hesitate to follow up, and you need to have a significant learning curve for doing these methods. To improve your scanning, you need to be good at second trimester scan and then be rapid to adapting to new fetal positions, get the best out of your machine and understand fetal development. At most times, you will be expected to pick up about 60% of abnormalities, but there are new and new papers which are coming up on a daily basis which say that you can pick up almost about 80 to 90% abnormalities. So in conclusion, first trimester screening is an effective method for structural abnormalities. A complete anatomical survey is possible in 98%. In low risk population, about 60 to 70% of abnormalities can be picked up. If you have a nuchal edema in high risk population, you can pick up about 80%. Lethal abnormalities need to be picked up and terminated. Minor suspicions, always follow up, don't commit. What's most important is that for the patient point of view, you're confirming normalcy in a high-risk group, which is very encouraging and very important to do systematic scanning, as Alpana has shown you. And I thank you for a very, very patient hearing.
I mean, you've really shown how there's been a paradigm shift to look at anomalies from the second to the first trimester. And your elaborate display of images has been wonderful. And it goes to show that most of the anomalies that we now see on the second can be indeed picked up in the first trimester. Thank you so much.
Thank you, Mohit.
Yeah, thank you. In spite of your busy schedule today, I know you have 4 talks, but thank you so much for joining.
Thank you. Thank you.
So we don't have any questions for you, sir. So you can, if you want to leave. Yeah. And now we move on to the fetal heart. Now, most of the beginners always have a trouble figuring out the exact anatomy of the heart. And we have Dr. Sonia Patankar, who's been a fellow consultant, works with me in Abhipray. She is an alumni of the prestigious KEM Hospital, and she's going to take you step by step as to how and what to look in the fetal heart. Over to you, Sonia.
Thank you, sir. I'll now share my screen. Good morning. I'm Dr. Sonia Patankar Bairi, and my topic for today is fetal cardiac sonoanatomy and scan planes. Before I begin, I would, however, like to express my gratitude to the ICRI, IRIA, and my mentor, Dr. Mohit Shah sir, for providing me this wonderful opportunity. So fetal cardiac anomalies account for approximately 8 to 9 per 1,000 live births. And this incidence will actually be much higher if we include subtle anomalies like a persistent left SVC. We all know that the structural cardiac anomalies are among the most frequently missed on a routine mid-trimester ultrasound, thus bringing upon the role of cardiac screening and guidelines so that we can maximize the detection of these heart anomalies during our routine second trimester scan. Guidelines actually tell us the bare minimum that we need to do to maximize the detection of anomalies. However, when it comes to documentation, the sky is the limit, because the more we document is the more that we have seen. We follow the ISWAG guidelines for sonographic screening of the fetal heart. The ISWAG guidelines include sections of the fetal upper abdomen for assessment of the fetal situs, followed by the axial four-chamber view and views of the left and right ventricular outflow tracts as a part of our routine cardiac screening. However, we also recommend that the 3-vessel view and the 3-vessel trachea view should also be included in our routine cardiac examination. The best time for evaluation of the fetal heart is between 18 to 22 weeks. However, in patients with a higher BMI, the heart may not be adequately evaluated at 18 weeks. Also, with increased gestation, the functionality of the heart also improves. But most of us are referred patients for anomaly scan around 18 to 19 weeks. So even if we do a scan at that time, with the legal age of termination now being extended from 20 to 24 weeks, this provides us an excellent window of opportunity at around 22 to 23 weeks to rescan the fetal heart and brain in greater detail. Optimum views of the heart are obtained when the apex is directed towards the anterior maternal wall. That is the apical four-chamber view, is the best view for evaluation of the fetal heart. We recommend the use of good machines with good probes, having good cardiac and color settings for detailed evaluation of the fetal heart. They should also allow for HD zoom and cine loop facilities to assist in the real-time evaluation of the normal cardiac structures. So the heart occupies the central part of the thoracic cavity and in the middle mediastinum. It is bordered anteriorly by the sternum and the anterior ends of the 2nd to 6th costal cartilages. The lungs are seen on each side posterolaterally, and the diaphragm is located inferiorly. Majority, that is around 2/3 of the heart, is seen in the left side of the chest, with 1/3 being on the right. And the heart should occupy approximately 1/3 of the thoracic area. We evaluate the heart using a simple systematic segmental approach, which is recommended by most guidelines in screening of congenital heart diseases. So this begins with assessment of the fetal situs, identifying the atrial arrangement, identifying the atrioventricular connections, the AV valves, identifying the ventricular arrangement, identifying the ventriculo-arterial connections, the semilunar valves, identifying the arterial trunks, that is the great arteries, in relation to each other. And finally, we evaluate the systemic and pulmonary venous connections. After establishment of the fetus laterality, it has now been accepted that the best view for assessment of the fetal situs is the transverse axial section of the fetal abdomen, where you can see one complete rib on each side. We have the stomach bubble on the left. The umbilical vein is coursing towards the right. The descending aorta is seen anterior and slightly to the left of the midline, and the IVC is seen anterior and to the right of the aorta and the spine. So as you can see in this video, as we go from the stomach, slide upwards towards the chest, the cardiac apex will be directed towards the left, and that establishes a normal situs. However, to note, the position of the aorta and IVC below the diaphragm are more reliable for determination of isomerism than is the location of the stomach in the abdomen. The cardiac axis points towards the left with the interventricular septum making an angle of approximately 45 degrees with a line drawn from the spine to the sternum. Abnormalities of cardiac axis are always associated with cardiac anomalies. So a left axis deviation can be seen in conditions like a TOF or a common arterial trunk or a coact. A right axis deviation will be seen in a DORV or a large AVSD. Certain extracardiac conditions like an omphalocele or a gastroschisis could also lead to deviations of the cardiac axis, and we need to look for this. Majority, that is 2/3 of the heart, is seen on the left chest, and this is lipocardia, which is the normal position of the heart. If the heart is majority located in the right chest, then we are looking at a dextrocardia. Now, if we have a case of dextrocardia, the next thing that we need to do is to look for the position of the cardiac apex. So if the apex is directed towards the right, that is a dextroversion, which is most likely secondary to a cardiac anomaly. While if the heart is in the right chest, but the apex is still pointing towards the left, I'm looking at a dextro position, which is mostly due to an extracardiac cause, like you have a congenital diaphragmatic hernia or a large left pleural effusion, which could be shifting the heart towards the right, but the apex will still be towards the left. The heart occupies 1/3 of the thoracic area, with the cardiothoracic circumference remaining fairly constant between 0.45 to 0.5. An abnormal cardiothoracic ratio will happen due to a fetal cardiomegaly, which could be secondary to cardiac cause like a valvular dysplasia, like an Epstein's or a AVSD, which was causing a hollow systolic tricuspid regurgitation. Extracardiac causes, which could lead to high output states like a vein of Galen or a large placental chorangioma, could also lead to an abnormal cardiothoracic ratio. We know that fetuses of diabetic mothers have large ventricular wall hypertrophy, leading to an abnormal cardiothoracic ratio. To note, there is no cardiac condition where the heart is intrinsically small. This happens secondary to extrinsic compression, where the lungs may be massively enlarged, like in a chaos syndrome. The most important view for evaluation of the fetal heart is the 4-chamber view. Now, when we start, we should look at the normal size of the heart in the chest by obtaining a transverse axial section of the fetal chest. You can see one complete rib on each side. You should have the descending aorta anterior and slightly to the left of the spine. The apex of the heart should point at angle of approximately 45 degrees. We have both the atria, which should be equal in size. The AV valves can be seen with a slight apical insertion of the tricuspid valve. We have both the ventricles, which are equal in size. You can see the moderator band here, which is seen at the apex of the right ventricle. And the interventricular septum should also be intact. Coming to the atria, we can see that both the atria are approximately equal in size. You can see here the flap of the foramen ovale is opening in the left atrium. The flap of the foramen ovale is embryologically related to the septum primum. So in some conditions where you may not be able to adequately visualize the atrial septum primum, that could happen secondary to massive enlargement of the coronary vein, which could be secondary to a persistent left SVC. So here you may not be able to visualize the atrial septum primum adequately. In these cases, the flap of the foramen ovale acts as a surrogate marker for the atrial septum primum. So when you see the flap, you are reassured that the septum primum is present. You can also see the pulmonary veins opening in the left atrium. So at the 4-chamber view level, the 2 inferior pulmonary veins are opening into the left atrium, and hence the border of the left atrium is relatively a straight line. Both the ventricles are also approximately equal in size. The left ventricle may appear slightly larger because of the moderator band, which is present at the apex of the right ventricle. The interventricular septum should be intact, and this is better assessed on a lateral 4-chamber view. Yeah, you can see in this video the 4-chamber view, an apical 4-chamber view, where both the atria are approximately equal in size. You can see the flap of the foramen ovale here opening in the left atrium. You can see the free motion and free opening of both the AV valves, with the tricuspid valve inserted slightly more towards the apex than the mitral valve. Both the ventricles are also equal in size. You can see the moderator band here, which is at the apex of the right ventricle. Next important thing is the chamber lateralization. That is, we need to identify the morphology of each chamber, because abnormalities of cardiac position, as happen in transposition anomalies, need to be picked up. So the right atrium is anteriorly located. It has a posterior portion which is smooth. The anterior one may be slightly trabeculated. The important thing to see here is on a sagittal view, you can see the opening of the superior and inferior vena cava into the right atrium. This view, the bicaval view, also allows you to look for the right atrial appendage. The right atrial appendage is seen anteriorly, and it is more broad or pyramidal in shape as compared to the left atrial appendage, which is narrow and may not be always well visualized. The right ventricle is the most anterior chamber of the fetal heart. It is located immediately behind the sternum. You can see, as I discussed, the moderator band at the apex of the right ventricle, and this is the morphological hallmark of the right ventricle. The tricuspid valve, which separates the right atrium and right ventricle, it has a more apical insertion. It is more closer to the apex as compared to the mitral valve. This differential insertion is what is called as the offset of the AV valves, and this is very important for ruling out an AVSD. So if you have an AVSD, both these valves will have a more linear, they will be in a straight line, so that will be a linear insertion. And so this differential insertion has to be looked for. The right ventricle has a feature in that the chordae tendineae insert right up to the right ventricular apex, which is better seen on a lateral four-chamber view, as I shall show you later. The left atrium is the most posterior cardiac chamber, just anterior to the spine and the descending aorta. It has 4 pulmonary veins opening in it. The 2 inferior ones are situated at the level of the four-chamber view. The pulmonary veins are important because they tether the heart to the posterior mediastinum. And that is the reason the posterior border of the left atrium is more or less a straight line. If this tether is lost, like in venous abnormalities, like a TAPVC, the heart will be shifted more anteriorly. The left atrial appendage is very narrow, and we may not be able to always visualize it well. The coronary sinus is located in the posterior part of the left atrioventricular groove. You can see it as 2 parallel lines opening in the right atrium. Normally, it is very small, between 1 to 3 mm. It can get dilated in venous abnormalities like abnormal drainage of the pulmonary veins, or abnormal drainage of the ductus, or a persistent left SVC, which is draining into the right atrium via the coronary sinus. The left ventricle is crescent shaped, seen posterior to the right ventricle, and it forms the apex of the heart. It has relatively smooth walls as compared to the right ventricle, which is more trabeculated. We have the mitral valve separating the left atrium and ventricle, and which is situated more higher than the tricuspid valve, giving the differential offset. There is no moderator band here. And you can see here, both the ventricles should be equal in size. The left ventricle may appear slightly larger because of the moderator band. You can see it forming the apex of the heart. We have the moderator band here at the RV apex with a differential insertion of both the valves. We need to look for in the lateral four-chamber view, you can see that the chordae tendineae in the right ventricle are going right up to the RV apex. And so this will not be seen in the left ventricle. In the left ventricle, the chordae tendineae insert via the papillary muscles into the lateral wall of the left ventricle. This is a differentiating feature between the 2 ventricles that we need to note. Here you can see beautifully the offset of the AV valves. The tricuspid valve has a more apical insertion as compared to the mitral valve. Very important to rule out AVSDs, as I mentioned. You should be able to see the free opening and the free movement of the AV valves throughout the cardiac cycle, where your cine loop feature will help you. Same applies to the semilunar valves. You should see the free opening of both the semilunar valves, the blinking of the valves, which indicates their the free opening and closure of these semilunar valves has to be seen, because an absence of free opening and closure is a pointer towards a valvular dysplasia or a valvular aplasia, which we need to look for. The interventricular septum is best seen on a lateral four-chamber view. It is slightly thicker at the apex and more muscular here, and it thins out as we come towards the AV valves. A defect in the inlet septum at the level of the AV valves is associated with chromosomal abnormalities. A defect in the muscular part of the septum can be left alone because it may undergo spontaneous closure. A perimembranous septal defect under the origin of the ascending aorta is associated with aortic override. And an outlet septal defect is generally under the opening of the pulmonary artery. So the interatrial septum is formed from the septum primum and the septum secundum. The foramen ovale is a gap in the septum secundum, while the flap of the foramen ovale is embryologically related to the septum primum. So the ASDs that we can diagnose in fetal life are generally only the septum primum ASDs. We cannot diagnose septum secundum ASDs in fetal life. The flap of the foramen ovale can be seen opening into the left atrium, because the DV gets the blood to the right atrium and it is pushed into the left atrium. So the flap will be seen opening into the left atrium here. The crux of the heart, the crux of the heart is, really the heart of the matter. It is the area where the lower part of the atrial septal tissue, that is the atrial septum primum, is meeting with the upper part of the interventricular septum at a site where both the tricuspid and mitral valves are inserting in a differential insertion. So here you have the lower part, the atrial septum primum, meeting with the interventricular septum, where you have both the AV valves also inserting. This is very important because an intact crux essentially rules out partial or a complete AVSD. We need to document this in every 4-chamber section that we are acquiring when we are doing a cardiac scan. Now, great arteries crisscross each other as they exit from the ventricles because of the morphological arrangement of the outflows. So when we are looking at the great arteries, we need to look for the aorta, the pulmonary artery, the branches, that is right and left pulmonary artery, the aortic and the ductal arch, their respective semilunar walls. We also need to look for their ventricular connections, the sizes, the patency of the vessels, the flow velocity and the flow direction. We need to also emphasize the relative positions of these great arteries in relation to each other and also in relation to the trachea. So the main pulmonary artery immediately after it arises from the right ventricle branches into the right and left pulmonary artery. This is an important feature to differentiate it from the ascending aorta. The ascending aorta arises from the left ventricle, and in an axial section, it will be always to the right of the pulmonary artery. It then continues as the aortic arch and gives off the neck vessels, coursing further as the descending thoracic aorta and the abdominal aorta. So now we need a method where we can evaluate all the structures of the heart in various scanning planes in relation to each other. So the various scanning planes that we have in our armamentarium include the 4-chamber view, the left ventricular outflow view, which is also the 5-chamber view. We have the right ventricular outflow view, the 3-vessel and the 3-vessel trachea view, the views of the aortic and ductal arches, and finally we have the bicaval view, which is the view of the superior and inferior vena cava. The 4-chamber view is obtained by transverse axial section of the chest, going slightly cephalad from this view towards the fetal head. You will get the 3-vessel and the 3-vessel trachea view. And sequential tilting of the transducers will help you to elongate and get the views of the left and right ventricular outflow tracts. So we need a combination of axial, sagittal, and oblique views for detailed and complete evaluation of the fetal heart. The 4-chamber view is tells you about the inlet of the heart. So it is a transverse axial section of the fetal chest. You can see one complete rib on each side of the fetal chest wall, which is generally obtained at the level of the 4th rib. You have the 2 pulmonary veins opening along the posterior wall of the left atrium. And so there are different ways. So various ways to get a 4-chamber view. You can have an apical, a basal, or a lateral 4-chamber view. Of these, the apical 4-chamber view is the most important because it helps you to get a detail of, and it's the best way to depict the fetal anatomy and the symmetry of the chambers. The lateral 4-chamber view is best for visualization of the interventricular septum, the foramen ovale flap, and also the septum primum, because the ultrasound beam is parallel to the septum in this plane. The basal 4-chamber view is generally not preferred. However, if there is a restriction of mobility or the fetal position is unfavorable persistently, then we can use it to get an overview of the symmetry and basic anatomy of the chambers. Going through a checklist for the 4-chamber view, these are the things that we have to see when we obtain a 4-chamber view. The heart should occupy around 1/3 of the thoracic cavity with its apex directed towards the left, with the septum making an angle of 45 degrees. You have the descending aorta located anterior and slightly to the left of the spine. You have 4 chambers. You have the 2 atria, which are approximately equal in size. The ventricles are also equal in size. You have the free opening of the AV valves, with the tricuspid valve having a more apical insertion on the at the crux than the mitral valve. You can see the moderator band located at the apex of the right ventricle. An intact interventricular septum right from the crux up to the apex has to be seen. The 2 ventricles are contracting, that is opening and closing equally. And lastly, as I discussed, the flap of the foramen ovale should be opening in the left atrium. Usage of color flow settings can help you to see the chamber filling. complete filling of the chambers is important because it tells you about the normal functioning of the AV valves. So if the AV valves are restricted, then the chamber filling will be inadequate and incomplete. So color flow helps you to assess the proper filling of the chambers as well as the flow direction going from the atria to the ventricles. The most neglected area is actually the area behind the heart. So when you obtain a 4-chamber view, the only vessel that you should see behind the left atrium and anterior to the spine should be the descending thoracic aorta. Sometimes you may have an additional vessel that you can see here, which could be a dilated azygous vein in cases of an interrupted IVC. Another important thing to note is the distance between the posterior wall of the left atrium and the anterior wall of the and the descending aorta. So normally this distance should not be more than 4 mm. But sometimes, as I had mentioned, that the pulmonary veins are important because they tether the heart to the posterior mediastinum. So if this support is lost, like in a cardiac type of TAPVC, the left atrium will be shifted anteriorly and this distance will increase. Some masses like some ecogenic masses or a CPAM, which is maybe insinuating into this space, will also cause an increase in this distance. The left ventricular outflow tract, that is the ascending aorta, arises from the center of the heart from the left ventricle. And the two important things that we need to see here is that the anterior wall of the left LVOT should be continuous with the interventricular septum. And the posterior wall of the LVOT should be continuous with the anterior leaflet of the mitral valve. This is important because this continuity this septo-aortic continuity may be lost in cases of an aortic override. So if I make a line between the interventricular septum and the anterior wall of the LVOT, there should always be an obtuse angle, and this will be lost in cases of an aortic override. So in cases of aortic override, this line will be almost a straight line. So an obtuse angle between these two structures essentially helps to rule out an aortic override. The posterior wall should have a continuity, that is a fibrous continuity with the anterior leaflet of the mitral valve. The right ventricular outflow tract, that is the pulmonary artery, arises from the right ventricle and immediately bifurcates into its right and left branches, with the left branch continuing posteriorly as the ductus arteriosus. Here you can see the left branch is having a more or less a straight course and continuing as the ductus arteriosus, while the right branch of the pulmonary artery is going as an oblique course and it is going behind the ascending aorta and the SVC. You can also see the free opening and closure of the pulmonary valve leaflets. The aortic arch arises from the left ventricle and it arises in the middle of the chest. So it has a more narrow shape. It is more circular as compared to the ductus arch, because the ductus arch arises from the right ventricle. We know that the right ventricle is the most anterior chamber. So the ductus arch will have a more wider course as compared to the aortic arch. Also, the aortic arch will give rise to the neck vessels, while the ductal arch has no branches. Our examination of the fetal heart will be absolutely incomplete if we do not examine the systemic and pulmonary venous connections. The best view to evaluate the systemic venous connections is the bicaval view, where in the sagittal plane, you can see the opening of the SVC and IVC in the right atrium. This has been likened to a hammock. So this is also called as the hammock view. Now, as we go cephalad from the transverse section of the 4-chamber view, we can see the 3-vessel view. It is important because you can see the 3 great arteries, that is the 3 great vessels, that is the pulmonary artery, the aorta, and the SVC in their transverse plane here. Now, the important thing that we need to look for is the position and size of these vessels. So when we go from left to right, we should always have the pulmonary artery, followed by the aorta, and then the SVC, which is the most right of all the vessels. Another important thing to look for is their size. So that also decreases from left to right, with the aorta being slightly smaller than the pulmonary artery and the SVC being slightly smaller than the aorta. Going slightly further cephalad, you will get the 3-vessel trachea view. So in this view, the vessels are not in a complete axial plane. You have the transverse, the aortic and ductal arches merging into the descending aorta, forming an acute angle between them. So they basically form a V, and this V should be to the left, always and always to the left of the trachea and the spine. So you should not see any vessel to the right of the trachea. Also, the pulmonary artery is always larger in size than is the aorta, while the SVC is the smallest. So here you can see both of them are merging into the descending aorta, forming a V here. The part of the left pulmonary artery before it opens into the aorta is the ductus arteriosus, while the part of the aorta immediately after it gives off the subclavian artery is called as the aortic isthmus. Another objective criteria, we know that the pulmonary artery should be slightly bigger than the aorta, but we have objective criteria in place for assessment of this. So the ratio between the pulmonary artery and the aorta is roughly around 1 to 1.16. Another thing you can see here is you can see this echogenic tissue of the thymus, which should be seen anterior to the great vessels in the 3-vessel view. So in the 3-vessel view, what we need to look for is the sizes of the vessels, their alignment, their arrangement, their number, because you can have, instead of 3, a 4th vessel, which could be a persistent left-sided SVC draining into the coronary sinus. We need to look for the V, which should be to the left of the trachea always. A reverse flow in these vessels. So normally the flow is directed posteriorly in both the vessels. A reverse flow could be there in cases of ductus dependent conditions. We can also have a turbulent flow in either of the vessels, secondary to some vessel narrowing. When the great arteries are exiting from the ventricles, so they are at right angles to each other. So this is the normal crisscross of the great arteries which is there. This will be lost in cases of transposition anomalies, where you will have parallel outflows. So we need to look for the parallel outflows at the origin, that is when the vessels are exiting from the ventricles. One important pointer towards parallel outflows is the presence of parallel valves. So this has to be carefully looked for to exclude transposition anomalies. Lastly, but not the least, an important structure, as I mentioned earlier, is the presence of an echogenic thymus, which is anterior to the great vessels in the 3-vessel and 3-vessel trachea view. You can see the internal mammary arteries, which are bordering the thymus, one on each side, forming the thymic box. So both the internal mammary arteries should generally have a parallel course. Why is this important? Because many conotruncal abnormalities are associated with the DiGeorge syndrome, that is associated with thymic hypoplasia. So if the size of the thymus is reduced, then you will see that these internal mammary arteries are slightly converging towards each other because of the reduced volume of the gland. And that is very important. We also have objective criteria. So you could measure the thymus to thoracic ratio in an AP. So you have the AP diameter of the thymus and compared to the thoracic diameter, that remains constant throughout pregnancy at around 0.44. And this will decrease in cases of thymic hypoplasia, which is associated with the DiGeorge syndrome. So this brings us to the end of my lecture. All the schematic diagrams in my presentation have been taken from Dr. Ravi Choi's book. Thank you so much to all for a patient listening.
Thank you, Sonia. Dr. Sonia, it's wonderful. You bring a perfect foundation to understand basics of cardiac anatomy too well. And with this, we go to the next frequently encountered topic is an abnormality in the fetal heart. So we'll be handling this systematically with the 2 most important views, the 4-chamber and the 3-vessel view. So take us to the 4-chamber view. We have Dr. Rachita Ramurthy. She is a consultant fetal radiologist from Srinivasa Scan Center in Bangalore. And I can assure you, people, she is brilliant in what she does. She is an eloquent speaker and a very knowledgeable person. A few years back, I used to call her a star on the horizon, but she's already up there and shining. And she's going to talk on the abnormalities of the fetal 4-chamber heart. Over to you, Dr. Rachita.
Thank you so much, Dr. Mohit, for including me in this wonderful program and also for that absolutely lovely introduction. I'm so blessed to have mentors like you who encourage me, and your words are so important, and thank you so much. I would like to just share my screen, and let me go full screen. Thank you, Dr. Sonia, for that wonderful talk. You've made my job so much more easy. We've seen how important the 4-chamber view is and what are the landmarks that are needed to be studied in every single case. And in this talk, we'll look at the abnormalities in the four-chamber view. And I'm going to restrict myself to the second trimester four-chamber view, because that's when we study the heart in a good amount of detail, and that's when most of our abnormalities are picked up. So we know echocardiography is a part of every single study in the mid-trimester anomaly scan. And part of this echocardiography is to look at the heart as a whole. Like Dr. Sonia said, you look at the situs, size, axis, and position of the heart, any mediastinal shift. And you also look at the interior of the heart. And in the interior of the heart, you have the different views: four-chamber view, LV outflow tract, RV outflow tract, three-vessel view, and the other oblique views if required. So four-chamber view is the most basic view, and that will give us 60 to 70% of the information that we want of the heart will be seen on the four-chamber view as well. Look at the heart as a pump as well. Look at the rate of the heartbeat, rhythm, flow velocities. If we're suspecting any structural abnormality in the outflows, especially flow velocities should be measured, and functional indices can also be measured. But on the four-chamber view, we are also interested in the sequential segmental analysis. Are the connections normal? The vessels, are they entering the right chambers, and are the right vessels leaving the correct chambers is what we need to look at. So the four-chamber view, we've seen how to obtain it. It's just an axial view, a little cephalad to the diaphragmatic plane. So you start from the abdomen. Dr. Sonia has showed us what is the normal abdominal section. And once you finish the abdomen section, you just move a little cephalad into the chest, and you get this nice four-chamber view with the cardiac apex pointing to the left, and 2/3 of the heart onto the left side, 1/3 onto the right. And we've seen all the landmarks that you're supposed to document and supposed to recognize. Always, always save a clip as well as stills of the heart, because while we're studying, of course, we're going to be studying it on a real-time movement of the heart, but always document clips as well in all the views, because anytime we have a doubt later on, maybe 3 days later, 1 month later, 2 months later, she comes back for a third trimester scan and the heart is looking different. You want to go back and look at your second trimester clips. It's so important to document at least a 3-second, 4-second clip of the four-chamber view as well as all the other outflows. So let's look at this now. This is an image I'm showing you of the four-chamber view. I'm seeing all the landmarks. The pulmonary veins are joining the left atrium. The left atrium is closest to the spine. That's the apex onto the left. This is the left of the fetus. That's the right. The head is down, spine is down. That's the right atrium and right ventricle. Is anything looking abnormal? The crux is looking normal. But this is, I've just frozen a still. As soon as I start playing the clip, what happens? There's a huge gaping hole in the crux. So never ever base diagnosis on just a still image. Study it in real time. And here you see that there is a large AVSD over there. And this is definitely not a normal heart. So let's look at the heart as a whole. There are so many abnormalities that you can pick up in the heart or in the thorax just by looking at the heart as a whole, going into the four-chamber view as such. So the heart as a whole, you need to look at the situs, size, axis, and position. You know how to identify the situs. The situs is identified always by looking at the fetal position and how the lie of the fetus is, orienting ourselves into that fetal position, deciding which is the right side of the fetus, which is the left side of the fetus, and only then checking are the stomach and the apex on the right. First, decide which side of the fetus is left, and then check is the stomach on the left, is the apex on the left. So that's an exercise we'll have to get used to. And once you have identified the situs, the abdomen section is normal, stomach on the left, and the four-chamber view is normal, cardiac apex is on the left. Then only do we look at the other features, start studying the heart as such. So this is how we do it. This is an exercise I'll take you through. It's a cephalic presentation. That means the head is down, spine is over here. And putting myself in this position with my head down and legs on top, spine over here, I know that this should be the right of the fetus, this should be the left of the fetus. And if you draw a midline across the abdomen, stomach is definitely onto the left of the fetus. And you can also see that the aorta is towards the left of the midline, and the IVC is anterior and to the right of the midline. So that's a normal abdominal situs. You move up into the 4-chamber view, the apex of the heart is on the left, and also 2/3 of the heart is on the left. So we're happy that the normal situs solitus. But what are the abnormalities we can get? You can get a situs inversus totalis, where it's a mirror image. Instead of stomach and apex on the left, you have stomach and apex on the right, liver on the left. Or you can have a normal abdominal situs with stomach on the left, but the apex will be pointing to the right, and that's called a dextrocardia, normal abdominal situs with dextrocardia. Or you can have a situs inversus with levocardia, where the abdominal situs is inverted, the liver is on the left now, but the cardiac apex remains to be on the left. So that's a situs, abdominal situs inversus with levocardia. And then you have the worst kind, where it is situs ambiguous, where the liver extends from right to left, the stomach is somewhere in the center, there's a mesocardia or the apex pointing to either one side, and such situs abnormalities will have a very, very high incidence of congenital heart defects. Starting from situs solitus to situs ambiguous, any abnormality of the situs, increasing order of incidence from left to right for the incidence of CHD. Let's look at this now. It's a cephalic presentation. Head is down, the spine is over here, and the legs are at the fundus of the uterus. So putting ourselves in this position, head down, I know that this is the right of the fetus, this is the left of the fetus. So what is happening to the situs? I can see the stomach actually is on the right of the fetus, and the apex of the heart is to the left. So this is a abdominal situs inversus with a levocardia, and then that will prompt us into a detailed study of the heart, because you know the incidence of cardiac defects will be high. So that's a situs inversus with levocardia. Let's look at this example now. That's the abdominal section. The liver is extending from side to side. The stomach is in the midline somewhere. And this is the 4-chamber view. That's the thorax. That's the midline. And you can see that it's a grossly rotated heart over here. It's completely almost transverse in position, a lot of axis deviation. So this is a situs ambiguous, means a heterotaxy. And on the abortal examination, definitely it was a right atrial isomerism, where both the lungs were the tri-lobed type. Both right and left lungs are right lung morphology. So it's a right isomerism. So of course, once you go into the detail of the heart, you will find abnormalities. We'll see a few examples of that as well. So we're done with the situs now. Coming next to the size of the heart should occupy 1/3 of the area of the thorax. And it's a subjective measurement most of the time. If any doubt, you can always objectify it, draw an outline of the heart, draw an outline of the thorax, and measure the ratio. Area ratio is always best. If it exceeds 33%, then it is a cardiomegaly. You can also have other measurements in the 4-chamber view, such as the wall thickness, the free wall thickness, and the septal thickness. Let's look at this now. That is a normal 4-chamber view. That's the area of the heart. That's the area of the thorax. Just visually, I know that it is occupying only 1/3 of the area of the heart. So I'm happy. That's a normal cardiac size. You can also do a circumference ratio, and it should be 50% or less. Look at this in contrast. I don't even need to measure it. I know that the heart area is definitely more than 1/3 of the thoracic area. It's a cardiomegaly, a global cardiomegaly, where all 4 chambers are large. And also the contractility is so poor. The walls, the myocardial walls are so weakly contracting. There's barely any pump or squeeze of the heart. So this is a dilated heart, dilated cardiomyopathy with dyskinesia of the walls. There's also free fluid. You can see pleural effusion. There is onset of hydrops in this fetus. Coming to the axis, 45 degrees plus or minus 20 degrees is the normal axis. And if there is any left axis deviation, which is more than 65 degrees from midline, you are going to be looking for outflow tract abnormalities. If there's a right axis deviation, 25 degrees or lesser, then it's more likely to have inflow tract abnormalities. And that's how you measure the axis. Draw a midline across the thorax, draw a line across the interventricular septum over here. And that angle that forms is what you measure, and it should be between 25 to 65 degrees. Let's look at this example now. That's the four-chamber view. That's the midline. This is the interventricular septum. Even subjectively, I can say that the axis is deviated to the left. Definitely, there's a left axis deviation. That's the clip showing us that the axis is deviated to the left. And what are we looking for? Outflow tract abnormalities. The rest of the heart over here on four-chamber view is looking absolutely normal. But as soon as I go into the outflow tracts, I see that there is an overriding aorta. That's the malalignment VSD. The aorta is committed to both ventricles over here. And on color, it's receiving flow from both the ventricles. So this is a classical TOF type of outflow tract abnormality, which is causing a left axis deviation on the four-chamber view. So when you start in the four-chamber view itself, you are alerted that there could be possibly problems in the outflow tracts. So it's even small subtle findings of the axis deviation should put us on our guard. Let's look at this example now. That's the right of the fetus. This is the left. This is the midline over here. That's the spine. That's the sternum. And if I draw the midline, the heart is slightly shifted in position also towards the right. And more importantly, the axis of the heart is almost coinciding with the midline. So it is a right axis deviation. There is a mesocardia here. The apex is coming to lie just below the sternum. So it's a mesocardia with a right, because of the right axis deviation. And in this case, I'm going to be worried about the inflows, but not just the inflows. I'm worried, why is there a shift over here? The shift, is it because of something inside the heart or something outside, like a volume loss on the lung? The lungs are looking normal in ecotexture on either side. So there is no congenital diaphragmatic hernia that I'm suspecting on the left here that has pushed the heart, but rather, is there a volume loss on the right side? Is the right lung small? And if I'm suspecting a smaller right lung, I know there could be a problem with the venous drainage as well. So I put on the color, and on color, we do see on a sagittal section, you're seeing an abnormal vein draining, going right down, crossing the diaphragm and draining into the IVC over there. So that's a partial anomalous venous drainage. Even though the two inferior veins over here are joining the pulmonary, left atrium normally, pulmonary veins are normally draining into the left atrium. There is another, the third abnormal pulmonary vein that's going down and draining into the IVC. So that's a partial anomalous pulmonary venous drainage, or a scimitar syndrome, where you have a right lung hyperplasia and an anomalous venous drainage. So all of this was picked up only because the axis of the heart was deviated, mesocardia was seen, and that's why we put in special efforts to see what was happening. Otherwise, this can be completely missed. Most often, partial anomalous venous drainage is not picked up in antenatally. So that's how important even these subtle changes of axis are, even though the rest of the heart looks normal. Let's look at this now. It's another example of mesocardia. The apex is almost at the sternum. There is a right axis deviation. And not only that, the heart looks compressed. The heart is not normally how you see it, is occupying 1/3 of the thorax. It looks much smaller, a tubular heart. And on either side of the heart, lungs are looking hyperechoic and tumescent. So this is a chaos, a congenital high airway obstruction sequence. If I turn the probe into coronal, you see that the lungs are actually so, there's such a mass effect that the diaphragm is inverted. The domes of the diaphragm are inverted. And because of the hyperechogenicity of the lung parenchyma, the tracheobronchial tree is so clearly delineated. That's a classical sign of a dark tracheobronchia against a bright lung background. And that's a chaos. Again, that is what is affecting the axis of the heart over here. Let's look at this example of an axis deviation now. That's the right of the fetus. This is the left. I've marked it for easy understanding. That's the spine, and this is the sternum. Again, it is a right axis deviation where the axis is almost coming to the midline, mesocardia. And coming to the interiors of the heart, the actual four-chamber view, Dr. Sonia has already told us about the landmarks, so we should be able to recognize them. So on the right of the fetus, I would expect the right ventricle, which should have the moderator band. But what's happening over here? The right-sided chamber is actually the morphological left ventricle, and the left-sided chamber is the morphological right ventricle. You can see the moderator band over here. You can see the tricuspid valve, mitral valve offset. The tricuspid valve is more apically inserted than the mitral valve. So that's a normal offset, but it is changed sides. It's on the left side now. The atrium, morphological left atrium, I identify because the veins are joining over here and the flap of the foramen is opening into the this chamber. So this is the morphological left atrium, and that is on the left. And the right atrium, morphological right atrium, is on the right. So what's happening over here is a atrioventricular discordance. The morphological right ventricle is connecting to the morphological morphological right atrium is connecting to the morphological left ventricle. Morphological left atrium is connecting to the morphological right ventricle. So atrioventricular discordance, and that is classic of a congenitally corrected transposition of great arteries. So you move on into the outflow tracts and you see that the morphological left ventricle is giving rise to the pulmonary artery, and the morphological right ventricle is giving rise to the aorta. So there is a discordance at that level as well. So ultimately, hemodynamically, it is normal, but the ventricles are changed in side, and that can be identified on the 4-chamber view itself. Coming to the last feature of the heart as a whole is the position of the heart. Normal is 2/3 to the left and 1/3 to the right. If it is a right, complete right shift of the mediastinum, then you're suspecting some abnormalities in the left hemithorax, like congenital diaphragmatic hernia, where the stomach could be up, or a large a dominant cyst of a CPAM, and the contralateral as well. If there's a gross mediastinal shift, you look at the right lung carefully, and any shift of the heart, please look at the 4-chamber view also carefully, because in a congenital diaphragmatic hernia, the possibility of a second abnormality in the heart is also high. And if there is a mesocardia, again, you know, the possibility of congenital heart defects is more, like in this scimitar syndrome, which I showed you earlier. Coming to the 4-chamber view as such, the segmental sequential segmental analysis, you look at the venous drainage, you look at the atria, look at the ventricles, and then the outflows. So out of these 8 connections, 3 of the connections are actually in the 4-chamber view itself. The 3 connections are pulmonary veins draining into the left atrium and the 2 atrioventricular valves. So 3 of the 6 connections are studied in the 4-chamber view. The rest of the landmarks, you know, Dr. Sonia has already enumerated them, and what all to look for. You have a checklist, and this should be attuned to us in our brains already. We should be so used to looking at normal hearts that anything abnormal, anything deviating from that is striking to us immediately. So that's a normal 4-chamber view. I don't think I'll go through all the things that you need to look at. This is your checklist, and always study it as a clip. Document both the stills and the clips. That's all the things that you need to look at inside the heart, all the structures that you need to see in the atria, the crux, the 2 valves, the ventricles, and the movement of the walls. As a thumb rule, these are the points that help us pick up any abnormalities. So in a normal case, the left atrium is the closest to the spine and it receives the pulmonary veins. It shows the foramen ovale flap. The right ventricle is the substernal ventricle and it shows the moderator band. The right atrium lies almost completely to the right of the midline and it receives the SVC and IVC, as we know. The left ventricular apex is, the left ventricle is what forms the apex, and it is smooth and it has no septal papillary muscle attachment. The interatrial septum shows the primum septum intact, and next you have the foramen ovale, and the foramen ovale diameter is generally the size of the ascending aortic lumen. Yeah. And the interventricular septum should be reaching up to the crux, and that will show that it is intact. So the crux should be complete. And size-wise, the right atrium and left atrium should be equal in size. Right ventricle and left ventricle should be equal in size. So these are the basic things that we need to keep in mind, and anything deviating from this should be picked up. So we know that there are 3 ways of doing the 4-chamber view, and Dr. Sonia has already said apical view is the best way to ascertain. If you're not possible, then you can do a subcostal view, but the basal view we don't really resort to study. So what are the advantages of apical versus subcostal? In an apical view, I can see the valves very well, but the interventricular septum, I am not going to really rely on this view because the beam is going to get attenuated in the septum itself, and then there can be a dropout at the crux. So the subcostal view, the lateral view, is very useful to look at the interventricular septum and the interatrial septum and to see if they are intact. Let's look at a few examples of the same. Look at this case, and this is a still I'm showing you. That's the crux of the heart. You can see that the tricuspid valve is attached a little more apically. That's the mitral valve, so that's normal. But what is this over here? Is the interventricular septum joining the crux completely? There looks like there is a gap over here. So it is an apical view. So I know there could be an artifact, a dropout artifact. So is this an actual inlet VSD, or is it just an artifact? So for this, I'll move on to the lateral view. From the apical view, I move the probe a little to the side of the fetus and try and insonate from the side so that the beam is perpendicular to the septum. And when the beam hits the septum perpendicularly, you get a nice specular reflection. And you see that it was in fact just an artifact and the septum is intact. It's going up to the crux. The primum septum is also intact. So that's just an artifact and it's not an actual VSD. So you go even more lateral, you get a very, very nice clear image of the septum, and you can see it in diastole, you can see it in systole, and this intact septum up to the foramen ovale is reassuring to tell us that there is no VSD. This is again how a VSD versus a dropout artifact we can also rule out by putting on color. A basic 4-chamber view of the heart is not complete without a color study as well. So any doubt, please put on the color. And if it is just a dropout, you see that there is no color crossing from side to side. If it is a true VSD, there will be color crossing out like in this case. So sorry, I don't know why the clips are not playing. I'll just play this in a slide view. It's not playing on the presenter view. So that's a 4-chamber view. You're seeing that there is a defect over here. So is that an artifact or is it a true VSD? Few of the features that will tell us that it's a true VSD is this edge sign. You can actually see a bright spot where that ventricular septum is ending. So it could possibly be a VSD rather than an artifact. I go on to the lateral 4-chamber view, and the gap is very well seen even in the lateral 4-chamber view. So it is definitely a VSD rather than a dropout. You put on the color and you're seeing color flow across blue and red, red and blue, back and forth across this gap. So it is a true VSD and not an artifact. Okay, so once you're done with looking at the crux, we'll come on to more features of the crux later, but I'll take you through a few of the features of the chambers. So first thing we need to study in the 4-chamber view is whether the pulmonary veins are joining the left atrium. This is the normal appearance. That's the spine. The closest chamber is the left atrium. And these are the 2 pulmonary veins joining the left atrium. And behind that, it's only the descending aorta that is seen. There is no other vessel in the area behind the heart, and the area behind the heart is not very large. It is the left atrium is quite close to the spine, and there's no space for anything more to fit over there. Let's look at this example now. That's the spine, that's the left side, this is the left atrium. The left atrium is small in size, and I'm not able to see the pulmonary veins joining the left atrium. Instead, what I'm seeing is a horizontal vein over there going across from side to side, and these are the pulmonary veins confluencing with each other to form a horizontal vein, a twig sign, and this twig is not connecting to the left atrium at all. So this I know is a total anomalous pulmonary venous drainage, and I need to see where this is actually draining into. So I go up into the 3-vessel view, and I see that there is a 4th vessel to the left of the pulmonary artery. That is the abnormal vertical vein, and you follow that vein up into the thorax, and that's the twig sign again, and you go up into the neck. This vein is actually connecting into the SVC. If I put on the color, I see that the color in this vertical vein is showing me flow away from the heart. So if it is away from the heart, I know it is a vertical vein rather than a persistent LSVC. And on color, again, I follow it up into the neck. And in the neck, you see that it is going and draining from the left into the right SVC. The flow here is away from the probe. So the vertical vein on the left side is turning and going into the right SVC. So that's a classic supracardiac type of TAPVC. So a TAPVC, you will find the abnormality in the four-chamber view itself, the twig sign, and then you follow up the vertical vein and see where it is draining. Let's look at a few right atrial abnormalities. Now, this is a four-chamber view. That's the right atrium. This is the left and left ventricle, right ventricle. Offset is normal. Right atrium is looking normal except for this band-like structure that is crossing across the lumen of the right atrium. So is it an abnormality like a partitioned right atrium, like a core triatriatum dextrum, which is very, very rare? No, this is just another normal variation, which is a very prominent eustachian valve. So whenever you're seeing this, if you turn your probe sagittally, and you see the hammock view of the outflows, you see that the normal eustachian valve, which guards the IVC opening into the right atrium, that sometimes can become very, very prominent, and that becomes like a ridge over there. On cross-section, it looks like a band in the right atrium, and it's just a prominent eustachian valve, and that doesn't cause any abnormality. It's not a defect at all. Let's look at this case now. That's the four-chamber view. In the right atrium, I'm again seeing the few vertical bands in this case. There are few septae that are running from the base of the heart up to the tricuspid valve. So what are those? Is it anything abnormal? No, this is just a remnant of the embryological development, which is called a Kyrie network. And again, it most often doesn't really cause any problems. So coming to the crux of the heart, we've already seen one example of an abnormality of the crux. I've shown you an AVSD, but why is it so important to look at the crux? This is a still of a four-chamber view, and this is how the normal crux looks. A crux is a cross. So you have one vertical limb, a horizontal limb, and this horizontal limb is formed by the two valves, the mitral on the left, a tricuspid on the right, and the vertical limb is formed by the septum primum and the interventricular septum. And these two limbs there should be no gap in any of them. And also there should be an offset. The tricuspid valve more apical than the mitral valve. So any problems in this crux will indicate any one of the limbs being abnormal. And most often, if there is a loss of offset, you are going to suspect a primum ASD, an inlet VSD, or an AVSD. And you see where the defect is and come to a conclusion based on that. If there's an exaggerated offset, the septal leaflet of the tricuspid valve even more displaced towards the apex, then you suspect an Epstein's anomaly. Let's look at a few examples of this. How do you document the crux? Always document it in a still with the valves closed. And you can also see it in the valves open, where you will see only the vertical limb. You will not see the horizontal limb. So if you want to see both the limbs, it should be with the AV valves closed. Let's look at this example now. That's a four-chamber view of the heart. I'm showing you the crux over here. And I see that there is a defect in this limb, the vertical limb on the atrial side, which is the primum septum. And in the primum septum, there is a gap that is happening over here. So is it a primum ASD? But if it is a true primum ASD, I should not be having a normal offset. But in this case, you see that there is a gap here, but the offset is maintained. If the offset is maintained, it is very, very unlikely that it is a primum ASD. A true primum ASD will lose the offset. Here, since the offset is present, I would rather think that this is an artifact because of an enlarged coronary sinus. An enlarged dilated coronary sinus is a very common finding when there is a persistent LSVC. So in the four-chamber view, if I have this doubt, if I'm rocking back and forth and I'm seeing the septum intact a little above, but then there's a gap towards the base of the heart. It is more likely that it is a coronary sinus dilated. And you go on to your 3-vessel view, and in this case, it was actually a persistent LSVC with an absent RSVC. So this persistent LSVC is going to be carrying all the flow back from the head into the heart. And definitely, when it joins the coronary sinus, that's a sagittal view showing you the vertical course of the persistent LSVC, and then bending up to the base of the heart and joining into the coronary sinus. So this coronary sinus becomes very, very dilated, and that can mimic a primum defect. Let's move on to this case now. This is a normal 4-chamber view that I'm showing you for reference, as compared to an example over here where there is an exaggerated offset. Here, the leaflet of the tricuspid valve, instead of attaching just below the mitral, is quite a lot apically displaced. There is such a large gap between the mitral and the tricuspid. So this is an exaggerated offset. And when I'm seeing this, I'm going to be suspecting Epstein's. As of now, this Epstein's is not causing any right atrial dilatation at all. That's because maybe the regurgitation is not that large. So you put on the color and you see that, yes, definitely the regurgitation is starting quite into lower down from almost the middle of the ventricular chamber into the atrium. And it's not a severely regurgitating Epstein. So that is why there's no chamber disproportion as yet, but the offset is what has led us to pick up this case. Let's look at this example now. Here you have a normal crux as compared to this, where there is definitely a primum ASD and also an inlet VSD. And more importantly, the horizontal limbs, there are no two separate valves. There is one common atrioventricular valve. So this becomes like that classic bicycle handle sign of an AVSD. And you see that there is a gaping hole in the crux. And this is a complete balanced AVSD where there's no chamber disproportion. And this inflow is going to equally go into both the chambers. So a loss of AV offset, inlet VSD, primum ASD, you know that this is an AVSD, atrioventricular septal defect. And whenever we pick up an atrioventricular septal defect, we are very, very worried about chromosomal abnormality, especially down. So it will require further investigation to see that. I showed you a very subtle case of Epstein's anomaly as compared to this case, where it is a gross enlargement of the right atrium. There is a very low down septal leaflet, and you put on the color, there is a gross regurgitation, which is causing a large right atrium. So that is a later stage of Epstein's where there is a gross anomaly. So that chamber disproportion itself will tell you that it's an Epstein's rather than the offset. I've already shown you an example of CCTGA and how the 4 chambers will differ. So I won't go through that again. And that again is a 4-chamber view where the ventricles are switched. Let's look at this case now. This is another example of a crux abnormality where the horizontal limb is what is abnormal. And you see that one side, the right-sided valve, is very, very thick and bar-like, and it's not opening at all. And you also have a VSD over here, an inlet VSD. So this is an example of a tricuspid atresia with VSD. And because of the tricuspid atresia, you see that the right ventricle is grossly small. So there is chamber disproportion. The left ventricle is much larger, right ventricle is small, and there is a limb abnormality of the crux. So that's a tricuspid atresia with VSD. Coming on to more abnormalities of the chamber size, that's normal compared to this case where I'm showing you that the left-sided ventricle is very, very small and the walls are not contracting at all. It's dyskinetic. It's more like a ball moving up and down rather than squeezing into the lumen. There's also echogenicity of the walls, thick echogenic walls. And this valve also, the mitral valve, I'm not very happy with the movement of the valves. Tricuspid valve is moving very well. You put on the color, you see that there is good flow across the tricuspid valve, but there's hardly any flow across the mitral valve. So this is a classic case of HLHS, hypoplastic left heart syndrome, that you have to pick up in the 4-chamber view itself. And when you come on to the 3-vessel view, you see that the aorta is much narrower in caliber than the pulmonary artery. You put on color, and there is a reversed fill of the aorta from the ductus arch, which is giving you a classic red appearance of the aorta rather than blue. So this is a classic HLHS. As compared to this case, where you see that's the normal again, compared to the abnormal crux over here. What's happening over here is the opposite. The left side valve is moving very well. The mitral valve is moving very well, but I'm not at all happy with the tricuspid valve movement. So there's barely any movement over here. And you see the crux is looking intact, but what's happening to the crux is rocking back and forth. The IVS, interventricular septum limb of the crux, is not staying stable like in a normal case. It's going back and forth. And this is again a sign that tells us that there could be something abnormal happening on the right side over here. And this turned out to be a pulmonary atresia with intact interventricular septum. And because of the pulmonary atresia, there's barely any movement of the tricuspid valve, because this right inflow will be restricted because the pressure difference is there. Next, coming to another abnormality in the crux over here, you can see the rhythm itself of the heart is very abnormal. Even before looking inside the heart, I know that it's not a normally contracting heart, and you need to see why. So when you look at the crux, you see a bright dot over there. So this is a calcium speck, calcified crux. And when you see a calcified crux with abnormal rhythm, you're going to be worried about heart blocks, and the cause of this heart block could be an autoimmune disease in the mother. Anti-Rho, anti-La antibodies, anti-RO, anti-LA antibody assay should be done in the mother, and that could be a cause for this abnormality in the crux. Next, coming to chamber size. We've seen various examples of chamber size abnormalities, the right atrium being large or the left atrium being very small, right ventricle being very small or the left ventricle being small. But how much of this ventricular disproportion is actually significant? We have normograms for that as well. If any time in doubt, you can measure the right ventricular end diastolic Z score and the left ventricular end diastolic diameter Z score, and see if it is fitting in the normal range for gestational age. And overall, the chamber sizes, as you're going towards the 3rd trimester, there is a propensity for a right chamber dominance. Because of the pressure difference, the right chambers usually will be larger in the 3rd trimester than in the 2nd trimester. You even have normograms for that as well. So this normal right chamber dominance in the 3rd trimester should not worry us, as long as you're looking at the outflows normally and the outflows are looking a good size. So lastly, once we are done with the entire study of the heart interior and you're going to see the entire picture, you see that there is some amount of fluid around the heart, and that's a normal pericardial layer of fluid. How much is normal? Anything less than 2 millimeters is normal, and generally normal pericardial effusion, pericardial fluid will not cross the AV groove. But if the fluid is looking much more than 2 millimeters and it is crossing the AV groove, it's encircling the entire heart, then definitely it is pericardial effusion, and you need to look at the heart in better detail, look at other features of hydrops in this case. Lastly, I'd like to take you through one of the most common things that we will be seeing in a 4-chamber view of the heart, and that is a echogenic intracardiac focus. I wanted to put in this talk even though it's not actually an abnormality, an echogenic intracardiac focus is just a marker, but it's something that we will be very, very commonly seeing in our practice. Isolated echogenic intracardiac focus with all other features of the heart being normal has no relevance to a abnormality in the heart. It is just a calcium speck in the chorda tendineae. It does not cause any hemodynamic changes to the heart. All you need to study is the rest of the fetus in detail, look for additional markers of aneuploidy, and if there are additional markers, go ahead with other tests for aneuploidy, either an invasive testing to see the chromosomes directly or an NIPT. But if there is only these calcium specks in the heart and the rest of the heart connections are normal, we're not going to be too worried at all. In this case, I did see a LV echogenic focus, and I was, as usual, not worried. It was a second trimester pickup of an LV echogenic focus. The rest of the fetus was normal. But then later, when she came back to us in the third trimester, this is what has happened. Very, very rarely, it could actually progress to a rhabdomyoma. So what I saw in the second trimester was not a simple LV echogenic focus. It was the beginning of a rhabdomyoma. And by the time of the third trimester, it's grown into a nice big rhabdomyoma over here. And once I see a rhabdomyoma in the heart, I'm worried for tuberous sclerosis. So I looked at the brain carefully, and this brain already had a few echogenic tubers. We sent her for an MRI as well, and there were tubers in the brain. So this was a case of a tuberous sclerosis. I just wanted to show you an example of a regular LV echogenic focus, but extremely rarely in the third trimester, in this case, it progressed to a rhabdomyoma. So just keep in mind, an isolated LV echogenic focus, you really need not worry about. The heart is not going to be affected. So in conclusion, a four-chamber view is the basic view of echocardiography. 60% of CHDs are picked up in this view itself. We must study the heart as a whole, and then heart as a pump, and then look inside the heart for all the four-chamber view features. Also look at the area behind the heart, that is important. Study the four-chamber view in grayscale and in color Doppler. Stills and real time should be documented. All other views will follow the four-chamber view to complete your echocardiography, the outflow tracts, the three-vessel view, three-vessel trachea view, and the aortic arch views, etc. A detailed anomaly scan should follow. If any abnormality is picked up in echocardiography, please do a detailed anomaly scan. And putting all of the findings together, that will help us decide in future for the further investigations and how to counsel these couples. Thank you very, very much for a very patient listening.
Excellent, Dr. Rachita. And as usual, the star, wonderful depiction, exquisite images. Though I should agree that, I confess that the last case was scary, but it's wonderful presentation. Your images speak for yourself, and you have a wide range of collection. Very well done. I'm sure the doctors are going to benefit from your skills.
Thank you so much. Thank you.
So we now move to the next important view to assess the cardiac abnormalities, and that's the three-vessel view. And we have Dr. Jyoti Chaubal, who's the director of Thane Ultrasound Center, who are again the pioneers of fetal radiology in the city of Mumbai and Thane. Dr. Jyoti Chaubal has done her gynecology, and then out of sheer passion has moved into fetal ultrasound. And I can assure you, she is an excellent teacher, more than an excellent teacher. She is a wonderful human being, a mother to me. She have been with them for 13 long years, and I've seen how they groom the new radiologists that come under them for training. And she's going to take us through this wonderful journey of the three-vessel view. Over to you, madam.
Share screen. Thank you, Mohit. Okay. Thank you, Mohit. Thank you so much for those kind words. Is my screen seen?
Yes, but ma'am, you need to go to the first slide.
Yeah, I will go back.
Yeah.
So I think between Sonia and Rachita, they have really made my life very easy. And I'm just going to give a few extra points apart from whatever both of them have said. As we all know, apart from four-chamber view, we need to evaluate the outflow tracts to arrive at a diagnosis of a cardiac anomalies. And obtaining the RVOT and LVOT is not technically very easy. And therefore, probably we have these surrogate views of the three-vessel view and the three-vessel trachea view. Mind you, these are not diagnostic views, but they give us a clue to an anomaly, and we need to study the heart further to arrive at a diagnosis. So what we really follow is this sweep technique. So we sweep the entire heart from the abdomen up into the 4-chamber view, the LVOT, RVOT, 3-vessel view, and the 3-vessel trachea view. The same thing can be achieved by acquiring a 3D volume on a 4-chamber view and then walking through this volume. We will get exactly the same views. So we know that the ISUOG guidelines tell us that we got to look at these 6 views to make a definite diagnosis of a cardiac anomaly. We can do the sweep technique on V mode as well as color. The advantage of adding color is that if there are any flow related anomalies, as in no flow across a particular area where the flow should have been, or there is any aliasing, is there any narrowing of flow channel, all these can be picked up when we put on color over the sweep technique. So that brings us to the 3-vessel view, and Sonia has given us a great detail about what to look for and what not, what we can pick up on these views. So coming to the 3-vessel view first, and the 3 vessels that we see is the pulmonary artery in the longitudinal section, the aorta and the superior vena cava in the transverse section. The important points to note is their location. So arrangement. The arrangement from left to right is pulmonary artery, aorta, and the SVC. We also need to look at their sizes. We know the pulmonary artery is largest, superior vena cava the smallest. And the other important point to note is their alignment. So if I were to draw a line along the anterior margins of these 3 vessels, they would all fall in the same straight line normally. Next, we go on to the 3-vessel trachea view. This view is a slightly oblique view of the superior mediastinum. And the 3 vessels that we see are the pulmonary artery continuing into the ductal arch, the transverse aortic arch, and the superior vena cava. The 2 arches converge on each other, kind of forming a V, and the apex of this V is actually nothing but the descending thoracic aorta. The T in this particular view is the trachea. The trachea has echogenic walls, so it looks very bright, and it always lies to the right of this V. So that is the normal appearance. Now, if we were to switch on color over the 3VT view, both these arches should show the same color or same direction of flow. So we have to be extremely careful when we scan this view. In case we go along the lateral aspect of this particular view, we may end up seeing different colors in both the arches, and then we may mistakenly label this as a ductus dependent lesion. In other words, if you want to pick up a ductus dependent lesion, you have to make sure that your transducer is placed in such a way that the V either points towards the transducer or points away from the transducer. Only then we will see the same color flow and we will be able to make a diagnosis of ductus dependent lesion if we see different color flows whilst we are scanning in the appropriate manner. The beauty of the 3-vessel view is that we can also see it in the first trimester. In fact, this is now a part of the regular first trimester scanning according to the new guidelines that have come up recently. The other things that we can see on this particular view is the azygos vein. We need to reduce the color scale a little bit. So you need to go on slow flows, and then we can see the azygos vein draining into the superior vena cava. Sonia has already elaborated on the thigh box. So thymus is the structure that we need to see anterior to the 3VT view. And if it is in this particular view that we can actually measure the thymus to thoracic ratio, and we know that it is constant throughout pregnancy. But if we see a ratio which is 0.25 or lesser, or if we have a situation where the 3VT view lies directly behind the sternum, then we know that we are looking at thymic hypoplasia. And thymic hypoplasia is known to be associated with chromosomal abnormalities like 22q11 deletion. Then if we have a aberrant right subclavian artery, it is this view where we will be able to visualize it. So we have a vessel arising from the apex of the V and going all the way to the right superior extremity. It goes behind the trachea into the right superior extremity, and that is an aberrant right subclavian artery. Again, this is not of much clinical significance, but it is associated with an increased risk of aneuploidy, especially 22q11 deletion. So again, doing a CVS or an amniocentesis, depending upon the gestational age of the fetus, becomes essential in this situation. So now let's go and see what can go wrong with the 3-vessel view and the 3VT view. So instead of 2 vessels, we may have 2 vessels. Instead of 3 vessels, we may have 2 vessels. Now what do we do? So this is the protocol that we follow in our center. So we try and look at the size of the visualized vessel. If that vessel is really very large and the other vessel is not seen, or if the other vessel is extremely narrow and appears to arise from the same orifice as the larger vessel, then we are looking at a common arterial trunk. Now, this common arterial trunk is something which can be picked up pretty early in pregnancy, maybe even in the first trimester or maybe around 15 weeks. So what we typically see is a 3-vessel view which shows only 2 vessels. And then we look at the 4 chambers. We have a single atrium, single AV valve, and a single ventricle. And we have a large outflow tract coming out of the single large outflow tract. Similarly, we may have a pulmonary atresia with a VSD, where again we have a 3-vessel view where the pulmonary, where the aorta is large, the pulmonary artery is really very narrow. In this particular patient, there was a reversal of flow, but there was an intact interventricular septum. Now, whenever there is pulmonary atresia with an pulmonary atresia, there is no flow going into the lungs. And as the fetus grows, we have development of MAPCAs, major aortopulmonary communicating arteries. These arteries originate from the descending thoracic aorta and they supply the lungs. So whenever we see a pulmonary atresia, it is important to go and look for these MAPCAs. Next, we come to a situation where the visualized vessel is large, but the other one is small and has a reversal of flow. This would typically happen in aortic atresia. So here we have a 3-vessel view with a very, very, very narrow aorta or poorly visualized aorta. But the important point to note is that there is a gap between the pulmonary artery and the superior vena cava. That tells us that there is something there which we are not seeing, probably because it is very small. We switch on color, we don't see much of color. And then on the 3VT view, we can see that the aortic arch is very narrow with reversal of flow. And we all know that this is hypoplastic left heart syndrome. So we go on to the other views, 4-chamber and so on, to make a diagnosis. Look at the pulmonary veins, the flap valve to give a prognosis in this case. Similarly, we may have pulmonary atresia with intact interventricular septum, and the 3-vessel view shows that there is an extremely narrow pulmonary artery, a large aorta, and there is reversal of flow in the pulmonary artery. Then we look at whether the visualized vessel is prominent and the other vessel is visualized, but it is very small. This typically happens in a case of tetralogy of Fallows. So here we have a classic three-vessel view. We have a large ectatic aorta. The superior vena cava is well seen, but the pulmonary artery is poorly visualized. We go back to the four-chamber view. It practically looks normal, except that there is a slight axis deviation. And then when we look at the LVOT, we can see that there is a VSD with a large aorta overriding this VSD. And then we search for the pulmonary artery and it is extremely narrow. So we have a large ectatic aorta. It is in this condition that the large aorta is usually pushed anteriorly and the alignment in the three-vessel view is lost. So this is again a clue which tells us that something is going wrong over here. Now, the aorta generally is in tetralogy has a typical question mark kind of an appearance because it is large and atretic. So this question mark sign is again very classical of Fallows tetralogy. That's another Fallows, and Fallows is one of the common anomalies that you see in day-to-day practice. So we need to be well versed with all its features. Next, we go on to a situation where we visualize two vessels, but the vessel is normal in size. So this is a three-vessel view with only two vessels. And what do we do in these situations? We look at the curvature of the visualized vessel. If the convexity is towards the superior vena cava, then we are probably dealing with detransposition of great arteries. So in this particular fetus, there was a VSD as well. And you can see that both great vessels are parallel to each other at the origin. And as Sonia said earlier, now this is a still, but if we had a clip, we would see that both the valves were also seen in the same plane parallel to each other. So this appearance of the aorta, where the convexity is towards the superior vena cava, is popularly labeled as the I sign. Now, if you look at this normal heart, a clip of this normal heart, the first vessel which exits the heart is the aorta, and it goes straight towards the descending thoracic aorta. On the other hand, in this particular other clip, you can see that the first vessel which exits the heart is the pulmonary artery. It's a bifurcating vessel. And the aorta arises from the anterior ventricle. It has to curve posteriorly to reach the descending aorta. And that is what results in the I sign. Now, when this I sign is seen in early pregnancy, in the first trimester, a lot of people like to call it the reverse boomerang sign. And that is because of the reverse direction of the RVOT. Normally, the RVOT would head straight towards the descending aorta, but this reversed curvature is referred to as the reverse boomerang sign. So this is one more sign that we can see very often in the first trimester, and then think about a transposition of great vessels in this patient. Now, sometimes when we see a three-vessel view like this with only two vessels, and the convexity of the visualized vessel is away from the superior vena cava, we are probably dealing with corrected transposition of great vessels. Now, here the aorta arises from the anterior ventricle, which is morphologically the RV. But the aorta needs to travel a really long distance to reach the descending aorta. And that's why we have this curvature, which is away from the superior vena cava. So a three-vessel view which shows only two vessels and which has got vessels which are normal size, it is huge. We need to look at the curvature, the convexity of the visualized vessel, and that will give us a clue. And then, of course, we need to look at the other views to see what we are looking at. Right. Next, we go on to the presence of an extra vessel on the 3VT view. This also has been shown by Rachita quite well. So we have 4 vessels on this 3-vessel view. So we have an extra vessel to the left of the pulmonary artery. And similarly, we have an extra vessel to the left of the pulmonary artery. What is the next step thing that we will do? We will switch on color. And if both the vessels show the same direction of flow, then we know that we are looking at a persistent left superior vena cava, because both the right SVC as well as the left SVC are the blood is headed towards the heart. So the direction is going to be the same. Now, to confirm that this is a persistent left superior vena cava, what we will do is we will gradually move cephalad, and in this case, the brachiocephalic vein will be absent because both the SVCs will be draining directly into the heart. Now, generally, the PLSVC drains into the coronary sinus. The coronary sinus becomes very prominent and is visualized well on the 4-chamber view. The coronary sinus, as we know, lies in the groove, in the atrioventricular groove behind the left atrium. As it becomes prominent and dilates, it may reduce the inflow into the left ventricle. And this may result in a chamber discrepancy on the 4-chamber view. We may have a smaller left ventricle. If the inflow reduces, the outflow is also going to reduce. And then we may have a relatively narrow aorta, and this might sometimes evolve into a coarctation of aorta. So whenever we see an isolated, we feel there is an isolated PLSVC, we feel that at that point of time, everything is normal. There is no chamber discrepancy. The coronary sinus is not prominent. We still need to put up this patient for a follow-up and counsel the parents about possibility of evolving coarctation of aorta. So that's another case of a PLSVC and a prominent coronary sinus. Now, this was a very interesting case where initially I thought that this was a PLSVC, but come what may, the right SVC would not pick up color. So when we looked at it in greater details, we saw that this was a case of left SVC and the right SVC was absent. And how do we confirm that? We again go cephalad, try to look at the brachiocephalic vein, and the brachiocephalic vein shows flow from right to left towards the left SVC. So we can make a diagnosis there. Now we have another 3-vessel view with 4 vessels. And we switch on color as we decided earlier, and the color flow is different. So we know that we are looking at a vertical vein. We are looking at a case of anomalous pulmonary venous connection, the supracardiac type. The vertical vein is taking blood away from the heart and draining into the superior vena cava. Therefore, we have this different color flow in both these vessels. And then, of course, we will go ahead with the 4-chamber view, make an attempt to look at the pulmonary veins and so on. And this one was a very, very interesting case where there were multiple vessels on the 3-vessel view, and we could not really figure out what we were looking at because all the other things looked absolutely normal. And then when we went on to the longitudinal view of the aorta, we saw that all the 4 great vessels were originating from the arch of aorta separately. Normally, the right subclavian artery arises from the right brachiocephalic trunk. Here, the right subclavian artery was arising directly from the arch of aorta and going into the superior extremity. So this was a quadfurcation of the aortic arch. Next, we go on to altered size of the great vessels. So here we see that the aorta is really very large in comparison to the pulmonary artery. And this was a case of critical aortic stenosis. So we switched on color. There is a narrowing at the level of the aortic valve. There is aliasing. Velocities are very high, almost 400 centimeters per second. So what are the normal velocities? Anywhere between 80 to 120 centimeters per second. So this is a case of aortic stenosis. Here the aorta was really very large, and when we go on to the LVOT view, we see that the aorta is grossly dilated, and we can see that there is an absolute regurgitation across the aortic valve. This is commonly seen in Marfan syndrome. So this wave amniocentesis was done, and this fetus had a Marfan syndrome, and then his parents were evaluated, and the father happened to have Marfan syndrome, which was absolutely asymptomatic, except that he was 6'4" in height. Next, we go on to a situation where the pulmonary artery is larger than the aorta. And this was again a case of pulmonary stenosis with aliasing at the valve and high velocities at the valve. Another situation where the pulmonary artery is really very large. And when we switch on color, we see that there is regurgitation over here. And the branch pulmonary arteries are also grossly dilated. So that's a case of absent pulmonary valve syndrome. Now remember, the pulmonary valve is always present in this case, but it is a dysplastic valve. So it is stenosed as well as regurgitant, and therefore it causes gross dilatation of the main pulmonary artery as well as the branch pulmonary arteries, and to some extent dilatation of the right ventricle as well. Now, aorta, pulmonary artery, both have gotten dilated. Why shouldn't the SVC dilate? So here we have a large SVC, and this typically happens in case of right-sided overload. So we have a generalized enlargement of the heart in this kind of a situation, and it becomes important for us to look for the cause of this enlarged heart and the right-sided overload. And in this fetus, it was because of this vein of Galen malformation. Now, whenever the vessels are small, with or without reversal of flow, and we have already looked at hypoplastic left heart syndrome, critical aortic stenosis, and in some cases of coarctation of aorta as well. Now, this particular case of coarctation was really very interesting, because we could actually take a isthmus to duct ratio, which is normally 0.8 or more. So in this case, it was almost like 0.5, close to 0.5. And the longitudinal view of the arch actually showed a shelf narrowing in the region of the aortic isthmus. Then this was, of course, loss of alignment, which we have already seen earlier. And this was a classic case of tetralogy of Fallows. Whenever there is loss of arrangement, means the left to right arrangement gets altered, this commonly happens in a case of transposition of great arteries. So you can see over here, the aorta is anterior and it is more to the left as compared to the pulmonary artery. Then coming to arch anomalies. Arch anomalies are typically seen on the three vessel view only. So normally we said that the two arches form a V, but sometimes they may form this U-shaped anomaly. What happens in this situation is that the arch of aorta goes to the right of the trachea. So the trachea, which is supposed to lie on the right of both these arches, actually ends up lying between the two arches, and we have a U-shaped anomaly. Usually, this does not have any major anatomical significance, but this is known to be associated with chromosomal anomalies like trisomy 21 and 22q11 deletion. So whenever we see this, it is important to do karyotyping of this fetus. Then we may have a double aortic arch. What happens here is that the aorta bifurcates and surrounds the trachea and the esophagus. So in this kind of situations, apart from having chromosomal anomalies, we are also worried about these causing dysphagia or causing breathing difficulties to the baby when it is born. Not only that, as we said earlier, the arch anomalies are associated with thymic hypoplasia and 22q11 deletion. So again, doing a karyotyping is very important in these cases. Now, these kind of arch anomalies can be suspected in the first trimester as well. Now, this is another arch anomaly where the entire V, instead of being to the left, that instead of being to the left of the trachea, here we have the V which is to the right of the trachea. So it is a right V, and right V sign is invariably associated with chromosomal abnormalities and structural anomalies of the heart. So it is important to look for that. We can also have an aberrant left subclavian artery in this kind of a situation. So the left subclavian artery arises from the apex of this right V and goes into the left superior extremity. And last, which is a very, very rare situation, and the pulmonary artery. And this is a
I'm sorry, ma'am, you can continue. Sorry.
Hello, ma'am.
Hello.
I'm done already. That was my last.
Yes.
Yeah.
I saw that. I'm sorry about the disturbance at the last 1 minute, but I want to thank you so much, ma'am. Thank you, because you've covered the entire pathology so well. It is really wonderful to see all of those images and all the pathologies with live videos. Thank you so much. Thank you for your time, ma'am. I'm really grateful you could attend this. And now we move, friends, to the other topic of CNS, where we again begin with the basics. And this is important because we have to understand that the brain keeps evolving all the time. So there are certain set of structures which we expected to see at the 20-week scan. And to take us through this, we have Dr. Hemangini Thakkar. Now, Dr. Hemangini is the head of department of the prestigious KEM Hospital and GS Medical College. She heads the radiology department, and then she's one of the few HODs, I would say, who's passionate about ultrasound. She has mentored many students into taking up ultrasound, fetal ultrasound, be it vascular ultrasound, and I find that quite inspiring. She has been instrumental in starting fetal radiology programs for her residents, and she is a national figure with talks in all the state as well as national conferences. So she's going to take us through sequential analysis of the fetal brain anatomy. Over to you, Dr. Hemangini.
Can you see my screen?
Not yet. Start sharing.
Yeah, I've shared it, but it comes as others has to stop sharing.
Madam, to me,
Yeah,
madam,
I'll check out.
to me, stop screen kara, madam.
Yeah, I have done already, but let me see.
तिथे शेअर स्क्रीनच्या इथे जे दाबलं ना तेच परत दाबलं तर ते स्टॉप शेअरिंग होतं.
Okay, I'll do that. So, shall I press the same again?
Yes, ma'am. Stop sharing kara.
Should I say stop share again?
Stop share, yes.
Yeah.
So now try, Hemangini.
Yeah, can you see that?
No, not yet.
Shall I say leave? Will that be easier?
Oh, yes, ma'am. Chal. Yeah.
Logged in from 2 devices, ma'am, or only 1 device?
I'm only on 1 device.
Ma'am, open your...
Hemangini, as I told you, your name is reflecting as Dr. Jyoti Chaubal.
Ma'am,
Yeah,
please start sharing your screen, ma'am. Like, click on the share screen icon.
yeah, I did that. And now my PPT is coming, so I'm screening on that.
Okay, ma'am. Just click on it and click on share screen, ma'am.
Okay.
Better, madam.
Now you can see it.
Yes, ma'am. Please make it full screen, ma'am.
One second. Yeah.
Yeah, now you can just send that. Perfect. Emmanuel, you have
Okay.
it.
Thank you so much. Thank you, Mohit, so much for such a lovely introduction and making me part of this. I would like to thank also IRI, RCRI for organizing such a series of CMEs from where I've learned maximum from on this platform. So I'll begin. My talk is going to be today CNS anatomy in the mid trimester. So why it is important to examine CNS? Why it is so important? Because we know that the most common defects are the cardiac vascular CVS defects, but the next most common CNS defects are approximately 1 to 2 per 1,000 births. Especially in the Indian subcontinent, we see open neural tube defect, that is Arnold-Chiari type 2 malformation, which is more prevalent as prevalent as trisomy 21. Hence, we should be spending enough amount of time searching for CNS anomalies when we are spending so much time doing NT scan and doing aneuploidy scan. But more than that, the prevalent is CNS defects are more prevalent, so we should be spending more time on that. Yeah, so I will normally we follow the ISO guidelines. So CNS examinations in second trimesters are done under 3 headings. First is screening examinations. Second is targeted fetal neurosonography. And third is fetal MRI. So initially, when we do the normal anomaly scan, what we do is the screening examination. After that, there are certain indications where we have to move to the targeted fetal neurosonography. We will see that indications later. And even after that, if there are certain indications where we move to fetal MRI. When we move from targeted fetal neurosonography to fetal MRI, there is increase in the number of anomalies detected by about 7 to 15%. So first we'll see what are the screening examinations. So screening examinations should, as ISO guidelines suggest, that we should do early screening examination by 15 to 16 weeks. And all effort should be made to do the CNS examination by 16 weeks, because here the bones are not completely ossified and they are thin, so we can see through and through. Brain as well as spine, both should be examined as a routine screening examination. We normally in a screening examination, what ISOC suggests is that we do the transabdominal ultrasound. They do not suggest that for a screening, we go to transvaginal mode. But however, it is suggested that we should use higher frequency transducer as much as possible. Sometimes even we have to switch to the linear transducer. For screening, mainly we use the grayscale with harmonics and speckle reduction modules which we use. Normally the 3D and the color Doppler are part of the extended fetal neurosonogram. So what are the planes which we should see for the screening neurosonogram? So they suggest that usually we see 2 axial scans, that is transventricular plane and transcerebellar plane. But when we measure the BPD, invariably, we end up seeing transthalamic plane because we measure BPDS and head circumference in the transthalamic plane. So invariably, we'll end up doing transventricular, transcerebellar, and transthalamic plane. So here we can see that this plane, this is the plane A, which is a transventricular plane. It goes through the frontal horn as well as the occipital horn. This is the plane B, which is transcerebellar plane. as suggested by the ISUOC. So it also goes through the frontal horn as well as through the cerebellum. So that's an oblique plane and not exactly the axial plane. And this plane C is your transthalamic plane, which goes through the thalamus of the brain. This will be slightly under or below the plane A, that is the transventricular plane. We have to remember that all the planes should have a cavum septum pellucidity in the anteriorly located. So all the plane, though they are all slightly oblique plane, one below the other, it is cavum septum pellucidity has to be seen in all the planes. So now here we can see that this is the transventricular plane. This is the cavum septum pellucidity. This is the lateral ventricle, and we have to be very sure that we see the medial wall of the ventricle. This highly reflecting medial wall of the lateral ventricle has to be seen. Otherwise, we have seen residents measuring the ventricular diameter from here to the sagittal, that is the falx. So the structures to be seen on the transventricular plane, of course, the falx in the midline, cavum septum pellucidum, and the lateral ventricle, the medial wall of the lateral ventricle, and the choroid plexus. Of course, we have to see that the skull is properly ossified, and we have to see the eyebolic measurements of the size of the skull. We can also see this was around 19 weeks or so, and we should see a subtle indentation of the sylvian fissure. So this is the transventricular plane. Next plane which we have to see is the transcerebellar plane. Again, as I told you, we have to see the cavum septum pellucidum. These are the frontal horns. This is the tiny slit-like third ventricular, little bit of, we see it. These are the cerebral peduncle, and as the name suggests, it is the transcerebellar plane. So this is the cerebellum. This is the right and the hemisphere of the cerebellum, and in the center, we have to see the vermis, which will be usually hyperechoic. This is the cisterna magna over here. We see some veins-like structure or the echogenic line, which is traversing from the vermis up to the occipital bone. So these are the remnant of the Blake spout cyst. This is the nuchal fold thickness, which we measure it over here. So this is the transcerebellar plane. We make it a habit to measure the transcerebellar diameter, transverse cerebellar diameter in all the patients. There has to be cavum septum pellucidum, and there has to be a cisterna magna, which we have to see. So these are the structures which we see in the transcerebellar plane. Next we see is the transthalamic plane over here. Again, the cavum septum pellucidum, which could be rectangular with AP diameter almost 1.5 times the transverse diameter. It can be triangular also, which is normal. On the either side of it is the frontal horns. We always remember that the convexity of the frontal horn has to be towards the cavum septum pellucidum and not the other way around. Concavity, if you see of the frontal horns, means if you see frontal horn like this, then we have to again suspect a corpus callosal anomaly. So always remember that the cavum septum pellucidum is lying on either side by the frontal horns. In the center, we see the falx. There is interruption of the falx, which we see it over here. On the either side, posteriorly, we see the two thalami. There is a tiny slit-like structure, which is the third ventricle. These are cerebral peduncles. And this is what we see in the transthalamic plane. We have to measure the biparietal diameter, which is from outer to inner or inner to outer or mid to mid, any way which we can measure it. And head circumference, again, all around in the mid to mid position. So these are the three main planes which you are supposed to see in the screening examinations or a basic neurosonograph. Now, what are the measurements which we are supposed to take in the basic neurosonograph? So as we all know and we are well versed with, the BPD and head circumference are the main measurements which we take. BPD by OFD, that is occipitofrontal diameter ratio, it's eyebolic, but still if you want a figure, we can take it as a 70 to 85%. dolichocephalic skull and brachycephalic skull. So dolichocephalic skull will have the BPD will be little, the ratio will be less, and the brachycephalic skull, it will be little more. Next measurement which we have to measure is the transcerebellar diameter, TCD. So as we know that it increases every week for 1 millimeter per week between 17 to 21 weeks, 14 to 21 weeks. So in less than 20 weeks, fourth ventricle usually communicates with the cisterna magna, as vermis is not completely formed. So we should never make a mistake of communicating fourth ventricle with the cisterna magna, or for that matter, any posterior fossa anomaly before 19 to 20 weeks. So according to ISOC guidelines, by 19 weeks, these vermis is formed completely and no fluid should be seen between the fourth ventricle and the cisterna magna. So we should diagnose posterior fossa anomalies only after 19 weeks, never before that, because inferior part of the vermis is formed by 19 weeks. Then we have to measure the atrial width. So atrial width remains constant in the second and the third trimester, and it should be less than 10 millimeter. In the first trimester, the 10 millimeter criteria does not apply, because if you consider that as a criteria for ventriculomegaly, it will be too large in the first trimester. So as initially suggested by the previous speakers, we have to measure the ratio of the choroid plexus circumference by the circumference of the ventricle. So those criteria are different in the first trimester, but for the second and the third trimester, it is the 10 millimeter criteria. Moderate asymmetry is normal if both the atria are less than 10 millimeter. So moderate asymmetry means if there is a difference of 1 or 2 millimeter, but however, so one is 8 millimeter, another is say 6 millimeter, still it will be considered as a normal. Another measurement which we have to take is the cisterna magna. So it is measured from the outer edge of the vermis to the inner edge of the occipital bone. So what we measure it over here is the outer edge of the vermis to the inner edge of the occipital bone. That is the measurement of the cisterna magna, and that should be less than 10 millimeter. Always remember, large cisterna magna is not as bad as the effaced or a small cisterna magna, because if the cisterna magna is not seen, or a fourth ventricle is seen as a large fourth ventricle, then we are probably dealing with an open neural tube defect. So large cisterna magna is considered more or less a normal variant, very rarely associated with any chromosomal finding. So it is not that worrisome as compared to the small cisterna magna. So what is the cavum septi pellucidum? So it is considered CSP, it is seen between 20th to 37 weeks. Many times we see postnatally in the child's CT scan also the CSP which is in the center. Maybe it is a preterm child, or sometimes even in term child we do see CSP. What are the absence of CSP? As we know, the CSP, it is anteroposteriorly 1.5 times compared to the laterally or the width of the CSP and the length of the CSP. So when it is thick CSP, it again is associated with the corpus callosal anomalies like a dysgenesis of corpus callosum or thin corpus callosum, while absence of CSP is associated with many conditions like complete agenesis of corpus callosum, hydrocephalus or ventriculomegaly, holoprosencephaly, septo-optic dysplasia, or isolated CSP absence. So as I told you initially, that in all the sections in the screening, we have to see the CSP, and eyebolic, we need not measure it, but eyebolic, we have to see that it is more anteroposterior as compared to side, as opposite to the fourth ventricle. When we see the fourth ventricle, it is more wider as compared to the length of the fourth ventricle. So ventricular measurement, where do we measure it? Normally it is measured where there is a parieto-occipital sulcus. So this is the parieto-occipital sulcus which appears by 20th week. So if we are measuring it before 20th week, then it is roughly corresponds with where the choroid plexus is ending. So we can take that also as the mark, as the pointer. Where do we measure it? It is measured from inner to inner, as we can see it over here, and it should be less than 10 millimeter. Okay. So now, as the ISUOC suggests that this should be, we should try to do CNS scan transabdominally only, but even at the 16 weeks. So at 16 weeks, we don't see normal, we see little different looking anatomy. So this is the 16 weeks axial scan. This is the transventricular plane. This is called as a butterfly sign, where we see the choroid plexus which are snugly fitting within the ventricular system, except the frontal horn. So frontal horn should be devoid of choroid plexus. We see the center forks. So this whole thing rules out the holoprosencephaly. This rules out ventriculomegaly if it is snugly fitting within the ventricular system. If you are seeing the fluid within the frontal horns, that means you are ruling out a sign which is called as a dry brain, as shown by Dr. Chandalula. So that you are ruling out the open neural tube defect. And of course, the ossification of the skull, entire skull, that suggests there is no acrania or anencephaly sequence. Then next, at 16 week move is the transcerebellar plane. So this is the transcerebellar plane at the 16 weeks. As we said before, the frontal horn should be devoid of the choroid plexus. These are the thalami. This is small third ventricle, and this is slightly. So this is in between the thalamus as well as the cerebellum. We are seeing the cerebellum as well as the thalamus. And these are the cerebral peduncles. And this is the cerebellum. We have to measure again the transcerebellar diameter. Okay. And this is the cisterna magna. So these two planes, or combination of second and third plane and the transventricular plane, we can see it transabdominally also, or even at 16 weeks. So this covers the screening of the brain. Now we have to screen even the spine. So spine, only one longitudinal section is enough for the screening. We have to see the cerebrovertebral junction, and we have to see the intact skin covering the spine. We have to see the subtle lordosis of the dorsal spine, and then we have to see the upturning of the sacral spine towards the skin. This upturning and the continuous skin over it rules out the open neural tube defect, which is most important. Sometimes if the spine is anterior, we can even see the spinal cord within the spinal canal with using a linear transducer. So here we can see that spine is anterior. This is the spinal cord, which is over here. This is the cauda equina, conus medullaris, sorry. This is the cauda equina, and we see the CSF fluid, which is more posteriorly as compared to anteriorly. When you see this is very important, because if the cord is tethered over here, then this fluid over here posteriorly effaces. So because there is a leakage of the fluid. So open neural tube defect will not have a fluid posteriorly more as compared to anteriorly. Because normally what happens is, if the spine is posterior, fetal is lying prone in position. So this cord, if it is not tethered, it falls anteriorly more, and there is a more CSF over here. So this suggests that this is the normal, and this conus medullaris usually ends at the L2, L3 level. How do you calculate which is L2, L2, L3? You have to go from below up. That will be easier at many times, where the obvious bulging of the this, if we see this is where the angle is getting changed. So this becomes L5, this becomes L4, L3, L2, L1. So this is how. So when there is obvious change in the angle, we consider that vertebra as a L5. So this is how we calculate it and see whether the conus is ending by L2, L3 level by at least 23, 24 weeks. So this completes the screening examination of the CNS in the second trimester. Now, what are the indications where we move from screening examination to extended neurosonogram? So if there is any suspicions of CNS or spinal malformations, if there is any family history or any previous child which has a open neural tube defect, or there is any malformation at the nuchal translucency scan, that is in the first trimester, or there is a monochorionic twin, or we are suspecting congenital intrauterine infection, all these, or any, of course, exposure to teratogens. Or sometimes in some countries, the chromosomal microarray is the first investigation which is done, and that findings comes as an abnormal, or it comes of unknown significance. Then all these will make us to do we should do the extended neurosonogram. So what do we mean by extended neurosonogram? So extended neurosonogram, here the first most important thing is we have to switch from transabdominal to transvaginal scan. That is the must, and we should never compromise on our technique. So even if the ISUOC suggests that even if there is a breech presentation, then you wait either so that the fetus moves, or you do some gentle manipulation to see that it becomes a cephalic presentation. Even if we don't do this gentle manipulation, but if there is we can see it patient after 1 or 2 hours, it will definitely move. Then what are the planes which we have to see? So besides the 3 axial plane, which we saw in the screening sonogram, we have to see the fetus in the 4 coronal planes also, and 3 sagittal planes. Among the 3 sagittal planes, 1 is mid-sagittal and 2 are on either side the parasagittal. We have to see the spine in the longitudinal sections as we saw it in the screening neurosonogram, but also we have to see axial scans at each level of the spine. That is 1 cervical, 1 dorsal, and lumbar and sacral. Use high frequency linear transducer as much as possible. We can use 3D also if 2D is not giving us enough sagittal or coronal views, and we use color Doppler as well as slow flow imaging if it is available on your machine. So these are the extended neurosonogram. So the way it is different from the screening, I repeat again, move to transvaginal. We have to see coronal and sagittal views. We have to see axial spine views, at least 1 at each level. We can move to 3D as well as color Doppler. So these are the coronal. Now we have talked about the axial sections. Now I'll just talk about the coronal sections. So these are the 4 coronal sections. One goes in front of the lateral ventricle. So you won't see over here the frontal horns. Another coronal section is just at the level of the frontal horns. Third coronal section is at the level of the thalamus. Here, this is the thalamus. So this is at the level of the thalamus. And the 4th coronal section will be through the cerebellum, through here. So we'll see each section. So in first coronal section, which is in front of the lateral ventricle, basically we see the falx, which is in the midline, and it is because in front of the corpus callosum also it is not interrupted. So over here we see the non-interrupted falx cerebri, which rules out the holoprosencephaly spectrum. These are the upper wall of the orbits, and yeah. So now after 26 weeks, we see this is the olfactory sulcus. So these are sulcus which we see it in coronal sections. This sulcus is seen only after 26 weeks. Then the next section which we take is through the head of the caudate nucleus. So here we see it, unlike the first sections, this is interrupted over here, the falx, and we see the horizontal hypoechoic structure, which is the genu of the corpus callosum. We should see the cavum septum pellucidum, and these are the true frontal horns. This is the area of the head of the caudate nucleus. Okay, so this is what we see in the second coronal sections. On the either side, which we see is the sylvian fissure with a subtle subtle indentation if it is earlier than 20 weeks. By seeing the coronal sections, the drawback in axial section where we were not seeing the near-filled ventricle and near-filled brain, that we can see it in the coronal section. Now, this is the third coronal sections, which will be through the thalami. So again, FARCs, which we see, genu of the corpus callosum. These are the cingulate sulcus. This is the frontal horns, cavum septum pellucidum. These are the thalami on the either side. Now, this is slightly a bigger fetus, so which we see over here, it is nicely acutely angled sylvian fissure. So this, as it progresses, the sylvian fissure development, we start seeing the acute angulation of the sylvian fissure, and by 26 weeks, it becomes completely fused. That is, this leaflet and this leaflet fused as a single line over here like this, and then the insula which is formed over here. So this is the normal development of the sylvian fissure, which we are supposed to see in coronal as well as in axial sections. This is the areas which is suprasellar area where we see the circle of Willis. Then the next coronal section is through the cerebellum. So again, we see this is the atria of the lateral ventricle. Behind this, that means still posteriorly, if we go, we see the occipital horn. The choroid plexus should end at the atria and it should not go into the occipital horn. So we have to remember that choroid plexus is never seen in frontal horn and in the occipital horn. If you see some areas like hyperechoic areas like choroid plexus within the frontal or the occipital horn, it is not the choroid plexus, but it is most likely a blood clot in the ventricles. Then since this plane is through the cerebellum, we see the cerebellum, which is nicely over here. As I told you, this is the fourth ventricle, which is horizontally placed more as compared to the anteroposteriorly placed in the axial as well as in the coronal. So this is the 4 coronal planes as we saw in the extended neurosonogram. Then the next which we have to see is the sagittal plane. So there are 3 sagittal planes. One is mid-sagittal, and the 2 parasagittal on either side. So this is the sagittal plane. Here we see nicely the corpus callosum, which is hypoechoic. This is, so we see out of here the sub amount of sylvian fissure is coming up, and we see the vermis over here, which is not so well seen. So I will tell you why it is like this. Now this is the parasagittal section. Here we see the frontal horns. This is the atria of the ventricle. This is the occipital horn. This will be over here, the temporal horn. And so this is what we see on the parasagittal sections. Now, if in the first mid-sagittal section, we were seeing it from the anterior fontanel. So we could see very well the corpus callosum. But if we move our probe from here to the posterior fontanel and we try to see in the mid-sagittal, then we see the vermis over here very well. So that is what we see it over here. This we have moved our transducer from frontal to the posterior, anterior to the posterior fontanel, and we see this is the vermis over here, very nicely defined. This is the 4th ventricle, vestigium of the 4th ventricle, cisterna magna. This is your tentorium cerebelli. Okay, and this partly you are seeing of the sylvian fissure. So if we want to see the anterior midline sagittal section, then we have to keep our transducer such a way so that we insonate through the anterior fontanel. If we want to see more of a vermis and the posterior fossa, then we move our transducer in the posterior mid-sagittal suture in the posterior fontanel so that we see the vermis better. So this is the one sagittal, mid-sagittal and 2 parasagittal sections. Now the spine. So as I showed you before, we have to see the gentle upturning. Try to use, if spine is anterior, use the linear transducer, see the conus medullaris, and then we have to see axial sections through each, at least each vertebrae. So this is the cervical vertebrae, this is the spinal cord, this is the central canal of the spinal cord, this is the vertebral body over here, and this is the dorsal vertebrae, dorsal spinal canal, lumbar spinal canal, and the sacral spinal canal. So this finishes our targeted neurosonogram in the with the 2D ultrasound. Now, many times we cannot see sagittal as well as coronal sections in the targeted neuroscram, even transvaginally. So that is where we move to the 3D ultrasound. So when we move to the 3D ultrasound, this is where how we see the 3D ultrasound over here. So here we see the cavum septum pellucidum, frontal horns, interrupted falx over here by the J2. This is the sagittal 3D ultrasound of the brain, where this is the cavum septum pellucidum, which is continuous with the cavum vergae, the entire length of the corpus callosum. And this is the axial sections of the brain, same structures which we are seeing, that is the cavum septum pellucidum and the fourth ventricle. So after that, if your spine is not, we are not able to see, or we see some abnormality or abnormal curvature of the spine, we can move to the 3D ultrasound. There 3D ultrasound is usually used for a coronal plane, where we see in the center, if we see only one hyperechoic center like this, that means we are seeing the vertebral bodies over here. If we see two on either side, that means our section is slightly posterior, coronal but slightly posterior, and we are seeing the two laminae of each vertebral body. And we can also see the ribs over here. And if our sections are slightly in between, that is body and the laminae or the posterior elements, we see all the combination of this and this. So we see in the center the vertebral bodies, and we see also the laminae as well as the ribs. So these 3D sections are more important if you are seeing any butterfly vertebrae or hemivertebrae you want to see, then these 3D does help a lot. So this completes our targeted neurosonogram, and thank you very much for this.
Thank you, Hemangini. Thank you for sparing out the time and covering the entire CNS so comprehensively. I'm sure the systematic way that you've explained will help the residents and the young doctors practice neurosonography in all the scans that they practice. Now coming to the crux of CNS or the midline CNS anomalies. Now, because, we have certain very often subtle markers and signs that can be picked up, and as well that we understand that midline anomalies cannot be missed because they have long-term consequences. And to cover this, we have our own Dr. TLN Praveen sir. He is probably the senior most radiologist and practitioner of fetal ultrasound. He is the past president of Society of Fetal Medicine India. He has guided and taught many students as well as consultants pan-India in his long career of so many decades teaching fetal ultrasound. He's a true master of fetal ultrasound as well as gynae ultrasound and radiology. And it's his humbleness that he treats me as a friend in spite of being so senior in this field. And I welcome him to give his talk on the midline CNS anomalies. Welcome, sir. Thank you for waiting so long. I know it's a Sunday. You're a busy man, but thank you so much, sir.
And thank you very much, Mohit. It was wonderful. And then thank you very much for introducing such kind words about me. And the only thing is you are projected as if I am a very old man. Anyway.
Sorry.
Okay. I'm sure the delegates are all hungry. It's already 1:30, past 1:30. And then anyway, this is one of the most important aspects of fetal neurosonography, which helps us in evaluating various midline abnormalities. When we talk about midline abnormalities, it is essential to try and comply it with the anterior and posterior complex, and that is what is going to be used in evaluating various midline abnormalities. Now, when we try to evaluate the midline abnormalities, the basic concept is that we try to use the basic sections which have been very nicely demonstrated by Dr. Hemangani, and has dealt in detail regarding the various anatomical structures that you need to see. And basically, in these things, the most important thing is the transventricular and transthalamic planes. These two planes are the axial planes or the transverse sections of the fetal head or the fetal brain. And this, we can call them as magic planes, or you can even call them as Janta planes, because this is quite often, this is what we start off evaluating the fetal brain. Now, when you go into the joint practice guidelines, which have been laid down by various associations, it has been suggested very clearly that identification and evaluation of CSP is the most essential part of the second trimester brain examination. That is one. The midline abnormalities can be suspected on the basic view, that is the transventricular as well as the transthalamic sections, and then you confirm these diagnoses, the diagnosis which has been suspected in these basic views, with an extended neurosonography, such as the sagittal sections as well as the kernel sections, which has been very, very clearly delineated by Dr. Hemangani. Now, coming to the kernel transthalamic and transcaudate planes, are extremely useful in evaluating the anterior complex as well as the kernel transverse and cerebellar sections are useful in evaluating the posterior complex. So the anterior complex can be evaluated basically or suspected a midline abnormality, basically taking into consideration the axial sections of the fetal brain as well as the kernel sections. But then they are confirmed by doing a mid-sagittal plane, which will directly give you an impression of the midline structures such as the CSP, corpus callosum, brainstem, as well as the vernix. So this is the basic concept that we need to understand before we go and deal with the midline abnormalities. Now, as I have already made it very clear, that evaluation of midline structures is basically done depending on the evaluation of the anterior and posterior complexes of the fetal brain. And this helps us in evaluating various midline abnormalities, as well as off midline abnormalities such as the malformations of the cortical development and the peri and intraventricular hemorrhages. As I'm limiting myself to the midline abnormalities, I'm not going to talk to you of off midline abnormalities because it takes a lot of time. So we will limit ourselves to the midline abnormalities. Now, let us have a clear idea about what is this anterior complex and the posterior complex. When we talk about the anterior complex, we have certain components which constitute the anterior complex. What are those components? The components are the interhemispheric fissure, and then we have the callosal sulcus, that echogenic area which forms the T, or the anchor is the callosal sulcus, and then we have the hypoechoic area, which is actually the genu of the corpus callosum. Then we have this rectangular or triangular cavum septum pellucidum, and we have this comma-shaped anterior horns of the lateral ventricles. All these things put together form the anterior complex. Now, let us try to understand about the posterior complex. Posterior complex, again, is similarly constituted by the splenium of the corpus callosum. Then we have the callosal sulcus, because as you know, the corpus callosum is entirely covered by the callosal sulcus, which is a pile reflection, so it is usually echogenic. Then we have the splenium, which is hypoechoic, that is the posterior most aspect of the corpus callosum. Then we have the interhemispheric fissure, which is seen very clearly delineated. Then we have on either side of the interhemispheric fissure triangular parieto-occipital sulcus, and then the medial walls of the lateral ventricles can also be evaluated. These things all put together are called as the posterior complex. Now, we have a basic concept of the midline structures, which are the things that we are going to evaluate, and based on their abnormalities, we try to identify the abnormalities. So what are the aberrations that you can expect as far as the anterior complex and the posterior complex are concerned? Now, we know that one of the most common important component of anterior and posterior complexes are the interhemispheric fissure. It is actually a linear in configuration, extending right from the frontal region to the occipital region. And whenever there is an abnormality which causes aberration of the interhemispheric fissure, it causes distortion that is, it loses its linear configuration. It becomes widened, that is because it gets separated. So these are the two things that you would like to look for whenever you try to evaluate the aberrations in the anterior and posterior complex as far as the interhemispheric fissure is concerned. Then comes the callosal sulcus. I've shown you the callosal sulcus, which is an echogenic area. And because it is the pyral reflection, and it forms a T-shaped or an anchor shape with the interhemispheric fissure as far as the anterior complex is concerned. And whenever there is an abnormality, when there is a deviation, it is called as the distorted callosal sulcus. That is 2. 3, we have the genu of the corpus callosum in the anterior complex, then the splenium of the corpus callosum in the posterior complex. We call it as abnormal whenever we can't make them out, or whenever it is thin, or whenever it is thick. These are the factors that we have to keep in mind, identifying the aberrations in these structures. Then comes the anterior horns of the lateral ventricles. They are usually comma-shaped or triangular in shape. The loss of comma or triangular shape, that is called as the distorted or dysmorphic frontal horns, are the ones which are very, very important, which tells us that there is something wrong with the midline structures, or midline abnormalities are there. And this also can acquire a quadrangular shape. That is 3. Then comes the posterior parieto-occipital sulcus, or the parieto-occipital fissure, which is actually triangular. And this is the point where we try to measure the lateral ventricles, cutting through the glomus of the choroid plexus. And loss of this triangular shape is always determined as a overdeveloped or underdeveloped posterior parieto-occipital sulcus. Then comes the lateral ventricle, which are fused. That is, the medial walls are not delineated clearly, but they are fused together. So these are all the various aberrations that we expect as far as the anterior and posterior complexes are concerned. Now, a few words about the development of the fetal brain. As we all know, the fetal brain develops from 3 primary vesicles. They are the prosencephaly, mesencephalon, and then the rhombencephalon. The formation and the cleavage of the midline development of prosencephalon occurs by about 4 to 10 weeks of gestation. Whenever there is a failure of formation of the prosencephalon, this results in what is called as eprosencephalon or etelencephalon, which is very, very rare condition. And this is basically intense, or it indicates that there is absence of forebrain. That is one aspect of it. Now, coming to the partial or total failure of the cleavage results in a spectrum of holoprosencephaly, and abnormal midline development results in septal abnormalities, corpus callosal agenesis, and dysgenesis. So these are all the things that we have to keep in mind as far as the development of the brain is concerned. Now, let us get back to as all the societies have very specifically mentioned that the identification of cavum septum pellucidum in all 3 axial sections, that is the transventricular, transthalamic, and the transcerebellar, you need to see this sort of a box-like rectangular structure which interrupts the interhemispheric fissure anterior 1/3 to posterior 2/3. And then if you carefully see that it is actually it develops from, embryologically develops from what's called as the lamina reunions, and it occupies the total space between the anterior horns of the lateral ventricles. You can see the anterior horns of the lateral ventricles on either side skirting it. Not only that, the another important thing is that whenever you have a high resolution scanner, there you can actually see the septum pellucidum. These are the septum which you can see it. This is a double layer appearance. This is the septum. That is the lateral walls of the lateral ventricles, or the frontal horns of the lateral ventricles. So these 2 things, these are called as the septum, and this is called as the cavum. So the fluid or the box-like structure which is seen as a cavity in the midline is called as the cavum septum pellucidum. And when the posterior extension of this cavum septum pellucidum is nothing but cavum vergi, it is absolutely a normal variation. And in a still further posterior extension is called as cavum villi interpositum. So this is how we are going to identify the cavum septum pellucidum. Now, the same structure in a sagittal section, what happens is it is the space that is anterior to the foramen magnum. So how do you know? You can take the tila choroidae, the anterior aspect of the tila choroidae, that is nothing but the roof of the 3rd ventricle. If you draw a line, the line which is cutting across the cavum septum pellucidum is what is called as the foramen Monro. That is the location of the foramen Monro. And then we have the cavum septum pellucidum, which is just in front of it, and the cavum villi interpositum is the one which overhangs the posterior aspect of the tectum, or the what you call as the tila choroidae. and the cavum villi interpositum is just posterior and below this the splenium of the corpus callosum, and then the internal cerebral vein or inferior cerebral vein, internal cerebral vein goes or traverses behind the or below the cavum villi interpositum, because this is an extremely important landmark to differentiate between a normal cavum villi interpositum from a arachnoid cyst in the midline. So these are the things that we have to keep in mind. And next is the normal configuration, which has to be evaluated. See, whenever we try to evaluate the midline structures based on the cavum septum pellucidum, we need to understand the normal shapes and configuration of the anterior complex, particularly the cavum septum pellucidum. As I said, cavum septum pellucidum is usually rectangular or triangular. So any alteration in this shape indicates that there is something abnormal. Any absence of this indicates there is abnormal. The lateral frontal horns of the lateral ventricles are comma shaped, which engulf or support on either sides of the cavum septum pellucidum. They're usually comma shaped. Sometimes it can be even triangular, with the base of the triangle laterally placed. This is again an important thing. So whenever there is an alteration in these comma shaped lateral ventricles or the triangular shaped lateral ventricle with frontal horns of the lateral ventricle with the base along the lateral wall, it indicates that there is something wrong with the midline structure. So this is one thing which we have to be very, very clear and understand about the cavum septum pellucidum. Now, coming to corpus callosum and the cavum septum pellucidum. Remember, if you demonstrate a normal corpus callosum or normal cavum septum pellucidum, it is definitely associated with normal sized corpus callosum. This is one small dictum that you have to always keep in mind. Now, the length of the corpus callosum, cavum septum pellucidum, is actually directly proportional to the length of the corpus callosum. And in partial agenesis of corpus callosum, the cavum septum pellucidum will be short and distorted, because it is present. The part of the corpus callosum is present, but it is partly absent, and that is the reason why there is no absence of cavum septum pellucidum, but there is distortion of the cavum septum pellucidum. In complete agenesis, the corpus callosum will be absent. So these are the basic concepts that we need to understand as far as the midline abnormalities is concerned, because one of the commonest midline abnormalities which we come across are the agenesis of corpus callosum or partial agenesis of corpus callosum. Now, absence of cavum septum pellucidum in the presence of corpus callosum. This is an extremely important factor that you should keep in mind. So you don't see the cavum septum pellucidum, but you still see the corpus callosum, that is particularly the genu as well as the body of the corpus. That indicates that there is a septal agenesis. As I said, the corpus callosum has got two layers. One is by the medial horns, lateral horns of the frontal horns, lateral walls of the frontal horns, and the other one is by the septal. Whenever there is a septal agenesis which is associated with a spectrum of intracranial abnormalities such as the holoprosencephaly, septo-optic dysplasia, dysgenesis of corpus callosum, and schizencephaly, all these things are basically you have to keep in mind. Whenever there is a septal agenesis, you don't see the double layer. Not only that, you see a continuation between the frontal horns of both the lateral ventricles. That is how it is going to present. Now, the CSF has got such an important role to play that we need to understand the biometry of the CSF. Usually the CSF is identified from 18 weeks of gestation. So if you don't find a CSF at 14 or 15 weeks of gestation, don't get panicky and don't label it as abnormality, because quite often we see from 18 to 20 weeks of gestation, and normal size of the CSF measures between 2 to 10 millimeters in its AP diameter. Remember, I said it is a rectangular shaped structure, fluid-filled structure. So naturally, when I say rectangular shaped structure, the anterior posterior diameter will be more than the lateral to lateral diameter. This is an extremely important factor, and that is what decides the cavum septum pellucidum ratio, that is the length by width, and it is called abnormal whenever it is less than 1.5, and there are various normograms that are available to tell us at each gestational age what is it expected of. So this is basically about this one. Now let us get to the pitfalls of CSF, because I've been stressing a lot on this CSF, but then we should know that there are certain situations where we may mistake some other structure for a CSF. The most important thing, as you can see here, this is the beautifully demonstrated rectangular cavum septum pellucidum, whereas here something which is triangular, which I said that the cavum septum pellucidum can also be triangular, but then it is very much on almost to the midline. See, I said that the cavum septum pellucidum is at the junction of anterior 1/3 to posterior 2/3, whereas here it is almost at the midline. So what is it? What is the structure that is seen at the midline, which is being sandwiched by the thalami? It is the third ventricle. So in the absence of agenesis of corpus callosum, the third ventricle gets elevated, and that is what it should not be mistaken for a cavum septum pellucidum. Not only that, if your section is little below, then you will include the fornix, and this should not be confused with the cavum septum pellucidum, because the cavum septum pellucidum actually on ultrasound, it appears as 2 lines, whereas the fornix, once you include the fornix, then it appears as a 3-line structure. So these are the pitfalls that you have to keep in mind while evaluating the cavum septum pellucidum. Now, let us see what are all the abnormalities that we can come across as far as the CSP is concerned, that is cavum septum pellucidum. If it is present, is it normal or abnormal? If it is normal, I mean, it should be less than 10 millimeters. And if it is enlarged, that is more than 10 millimeters, then you need to think in terms of an isolated enlarged CSP, which could be associated with aneuploidy. That is 1. 2, it could be also be because of a CSP cyst. Now, coming to the absence of CSP, once the CSP is absent, most important thing is we need to understand whether there is any cleavage abnormality, that is incomplete separation of the cerebral hemispheres. If there is an incomplete cleavage of the cerebral hemispheres, then we need to think in terms of a spectrum of holoprosencephaly. Then if it is small, frontal horns with colpocephaly, that is the pinched frontal horns with colpocephaly, that is the dilatation of the posterior horns of the lateral ventricle. Then we think in terms of a corpus callosal agenesis. And then if the CSP is absent, but there is severe ventriculomegaly, you need to understand that this could be an acquired seizure CSP absent, which could be because of obstructive hydrocephalus, which can cause necrosis of the septae, and that results in absent CSP, or it can be because of injury, hemorrhage, cystic changes, and volume loss, hydrancephaly. These are all the causes which can result in absent CSP when there is a severe ventriculomegaly or hydrocephalus. Now, when there is absent CSP with normal frontal horns, in that situation, one has to be very, very careful that we are not going to we are dealing with a benign condition, which is called as the isolated septal agenesis, or it is a very serious condition, which is called as the septo-optic dysplasia, which is associated with hypoplastic optic nerves. So this is what we have to keep in mind while evaluating the. Now, coming to the septal agenesis, in the septal agenesis is also called as agenesis of corpus callosum or septal agenesis, absence of septum pellucidum. And in the presence of normal cleavage of the prosencephaly, changes of CSP is known as the septal agenesis. That means it can be isolated or it can be associated with other abnormalities such as the hypoplastic optic chiasma. Not only that, there can be pituitary fossa dysfunction, pituitary dysfunction also associated with it, when it is called as septo-optic dysplasia. When these two things are not there, and there is an absence of the septum, we call it as septal agenesis, and it can be isolated. So what happens in this one? We have the anterior horns which are in continuation with each other. Normally we have the septum in between, which divides the lateral walls of the frontal horns, whereas in a septal agenesis you find what is called as the butterfly wing appearance. That is one. Next is that the interhemispheric fissure as well as the corpus callosum will be normal. This is extremely important that you should see. And then the optic chiasma and the optic nerve has to be evaluated, particularly to demonstrate the posterior limbs of the optic nerves. That is very, very important. Not only that, the septal agencies can also be associated with cortical development, the developmental abnormalities such as schizencephaly, holoprosencephaly, and callosal abnormalities and facial defects. Now, counseling, when you counsel them, now on an ultrasound examination, you found that there is a septal agenesis, but then you can partly demonstrate the corpus callosum. In that situation also, before you prognosticate it as a benign condition, it is always advisable to counsel the couple, saying that there is a possibility of 20% of these cases can be associated with septo-optic dysplasia. So that is the reason why you need to give a guarded counseling for these patients. Now, this is a classical example of the butterfly wing appearance of the corpus callosum, where you don't find the septum. cavum septum, and then cavum is the cavity, septum is absent, and then you can see the continuity of both the lateral ventricles in the midline. So, but then here you can very nicely see the callosal sulcus. You can also see the corpus callosum. In the same patient sagittal section, beautifully demonstrated corpus callosum. So the corpus callosum is normal, whereas there is a continuity between the lateral horns of the frontal ventricles, which indicates that it is an isolated septal agencies. Now, the situation is that we have to positively demonstrate the posterior limbs of the optic tract. This is extremely important in order to rule out the possibility of septo-optic dysplasia. Not only that, involvement of the pituitary gland also has to be evaluated. How can we do that? We can do that by evaluating serum histiol in maternal urine or blood, so that once there is a absence of decreased serum histiol in the maternal blood and urine, it indicates that there is a pituitary gland dysfunction. And you do a 3D rendering of the optic tracts where you can see the posterior tracts very clearly. And when there is a hypoplasia of these things, then you know that you are dealing with a septo-optic dysplasia. So basically, when you demonstrate a continuity between the lateral ventricles, in that situation, even if the corpus callosum is seen clearly, it is essential that you need to do evaluation of the optic tracts as well as get the urine test done for urine or blood test done for serum histiol to rule out the possibility of septo-optic dysplasia, because even an isolated agency of septal agencies can be associated in 20% of the times with septo-optic dysplasia. That is the importance of it. Now, coming to the CSF abnormalities, acquired ASP, that is absence of septum pellucidum. Whenever there is an obstructive hydrocephalus, increased intraventricular pressure, this can result in septal necrosis, and this results in acquired absence of CSP. This is one thing which we have to always keep in mind. And it's not that always it is because of the agents of corpus callosum, but this also could be a responsible factor. Now, we have a situation where the CSP is more than 10 millimeters, which is normally is 2 to 10 millimeters. And whenever it is more than that, there are things that we have to keep in mind. One is that it could be associated with chromosomal abnormality, or it could be because of a cyst in the CSP. And this has to be, this need to be differentiated from the interhemispheric cyst, which is associated with anomalies of corpus callosum. So whenever we find there is a large CSP, associated with it, if the corpus callosum is demonstrated normally, then we need to think in terms of an isolated large CSP and evaluate them for aneuploidy, or it could be a CSP cyst. But whenever there is an associated abnormality of the corpus callosum, we need to think in terms of an interhemispheric cyst, and it is very difficult to differentiate one from the other. Now, so absent septum pellucidum, most important thing is communication with the anterior part of the lateral ventricle. Then it is a monoventricle. These are the spectrum of lobar holoprosenception that we can come across, and they can be associated with the non-cleavage of the cerebral cortex, facial abnormalities, agenesis of corpus callosum. Whereas when there is a separate anterior horns, in that situation, non-cleavage of partial parietal region, which is basal ganglion, which is nothing but the mid-interhemispheric variant of holoprosencephaly. Suppose if there is a normal cleavage with the absent septum pellucidum, in that we need to think in terms of the septal remnants. If there are septal remnants are present, then you need to think in terms of hydrocephalus. If they are absent, then you need to think in terms of a cortical abnormalities, either a schizencephaly or absent of a SOD and or an isolated ASV. So these are all the things that you have to keep in mind as far as the absent septum pellucidum is concerned. Now, we need to know when we deal with the midline abnormalities, one of the most important thing that you have to keep in mind is the corpus callosum. The two cerebral hemispheres are connected by the corpus callosum, which is the largest commissure which we come across in the fetal brain. It is also developing from the lamina reunion, which is also responsible for the development of the CSP at 10 weeks of gestation. And this CSP is a corpus callosum is made up of axonal fibers, which are packed and run from side to side, connecting both the cerebral hemispheres, and is constituted by 4 components, that is anterior to posterior. We have the rostrum, genu, body, and the splenium of the corpus callosum. The development of corpus callosum starts from the body and progresses bidirectionally. The development of corpus callosum is usually completed by about 18 to 20 weeks of gestation. So absence of corpus callosum before 18 weeks of gestation should not be given much importance, but then it has to be followed up in order to see whether there is a continuation or absence of corpus callosum even after 18 to 20 weeks of gestation. The rostrum is the last segment to develop. So this is the basic concept that we need to understand as far as the corpus callosum is concerned. Now, this is a typical example where you can do a mid-sach section where you can beautifully demonstrate the corpus callosum all along the midbrain. And this is a transvaginal grayscale imaging. It is not a 3D rendering, wherein you can beautifully demonstrate the corpus callosum. You can see the rostrum, genu, body, and the splenium of the corpus callosum very nicely demonstrated. And you can see that this is the rostrum, genu, body of the splenium, and that is the tectum or the tila choroidae, posterior aspect of the tila choroidae. So this is the normal anatomy. And then when it comes to biometry of the corpus callosum, because we need to give importance to the measurements of these structures, because when you have a subtle changes in the size of the corpus callosum, it is highly indicative of a dysgenetic corpus callosum. That is the reason why we need to know the measurements. The linear measurement is usually from the rostrum to the splenium. This is what's called as the rostrocaudal length of the corpus callosum. The thickness is measured at different sites. That is one at the genu, and the other one is at the body and the splenium. Now, there are nomogram charts that are available at each gestational age, and based on that, you can say whether the corpus callosum is normal sized or abnormal in size. Now, coming to the developmental abnormalities of corpus callosum, the most commonest things are the complete agenesis of corpus callosum. Then we have the partial agenesis of corpus callosum, and that means there is a part of the corpus callosum is absent. Now, it can also be a hypoplasia, that is normal length but thin, or it can be dysgenetic, which can be thinner or thicker, and complete and partial agenesis of corpus callosum can be secondary to ischemia as well as infection. So this is how you have to categorize the abnormalities of the corpus callosum. When you talk about the complete agenesis of corpus callosum, the anterior complex, let us take it through each one, anterior complex and the posterior complex. In the axial and the coronal views, we can beautifully demonstrate that there are certain indirect signs of complete agenesis of corpus callosum. First and foremost thing is but then this has to be confirmed by doing a sagittal section. That is very, very important. So in the agenesis of corpus callosum, CSP is absent. This is what we sort of. So in the anterior complex, the absence of CSP is one of the most important things which prompts you to think in terms of a absent corpus callosum. But if in isolated septal agenesis, CSP is absent, but the corpus callosum is normal, that we have already dealt with, then there will be what is called as the colpocephaly. That is, there will be pinching of the frontal horns, dilatation of the posterior horns or the occipital horns, which is called as the colpocephaly, or we call it as a teardrop ventricle. Not only that, the frontal horns are displaced laterally, and their shape, which is normally seen as a comma shape or a triangular shape with the base being lateral, here you have the base being medial. So this is a classical appearance of the frontal horns in the agenesis of corpus callosum. And then it can be distorted as steer horn appearance. And the third ventricle, because there is no limiting factor of the corpus callosum, the third ventricle tries to elevate itself upwards, so that what happens is you can find that there is a dilated third ventricle which is seen in the center. So these are the various indirect evidences that you find. First is that there will be a separated frontal horns. You can see both the frontal horns are separated, and then we have a third ventricle which is elevated, and then there is a widely separated cerebral hemispheres and a radiating sulci, usually the callosal sulcus. Cingulate gyrus is the one which continues all along with the cingulate gyrus as well as the callosal sulcus, because we know that callosal sulcus is the one which skirts or which envelops the corpus callosum. Whenever there is an absence, the part of the absence of corpus callosum you will find missing of the callosal sulcus. Sometimes whenever it is distorted, you find what is called as the radiating sulci. Not only that, if you do the color Doppler, wherein normally you can see that the marginal vessels, that is the pericallosal artery, the marginal branch of the pericallosal artery, should normally skirt the corpus callosum, but whereas it becomes verticalized. So that these are the various things that will prompt us to think in terms of agency of corpus callosum. Now, not only that, the changes in the anterior complex are first and foremost thing. The interhemispheric fissure is continuous. There is absence of cavum septum pellucidum. There are 3-line configuration. One is the medial aspect of one cerebral hemisphere. Then is the interhemispheric fissure. Then the other one is the other medial margin of the cerebral hemisphere. These are the 3 lines that you see. And then not only that, the callosal sulcus is not seen because there is no genu of the corpus callosum, and then the cavum septum pellucidum is absent. And then at the same time, the anterior horns are dysmorphic. So these are the features which will help us, particularly based on the anterior complex when you want to diagnose agency of corpus callosum. Now, coming to the posterior complex, what happens in the agents of corpus? Because when you say agents of corpus callosum, it means that the corpus callosum in toto is absent. So in that situation, naturally the splenium of the corpus callosum is not seen, is one. Two, the callosal sulcus is also not seen because there is no corpus callosum. Then the interhemispheric fissure is widened, as you can see here, and then you can see that the posterior parieto-occipital sulcus is underdeveloped. So, and then you have the colpocephalic, that is the dilatation of the occipital horn. So these are all the features that you can see as far as the posterior complex is concerned. Now, then comes the sagittal plane, where it confirms your diagnosis. See here, this is a true sagittal plane. When I say it's a mid-sagittal plane, I should demonstrate the corpus callosum as well as the vermis in the same plane. When I demonstrate both of them in the same plane, then only it is a mid-sagittal section. Whereas here, I can demonstrate the vermis, but I'm not able to demonstrate the corpus callosum, which directly indicates that there is an absence of the corpus callosum. And then, because of the absence of the corpus callosum, and because there is an interhemispheric fissure, there can be interhemispheric cystic areas, or even the third ventricle can be elevated up. And then you do a sagittal, in the sagittal section, when you put the color Doppler on, you can see that there is a verticalization of the marginal vessel of the marginal branch of the pericallosal artery. So these are all the various. Now, coming to the partial agenesis of corpus callosum, is little difficult to diagnose antenatally, but then there are features which are very suggestive of partial agenesis. And the commonest segment that is involved is the posterior segment, that is the splenium of the corpus callosum. And it is quite often a causative factor is the ischemia as well as the infections. Now, whenever we have a short, distorted cavum septum pellucidum, here, the length of the cavum septum pellucidum is directly related to the length of the corpus callosum, which we have already understood. Whenever it is shortened, that is AP diameter is less than 2 millimeters, or whenever there is a severe PACC, that is partial agency of corpus callosum, cavum septum pellucidum will be very small, distorted. Not only that, it is small, it is distorted. And also you can see that the length of the corpus callosum is measured from the callosal sulcus to the fornicis. So this is what is important that you need to keep in mind while measuring the corpus callosum. This is the callosal sulcus, and that is the fornicis, and this is the measurement you take as far as the CSP is concerned, where width is measured lateral to lateral in the mid portion of the cavum septum pellucidum, and the length by width ratio will be altered as far as the partial which will be less than 1.5, and the shape of it or also sometimes can be altered and becomes square shaped. Sorry, I think it's round or square shape, not rectangular. Rectangular is normal. Now, coming to the changes which can be anticipated in the anterior complex, is that the interhemispheric fissure will be normal or sometimes distorted, because depending on the segment of the corpus callosum which is involved. If this segment of the corpus callosum that is involved is genu of the corpus callosum, definitely the interhemispheric fissure will be abnormal. If it is not the genu but the splenium, then the interhemispheric fissure in the anterior half will be normal. Whereas the callosal sulcus will be normal if the genu is intact. And at the same time, the GC, that is the corpus callosum, cavum septum pellucidum will be normal if the anterior part of the corpus callosum is normal, as well as the anterior horns, that is there can be normal when the genu is there, but it can be when the genu is there, but it will be dysmorphic when the genu is absent. So whenever there is a splenium involvement, the frontal horns are intact. So these are the things that you need to take. And this is the distortion of the frontal horns that you can see, and distortion of the cavum septum pellucidum, which is beautifully seen. And you can see part of the callosal sulcus, that is the interhemispheric fissure. So it is possibly a partial callosal agenesis or corpus callosal dysgenesis, wherein either the body or the splenium is affected. So these are the factors that you have to keep in mind. Now, coming to the posterior complex, again, the splenium, if it is absent, and which is the commonest one to get involved in the partial agents of corpus callosum, if it is involved, then you don't see the splenium. As you can see here, there is no splenium. In the same way, the callosal sulcus, which skirts the posterior aspect of the corpus callosum, will also be absent. The interhemispheric fissure anteriorly will be normal, but posteriorly it will be widened, and the parieto-occipital sulcus will be underdeveloped, as well as the frontal horns or the lateral ventricles are either normal or parallel to each other. So this is how you can construe the partial agents of corpus callosum. Now, as I said, all these midline abnormalities have to be confirmed by doing a sagittal section. Here you have sagittal sections where you can see this is the posterior fossa, that is the tectum, and you can see the corpus callosum. The splenium of the corpus callosum is not seen. Here you can see that that depends on the involved segment again. So absence of corpus callosum at the splenium and posterior body, no corpus callosum overlying the tectal plate. So this is exactly what it is. You can see that the part anteriorly is seen, but nothing is seen in the posteriorly. Whenever there is an absence of the rostrum and the splenium occurs, absence of rostrum rarely, and then the cingulate gyrus and the sulci seen only up to the present. So that's the reason why you have what is called as the sunburst appearance of the sulci. So these are the various things that can tell us that there is a partial agency of corpus callosum. Now here the dysplastic corpus callosum, which can be a thin corpus callosum. Here you have a distorted cavum septum pellucidum, distorted frontal horns, and you can see a very thin strip of corpus callosum. Whereas here also you can see a very thin strip of the corpus callosum. Here you have a thick corpus callosum. If you measure the genu, body, and the splenium, you will definitely correlate it with the normograms. Then it indicates that there is definitely increased thickness, which is suggestive of a dysplastic corpus callosum. Now, sometimes you do find some sort of an echogenic areas within the corpus callosum, as you can see here. And whenever you find this sort of an echogenous areas in the corpus callosum, you need to think in terms of a lipoma of the corpus callosum. These are the various abnormalities that you find as far as the corpus callosum is concerned. The second important midline abnormality which we have to keep in mind is the holoprosencephaly. Now, whenever there is a holoprosencephaly, the prosencephalon actually develops into telencephalon and the diencephalon. The telencephalon is the one which develops into the cerebral hemispheres and the lateral ventricles, as you can see here. And then the diencephalon is the one which develops the thalami and the third ventricle. So any abnormalities in the development of prosencephalon results in various types of midline holoprosencephaly. Now, the cleavage of the prosencephalon happens at about 5 to 6 weeks of gestation. It results in 2 cerebral hemispheres, 2 basal ganglion, and on either sides of the midline. Now, total or subtotal failure of the cleavage of the prosencephalon is the one which results in uncleaved forebrain, which is resulting in holoprosencephaly. So this is what is the basic concept of holoprosencephaly. Now, let us see the commonest variety, which can be diagnosed as early as about 8 to 10 weeks of gestation. When you do a transvaginal examination, there will be a complete failure in cleavage of the frontal lobes, that is the prosencephalon. That results in absent midline structures such as the interhemispheric fissure, cavum septum pellucidum, corpus callosum, and these are the things. And then this results in what's called as the monoventricle, and then there will be fused thalama on either sides. So an uncleaved cerebellum with a monoventricle is a classical example of alobar holoprosencephaly, and these are usually associated with facial abnormalities like a cleft, cyclops, or a proboscis. So these are all the things that you have to keep in mind as far as the alobar holoprosencephaly is concerned. Now, coming to the semi-lobar and lobar holoprosencephaly, the cleavage is seen at the occipital lobes, whereas in a lobar holoprosencephaly, the cleavage is seen occipital and parietal, but parietal lobes with posterior horns of the bodies and lateral ventricles are cleaved. Lateral ventricles are cleaved, whereas the anterior part of the cerebral hemispheres or the midline cleavage does not occur. Here, sorry. Now, what happens is so because of the cleavage has occurred in the occipital lobe in semilobar holoprosencephaly, we find that the interhemispheric fissure, anterior horns of the lateral ventricles, cavum septum pellucidum, and the corpus callosum are not seen because there is the fusion of or non-cleavage of the frontal lobes or the porencephaly, and then the splenium and the corpus callosum, posterior horns of the lateral ventricle, posterior part of the interhemispheric fissure, and the posterior parieto-occipital fornices are seen. Whereas in lobar, you can see the splenium and the same way the occipital and parietal lobes of the posterior horns and the body of the lateral ventricles are cleaved, but again the anterior horns are not cleaved. Here, the splenium and the of this corpus callosum, posterior horns of the lateral, this posterior component or the posterior complex is completely seen normally, whereas the anterior complex, where the rostrum, genu, and the anterior part are not seen. So this is how you are going to differentiate one from the other. More than that, these are very, very subtle differences. Both of them are have bad prognostication as far as the neurodevelopmental abnormalities are concerned. Now, coming to the middle hemispheric variant, that is what's also known as syntencephaly, where the cleavage occurs in the frontal as well as in the parietal occipital region. There will be a parietal region which is uncleaved. This is the part where it is uncleaved. This results in cavum septum pellucidum not to be seen. Body of the lateral ventricles are continuous with each other, as you can see, they're continuous with each other. And then the interhemispheric fissure is absent in the posterior aspect of the frontal horns and the parietal region. And the parietal cortex is in continuation with the midline, and the body of the corpus callosum is absent because the midline continuity is lost, that is the cleavage is lost, and then the circle of Willis and the anterior cerebral artery have an abnormal course where you can see them just below the calvarium. So these are all the features which are highly suggestive of a middle variant of middle interhemispheric variant of holoprosencephaly. Now, hydrancephaly is again an absence or thinned of the cerebral mantle. The cranial cavity is filled with fluid, incomplete flux. You can't see the midline structures at all. There will be a lot of debris, particularly in the form of hemorrhage or a lysed cortex, and there is no flow in the. This is basically because of occlusion of the internal carotid arteries. So, with this, I would like to stop here because the malformations of the cortical development, even though they are paramidline, that is off midline abnormalities, but I would like to stop here. Sorry.
Sir, I agree. In fact, what you have covered is already too exhaustive. And I believe, cortical development getting mixed here would be too confusing or too much to take right now.
Yeah.
But thank you so much. You have elaborately explained everything that should be seen rather, and the importance of looking at the anterior complex and the cavum septum. Thank you all. I just have one question for you, sir. Does cerebellar diameter give clue to microcephaly?
But, no, I can get you. Sorry.
Does the cerebellar diameter,
transcerebellar diameter,
yeah, transcerebellar diameter give clue to microcephaly?
It can tell us that there is a hypoplasia, but then, I mean, most of the times it may be associated with, but then it is not a direct clue for microcephaly. There are other features which have to be satisfied to call them as microcephaly. Because isolated cerebellar hypoplasia can also be seen.
Right. So other question is cardiac. I mean, how to differentiate PSLVC and TAPVC? Well, the PSLVC, the configuration of the left atrium will be normal. In TAPVC, you will have a convex posterior border. The distance between the spine and the aorta and the left
area
atrium
behind the
is
heart
very large. Yeah, and you will not see the normal pulmonary veins draining into the left atrium in TAPVC. So I think that completes the question, and I thank you so much, all of you, for participating in this ICRI. If any ICRI luminaries or members are there, they can probably give a vote of thanks, or I don't see them. So I think this is good enough. Thank you. I hope all the delegates have benefited from today's program. all the speakers have been, they've gone beyond their time and, the context to teach you the most basics of what you should see and what is expected out of you to make you a better fetal radiologist. Thank you all, and signing out now. Thank you, sir. Thank you so much. Thank you, Sarita. Thank you, Sweta. All of you from the VDoc2 team. Thank you.
Thank you, sir. With your permission, may I end the session, sir?
Yeah, please do. Thank you.